declared by the governor as a result of the COVID-19 pandemic, and in accordance with the governor's emergency order 12 pursuant to Executive Order 2020-04. This public body is authorized to meet electronically. This is a committee meeting of the Health and Human Services and Elderly Affairs Committee. Please note that there is no physical location for members of the public to observe and listen contemporaneously to this meeting. However, in accordance with the emergency order, I am confirming that all members of the committee and select legislative staff have the ability to communicate contemporaneously during this meeting through the Zoom electronic meeting platform. And the public has access to listen contemporaneously, and if necessary, participate in this meeting by the Zoom platform or by telephone. All necessary access information has been made available in the House calendar and through the electronic calendar on the General Court website. Notice for this meeting complies with House Rules 90 and with RSA 91A. Anyone who has a problem accessing the meeting should call 271-3600 or email hds@leg.state.nh.us. In the event the public as a whole is unable to access the meeting will be adjourned and rescheduled. Christina Daya, committee researcher, will be the staff assisting us. Please note that all votes that are taken during this meeting should be done by roll call vote. We will start the meeting by taking a roll call attendance. When each member states his or her presence, please also state whether there is anyone in the room with you during this meeting. This is required unto right to know law. And Madam Clerk, would you please call the roll?
Yes, thank you very much. Here we go. Representative Acton.
I'm here and alone in the room.
Representative Cannon.
Here, alone in my home in Somersworth.
Representative Cushman.
I'm here in the committee room.
Representative Folsom here. Representative Gay. Representative Kelsey.
I'm here at my home in Bedford alone.
Representative King.
Here at the LOB.
Representative Knirk.
I'm here in my home in Freedom, and I am alone in the room.
Representative Kofalt.
So he sent me an email that he never got a link to join. If Christina could send him one, I just sent an email to her.
Okay. Representative McKay.
Present.
Representative Marsh.
I'm present in the LOB.
Representative McMahon. Representative McMahon. Representative Merchant.
I am here in my home in Claremont, and I'm alone in the room, but my wife is somewhere in the house.
Representative Nelson.
Here in Brookfield, I am alone, but my wife's somewhere in the house.
Representative Nutter Upham.
I'm here in Nashua, alone in the room.
Representative Soloway. Representative Soloway, you're muted.
Thank you, Madam Clerk. I am here at my home in Lee, New Hampshire, and alone in my office.
Thank you. Representative Shapiro.
Here at my home in Keene, alone in the room.
Representative Query sitting in for Representative Snow.
I am here in Manchester, alone in my house.
Representative Weber.
Here in Walpole, alone in the house.
Representative Woods.
I'm here in my home in my study in Bow, My wife is elsewhere in the house.
Representative Pearson,
Here in the LOB.
and we'll come back to Representative Kofalt.
Yes, I'm here in my home office in Wilton. I'm alone in the room, but there are other people in the house.
Representative Gay is present. We have 20 present and 1 absent as of now.
Madam Ranking Member, would you feel comfortable in sharing why Representative Snow is not with us?
Yes, Representative Snow had a family bereavement. His son-in-law died suddenly last week, so he is tending to his family, and we very much appreciate Representative Query stepping in for him. And I was going to ask Madam Clerk if we have roll calls of any sort. I don't know whether we will today or not, but if so, could Representative Query be called last, just so that other people see he gets a flavor of where things are going? I know that he is very well able of forming his own opinions, but he's new to us, and that way he can have as much information as possible to inform his decision when we get to him.
The chair will certainly grant that request.
Thank you very much. I appreciate it, and welcome, Representative Query.
I'm opening the hearing on Senate Bill 149 FN, adopting omnibus legislation on health and human services. And Senator Dr. Sherman is being Dr. Sherman today, and I believe his aide will introduce this bill. And if the aide will put her hand up so she can be called into the meeting.
I do believe that you said, are we doing Senate Bill 74?
149.
Because I believe it's Senator Rosenwald to begin 149.
If Senator Rosenwald is willing to do that, I am comfortable with that. Senator Sherman told me yesterday his aide would do that, but I'm willing to certainly accept Senator Rosenwald.
Thank you, Mr. Chairman. Happy to be here from the State House. For the record, I'm Senator Cindy Rosenwald from District 13, which is most of Nashua. And I'm stepping in for Senator Sherman to introduce Senate Bill 149. This is a bill with 3 distinct parts. Part 1, for which I am the prime sponsor, clarifies that behavioral health services count towards medical expenses incurred by individuals who are part of the Medicaid Spend Down program. It does not expand the Medicaid benefit in any way, just makes it clear in statute that mental health care is health care for this program. And therefore, since it's just clarifying but not expanding, there is not any expected cost for this bill to the Medicaid program. However, it's necessary due to some ongoing confusion at some of the district offices. And the bill also requires reporting to the HHS Oversight Committee this year and next to ensure accountability for fairly and uniformly applying the benefit as required by law. The language of this bill was introduced in the House last year, and it passed and came over to the Senate. Unfortunately, it got tabled due to the pandemic and didn't move forward at the time, but it is still necessary. Part 2 of this bill is prime sponsored by Senator Sharon Carson from District 14. It makes some technical changes to RSA 318, which is the pharmacy statute, and it just enhances pharmacy services in certain facilities through the use of automated pharmacy systems. Part 3, sponsored by Senator Gray of District 6, provides some liability protections to licensed health facilities that were deemed to have been complying with emergency orders, state and federal, during the current corona virus COVID-19 pandemic. I believe the department is here to answer questions, if there are any, about at least parts 2 and 3. And I thank you for the opportunity to introduce this bill.
Senator, does anyone have any questions specifically for Senator Rosenwald about section 1? I'll give you a few minutes to read it over again.
Just a comment, this is the one,
The chair recognizes Representative McKay.
I think this is the one that Representative Snow has been talking about.
Any other comments or questions for Senator Rosenwald? I think I see Representative Shapiro. You are recognized, sir.
Thank you very much, Mr. Chair, and thank you, Senator Rosenwald. Just to clarify, I do not think this is the same issue that Representative Snow has been talking about. This just clarifies that mental health benefits should be counted towards the spend down. Representative Snow has made it very clear that he's concerned that there's no money in the budget to pay for the change to a higher maximum income.
Thank you for
They're
the
two different
question.
issues, I believe.
Yes, you are correct. This bill was introduced last year by Representative Murphy. It is not the same as House Bill 1639, I think was the number from last year by Representative Snow. You're right, that bill changed the threshold for qualifying to be in the in and out spend down program. This bill just makes it clear that if you're in the program and incur mental health treatment costs, those count towards your spend down.
Any other questions of Senator Rosenwald on part 1? Seeing none, the chair would like to call on Senator Carson for availability to answer questions on part 2.
I don't see her on the list.
Senator Carson is on the speaking list, but she's not on the right here list. Okay. Then the chair will call on Senator Gray for part 3. Senator Gray with us.
Mr. Chair,
Yeah?
if I may, I got an email from Senator Carson, a few of us did. She will not be able to make the hearing. She has a conflict as well at the last minute. She did ask for staff to present her part in part 2 of Senate Bill 149, Senate Bill 149. I don't know if there's staff on the Zoom to speak to it. If they don't, I can actually speak to it as well.
Thank you, Representative. There's a staffer to Senator Carson available to speak to part 2.
Mr. Chair, I do see Grant Bossy is on the line and has his hand raised.
Chair recognizes Mr. Bossy. And I miss your columns, by the way.
Thank you very much, Mr. Chairman. I miss writing them, but I don't miss the deadlines. Good morning, Mr. Chairman, members of the committee. My name is Grant Bossy. I am the Majority Policy Director for the New Hampshire Senate, and I'm here today on behalf of Senator Sharon Carson, who had an unanticipated family emergency, and appreciates the courtesy in letting me introduce Part 2 of Senate Bill 149 on her behalf. This bill clarifies the ability of the Board of Pharmacy to issue rulemaking for remote automated pharmacy machines. There was no opposition to it in the Senate. The senators agreed that this is a needed modernization in how pharmaceuticals are delivered, particularly in long-term care, hospice, and correctional institutions. that these systems are safe and secure and enhance both patient safety and cost. There are subject matter experts here that can testify to the technical parts of this bill. I understand there may be an amendment that comes in. Senator Carson is fine with that if the committee believes that amendment is warranted. And we think that the Board of Pharmacy should be able to regulate these machines through rulemaking. Thank you very much for your time.
Any questions for Mr. Bossi? I believe that's Representative Knirk.
Yes, thank you very much. And perhaps you can answer this question. If not, I'll wait for other ones who can. Does this include Schedule II drugs?
I would have to defer to the experts on that.
Thank you.
And Representative Woods.
Thank you, Mr. Chair, and thank you, Mr. Bossi, for taking my question. Just in terms of the time frame, it says that this will be rules no later than January the 1st, but takes effect in 60 days. Is that going to be a mismatch by chance in terms of getting rules in place within?
The effective date is of the whole bill authorizing the Board of Pharmacy to start this rulemaking process, and then the board would have to have the rules done by January. So the effective date is for the authorization, not the rules themselves, which would then come later.
Okay, thank you. I'll follow up, Mr. Chair.
Yes, follow.
Just for my own edification, a consultant pharmacist is, I'm not quite sure, perhaps yourself or even maybe Representative Merchant might help me out there. Not sure exactly what role they might play in this and what it is.
I would be curious to find the answer to that as well. I'd have to defer.
Representative Merchant.
Thank you, Mr. Chair, and thank you, Representative Woods, for the question. In long-term care, it's required under federal guidelines that each nursing home has a pharmacist who acts as a consultant to the nursing home and also to the medical staff and the medical team in regards to drug therapy.
Does that answer your question?
No, I can.
No, not really. What role does that person play in this part two in terms of the pharmacy?
The role they play in as far as the pharmacy is concerned, it's not so much on the supply chain, which is what this deals with. It's more into the utilization of the drugs within the nursing home itself, which is where their consulting comes into play. And that's one of the things I talked about with Senator Carson and also some other folks. I'd like to introduce eventually an amendment to the bill to strike out sections 2, 3, and 4, because it does become sort of complicated, and I don't think they're needed. Number one, I think the current law actually allows the Board of Pharmacy to create rules, if you will. The Board of Pharmacy disagreed, so therefore Senator Carson, on behalf of the organization that wanted to utilize the technology, has introduced this bill.
Thank you, Representative. Any further questions for Mr. Bossi on section 2? Seeing none, then the chair recognizes again Senator Gray or a staff member to speak to section 3. And whoever wishes to speak to that, please raise your hand. I don't see anybody. All right, with that, we will then circle back and look to those. Yes?
Mr. Chair, we had two hands come up, Grant. Melissa St. Cyr raised her hand, and Grant Bossi also did too, but they're both admitted into the room, so they should be able to speak.
Okay. And before they do, would Representative McMahon please introduce himself? He has just come into the meeting.
Oh, good morning, all. I apologize. I had the wrong Zoom connection, so that's why I got on about 5 minutes late. But just Charlie McMahon, representative out of Windham, and I'm alone in my office in home.
Thank you. Anyone to speak to section 3 who has raised a hand?
Okay, so both Grant Bossy and Melissa St. Cyr raised their hands and been admitted to the room to speak, but I don't, there may be a problem with their audio. I'm not sure.
Mr. Chairman, I can
No,
speak very briefly on this on behalf of Senator Gray. I thought he had intended to be here this morning. He may have had technical issues as well. I can't speak to the details of his section, but just on his behalf, this has to do with healthcare facilities providing care during a declared emergency, such as the one we have right now during COVID. We think this is a timely update to our laws so that we don't need to operate under the emergency declarations, that we have something in place in statute to give facilities the flexibility they need during a declared emergency. And once again, I'd have to defer on any questions, but thank you for your consideration.
Senator Gray likely to be here because we do have a specific question for him regarding Section 3.
Yeah, I'm trying to I'm trying to get him online now.
Okay, thank you.
Mr. Chairman, I have a very broad one that Mr. Bossy may be able to answer.
Please state your question.
Thank you. So am I correct in thinking that the basic thrust of Section 3 is to limit the liability of healthcare facilities that are acting under emergency orders, because sometimes those actions required under an emergency order do not necessarily comport exactly with accepted practices in a non-emergency. Would I be correct about that?
Representative, I'd have to defer. I'm simply not familiar with this section of the bill. I'm trying to get Senator Gray here for you.
Okay. And Mr. Chairman, I think that probably somebody from the Hospital Association could go into it in more depth. There may be others as well.
I'm guessing we should call Paula Minahan into the meeting.
Mr. Chair, this is Melissa St. Cyr. I don't know if you can hear me. I'm on the line and I'm happy to answer Representative Weber's questions as well as provide you my brief testimony.
Go ahead.
Thank you, Mr. Chair, members of the committee. For the record, my name is Melissa St. Cyr. I'm the Chief Legal Officer for the Department of Health and Human Services. And as to Representative Weber's question, this under RSA 21P, facilities that perform emergency management functions during a state of emergency can receive protection from suit and other kind of liability if they are reasonably attempting to adhere to the emergency orders that have been issued by the governor or by the department or anyone who has the authority to issue an emergency order. And so that's what this section is attempting to do. Did that answer your question?
Yes, it does. Thank you very much.
Great.
Now we have Melissa Cyr here. Is there anybody else who has a question along those lines for her?
I do just want to point out one more thing as well, if I may.
Please.
Chair. Thank you. I just wanted to point out the federal piece of this. So Centers for Medicare and Medicaid Services came out with many waivers that kind of changed the regulations, made things more lenient, gave the nursing homes and hospitals and others the ability to perform in a way that would allow them to meet the emergency that was occurring. And there's so many of them. I can't even tell you how many of them there are that CMS came out with. The one thing about putting the CMS waivers into this statute, and I just wanted to point out that because the waiver is issued by the federal government, the compliance of the health facilities with those waivers is up to the federal government. It's not up to the state to make a determination as to whether or not, the state of New Hampshire, to make a determination as to whether or not those facilities were in compliance or were not in compliance with those regulations. So in putting the federal laws, or the federal waivers, I should say, waivers to those regulations in this, it may give people a little bit of a false hope or a false sense of security that they won't be held liable for things that may have occurred that were in line with the waivers, because it's really up to CMS to make that decision one way or the other. So I just want to point that out. Certainly the department's, not concerned, but I just want the committee to know that is something that we identified and just wanted to point out. So I'm happy to answer any questions.
Seeing none, let me ask again, is Senator Gray on the line?
Mr. Chairman, I just heard from Senator Gray. He's currently chairing the Senate Election Law and Municipal Affairs Committee. He is trying to get somebody to take over that gavel so he can switch Zooms and join you. And he is going to get here as soon as he can.
Thank you very much. I have a number of people signed up to testify about this bill, but because it's 3 bills, my guess is that some of you are going to be interested in one part and not another. And so let me ask those of you who have signed up to testify, are interested in part 1, clarifying the Medicaid spend-down requirements, please raise a hand. We're going to call on you. Do not testify about part 2 or 3.
Senator Gray is available.
Okay, Senator Gray is available right now. Hold the previous thought, and Senator Gray, please speak to part 3.
I think they just promoted me to a panelist, so I'm here. Did you guys have questions? From what I'm told, I'm Senator Gray from District 6.
The chair recognizes Representative Marsh with a question on part 3.
Thank you, Senator Gray, for joining us. The committee has received a number of emails saying that an overdose prevention program was removed from this section of the bill in the Senate. Could you clarify the details of that?
There was a provision in there for overdose, and I believe, to the best of my memory, it has been a few weeks now, that we thought that was adequately covered in a different bill that we were supporting, and so that it was removed from this one.
Thank you.
Thank you. Any other questions about part 3 for Senator Gray? Representative Weber.
Thank you, Mr. Chairman, and thank you, Senator Gray, for being here. Could you have somebody send us a reference to where the OPP program may be found in other legislation? That would be very helpful.
I will check on that and try to get it to you, to Representative Weber.
Thank you very much, Senator.
Anyone else?
See no hands.
Seeing no one, thank you, Senator Gray.
All right. If you do have any other questions, please email them to me. I'm chairing a committee meeting on the another Zoom link, and I would appreciate the emails. Thank you.
Now, I want to go back and call those who are interested in testifying on part 1 and part 1 only to please raise your hand. We will be bringing you in.
Melissa St. Cyr is the only one who has her hand.
All right, Melissa St. Cyr, please.
I apologize. I didn't lower my hand from when I spoke earlier. I will do so now.
Anyone else who is interested in testifying on part 1? Then we will move to part 2. The relative to automated pharmacy systems. If you signed up to testify and wish to speak to part 2, please raise a hand and we'll bring you in one at a time.
Henry Villo is the only one with his hand up.
All right, Henri Valeur, and I also read Jody Fenelon as well. So you're called in, one or both.
Hello, good morning, Mr. Chairman. This is Henry Vayu. I'm here on behalf of Partners Pharmacy, and Jody Fenelon from Partners Pharmacy is also here this morning. If possible, if we both could go at the same time, I think it'd be much more efficient for your committee.
Yes, go ahead.
Jody, are you there?
Yes, I do apologize. I'm at an airport, so there's a lot of background noise. So
Okay, all right.
I'll mute when I'm not speaking.
All right. I'll just give a little history of why this section is in here. So Partners Pharmacy approached the Board of Pharmacy last June about the ability to do automated pharmacy systems in long-term care facilities here in New Hampshire, and made a presentation to the board last summer. And the response from the board was that while it had no issues, obviously, with the systems, it felt that the organization needed to come to the legislature to get the statutory authority to move forward with this, which was a little confusing because in RSA 318(5) A15, which speaks to rulemaking authority for the board, it directs the board to develop rules on automated pharmacy systems in long-term care facilities. Additionally, in RSA 318(42), it speaks to automated pharmacy systems there too. But nonetheless, we approached Senator Carson to bring a bill in to give the statutory authority to the board to adopt these rules. And that is what you have before you today. Since this bill has passed the Senate, we've spoken with Representative Merchant. He's very familiar with pharmacy issues. And we also spoke with Bob Stout, who is a past chair of the Board of Pharmacy, and who is actually working with a group, including some individuals on the board, to try to put some draft rules together. And Representative Merchant, I'll let him speak to his amendment, but his amendment would make it much more simpler and basically refer to what we believe is already the statutory authority in the law, and just basically direct the board to develop the rules. So as Grant Bossy mentioned, there was no opposition at all to this in the Senate. It is already being done in hospital facilities, and this would essentially allow it in the long-term care facilities. Jody is on the line too, in case there are any questions about these systems. And I know there was a question about what kinds of drugs from Representative Woods, and I think Jody is prepared to answer that question. So maybe Jody, I'll toss it over to you.
Hey, thank you. Thank you, Henry. Yes, to answer the question first from Representative Knirk, typically we would put controlled substances into the automated machine along with non-controlled substances. We would follow whatever guidance there is or registration that's required by the individual state, as well as obtaining a DEA ADS registration for off-site storage or keeping of controlled substances that belong to the pharmacy. And then we do have very stringent reconciliation processes to maintain the integrity and security of those controlled substances while they are off-site. I guess additionally, I will just comment that this automation has been used since 2002, and I apologize for the noise in the background. And currently, there are approximately 140 plus of the automation that we use in nursing facilities in 13 different states. And we find that it is extremely beneficial. It's been very beneficial. We've had the most installations ever in a year during COVID time because of the benefits of medication availability right on site for new admissions and changes in condition. Additionally, it does benefit infection control because the nurses they get the medications in a little envelope, they administer, and then they, shred, destroy that envelope. There isn't any continual handling of medication cards or vials or other packaging. And the security measures of maintaining the controls in the automated machine with every transaction being tracked. For every person that logs in, gets a medication package, meaning a licensed healthcare person, not just anyone. That is all tracked and has enhanced safety for management of controlled substances in the nursing facilities. So those are the prime benefits of it. Does anyone have any questions for me that I may need to answer or be able to answer for you?
Representative Knurk.
Yes, thank you very much. Yes, thank you for the answer on Schedule 2. The thing I just want to understand a little bit better, and I think I got it from what you're saying, but I want to clarify. So these systems are like basically a machine that will dispense prepackaged the dose. So is it dispensing a unit dose for a given individual at a given time? Or is it just disseminating, or I should say, dispensing the entire set for all of that wing, or how does this actually work?
Certainly, that's a great question. The medications, there's I'm going to call like an automatic run that's set up where all the medications for, like say, residents of a wing for their morning med pass would be packaged, but they're packaged individual resident. It's labeled per resident. The medications with a description are on an envelope, and then the nurse has that to administer to that specific resident. They can also obtain, if there's a new order or an emergency order, individual doses that are on the resident's profile that would be packaged, a one-time dose. And all of that is tracked to say when it was requested and who obtained it, who took it out of the machine when it was packaged.
Follow up?
Follow up.
And can it handle a PRN medication as well?
Absolutely, absolutely. If it's on the patient's profile after it's been entered into the system by the pharmacy and reviewed by the pharmacist, then a PRN dose can be removed with all the parameters that exist on a PRN dose, such as frequency. It can't be, if it's can be given every 4 hours as needed. They can't get it every 2 hours. They can only get it every 4 hours. There's a lockout on the time frame.
Okay, thank you.
Any further questions, Representative Cushman?
Thank you. Thank you, Mr. Chair. Thank you. Can the members hear me who are at home? Question is for the partners people. Can you guys explain, how will this help with new admits if there's no, like, for instance, in a nursing home, sometimes we'll get a new admission and they have medication orders that we don't have on site. Will this system help that? Is there like an emergency kit in this machine that can dispense medications we don't have on site already?
Yeah, certainly, Representative Cushman. How it works, there's up to 176 medications, tablets, or capsules available in the machine, and it is based on the typical prescribing habits of the physicians and nurse practitioners and the practitioners in that area, and that we modify it to be unique. And then there's also emergency type meds, IVs, and so forth. When a new admission comes in, let's say someone's admitted this morning, those orders come over to the pharmacy electronically or faxed over, however the facility transmits them. Once they're entered into our operating system and a pharmacist reviews them, meaning looks for allergies, proper dosing, drug interactions, and so forth, then as soon as the pharmacist literally hits the key and says this order, or each of these individual orders are appropriate and approved, within approximately 2 minutes, just as long as it takes for it to electronically transfer, the nurse could go to that machine and get that first dose out. So when someone comes in, they don't have to wait for the driver to deliver the meds that evening. They could get them, you know, and start their medications. The vast majority of them would be able to be started right from the machine, you know, within a short period of time after they're admitted, and the facility provides orders. Anything that's not in the machine, the pharmacy delivers, you know, on an urgent basis, you know, or with the routine delivery, depending on what the need is. And I will go back to Representative Knirk, the comment about the controlled substances. The pharmacy obtains appropriate prescriptions to meet all the DEA requirements for controlled substances. You know, we have all of that documentation as well. So that need doesn't change. We need to get the proper prescriptions from the prescriber, but we can take those via fax. So,
Thank
does
you.
that answer your question?
Yes, thank you.
All right, you're welcome.
Well, we have the partners here. I just want to make sure that you're okay with the removal of sections 2, 3, and 4 by amendment, because section 5 says the board shall adopt rules. So are you okay? Should we get an amendment removing 2, 3, and 4?
Yes, sir.
This,
Oh, go ahead. Go ahead, Henry.
yes, I'll let you speak to it too also, Jody, but yes, we're fine with that. We basically just want the Board of Pharmacy to feel confident that they have the statutory authority to move forward with this. We approached the board back, like I said, last June. We have the January 1, 2022 date in there to hopefully put this on the front burner for the board to move forward with the rules. So we're fine with removing those other sections. Those will get done in the rules. And the statute does speak to what needs to be included in the rules. So we're fine with removing those sections if that's what the committee wants to do.
Representative Woods.
Thank you, Mr. Chair, and thank you, Ms. Fenelon and Mr. Avulo for taking my question. Most of them have been, I had several questions about the process. You mentioned that if the medication is not in the cart, as it's called on the floors, it can be refreshed from a carrier. What's the turnaround? Say it's 2 in the morning and someone comes down with a dire diagnosis and needs, say, an antibiotic, an IV antibiotic or something like that. What is the reliable time frame? Not the average, but what's a reliable time frame to get that medication?
That time frame, if it's not available in the machine, would be what we would typically commit to for you know, stat urgent medication, which would probably be in the range of, you know, 2-3 hours, which is quite typical by the time you would fill it and, you know, transport it to wherever that would be. You know, so that commitment doesn't change just because the automation is in the building. You know, we still hold by that commitment. We don't say, you know, sorry, we'll send it tomorrow kind of thing. That doesn't, you know, we don't do that. We still hold to it. Rapid turnaround for urgent needs.
Thank you.
Any further questions? Well, thank you so much for bringing your testimony.
Thank you.
Thank you.
Have anything to share or ask on part 2 from the people who signed up to speak? Please raise your hand.
Not seeing any hands.
Not seeing any hands. Then we'll move on to part 3, relative to health facilities providing care in the declared emergency. Anyone wishing to speak to part 3, please raise your hand.
Mr. Chair, we have 3 people, now 4. The first one is John Freiberg, who I have allowed in to talk.
John Freiberg, welcome.
Thank you, Mr. Chairman and members of the committee. Can you hear me okay?
Yes.
Terrific. Good morning. My name is John Freiberg, and I'm the Chief Legal Officer of Solution Health. Solution Health is the not-for-profit parent organization of Elliott Health System in Manchester and Southern New Hampshire Health System in Nashua. I'm very grateful for the chance to briefly speak to you this morning in favor of Part 3 of SB 149. I find it fascinating and somewhat difficult to wrap my head around that the term COVID-19 was entirely unknown to most of us until about 14 months ago. It was announced as the name of the then rapidly spreading novel coronavirus on February 11th of last year. Between that time and right around this time last year in May, our country, our world, and especially the healthcare and emergency management systems within our communities faced unprecedented and in many ways unforeseen challenges. Over the course of just days, many of you will recall, healthcare facilities and their personnel simultaneously grappled with the challenge of, on the one hand, systematically shutting down all normal non-emergent activities, just like virtually all other areas of our society, complying with stay-at-home orders and directives, while at the very same time and in parallel, gearing up as never before to ready ourselves for the projected and potentially overwhelming and unmanageable surges of infected patients. The patient surges did come. Mercifully, however, again, you will recall, in most regions of the United States, New Hampshire included, hospitals and other medical facilities were able to keep pace with spikes of patients in need of emergency services, both COVID-related and otherwise. Healthcare facilities and providers were able to effectively rise to meet this emergency in large part because state and federal authorities issued various orders, rules, and waivers permitting changes in the ways that healthcare was delivered, changes necessary to respond to COVID and which would not have been permitted but for such governmental permission. SB 149, Part 3, is narrowly tailored to ensure that New Hampshire law, just like virtually, if not literally every other state, extends protection from civil liability to licensed healthcare facilities and their personnel for actions in compliance with a COVID-related emergency order, rule, or waiver from state or federal authorities. Briefly, a few examples of the actions to comply with COVID-related orders, rules, and waivers include the following: deferring or delaying non-emergent care to support stay-at-home orders and preserving precious resources such as ventilators and PPE and personnel, utilizing telehealth visits in situations which insurance and government payment programs would not have previously provided reimbursement, expanding inpatient capacity by opening ASCs, alternative care sites, such as at Southern New Hampshire University and in Lebanon and in Nashua, and as well as locations on hospital and healthcare campuses that were not previously licensed for the delivery of care, but were licensed under special emergency authorization from Health and Human Services. Limiting and prohibiting visitors in our facilities, triage screening ER patients in parking lots and diverting non-COVID patients away from ERs to other locations for screening and stabilization, sourcing and utilizing PPE in non-traditional ways, and simplifying some of the documentation and discharge planning requirements that were previously required, especially by CMS on the federal level. Now, an often expressed anxiety on the parts of physicians, nurses, and other healthcare professionals during this time, and still is, whether these very same actions to comply with government directives could later give rise to possible civil liability in the context of a negligence claim. In other words, could following these orders, rules, and/or waivers be pointed to as evidence of an action below the standard of care during so-called normal times? The purpose of SB 149 Part 3 is to avoid such an inequitable situation, such an untenable situation, to protect those who acted as directed under emergency management authority in order to protect each of us during the state of emergency. The New Hampshire Department of Justice, through an opinion of the Attorney General dated April 22nd, 2020, confirmed that that agency interprets RSA 21P as indeed covering healthcare workers following COVID guidance as emergency management activity. While we in healthcare are extremely grateful for this position of the Department of Justice, respectfully, an opinion from the executive branch is simply persuasive, not dispositive on the matter. And while we consider the AG's opinion to be entirely correct and persuasive, it is no substitute for a succinct and clear expression of the legislature's intent. So simply put, 13 lines of legislation clarifying RSA 21P is greatly preferable to a 5-page analysis from the executive branch, as helpful as the latter may be. In closing, I would simply note that there was no opposition in the Senate other than a technical issue raised by the Trial Lawyers Association that we were able to resolve through discussions, and we added on 2 final sentences to the proposed language, and that remedied and assuaged them of any concerns. And this bill passed unanimously through the Senate. So again, thank you for your support of this important effort to ensure that New Hampshire's healthcare facilities and providers are not later penalized in the context of civil litigation for what they were called upon to do in order to protect each of us, our families, and our communities during this unprecedented public health emergency. I've submitted written testimony, and I'm also happy to answer any of your questions. Thank you very much.
Thank you, Councilor. Any questions from the committee? I think that is Representative Shapiro.
I can't get unmuted to testify in the Senate.
Thank you.
Go ahead.
Mr. Chair, and thank you for taking this question. Apart from civil liability, I was wondering if there are any issues with professional liability in terms of licensing and code of ethics for specific providers, in terms of if there are conflicts between what they can do under emergency orders and what their professional code of ethics say. I know this is a different issue, but is this covered at all?
Yeah, that's a fantastic question. And I think it's not clearly covered by this because we tried to narrowly draft this to dock into 21P's immunity from civil liability. I think that will unfortunately be something we have to work through with the agencies, the AG's office, and with the courts later down the road. In a perfect world, which we're certainly not in right now, we would contemplate that sort of professional ethics or licensure standard issue. I think one could make an argument pretty persuasively that that's derivative of this liability immunity, but this does not address that head-on, Representative. I think that's something to be worked through with the courts and with those licensing boards later. But it's a fantastic issue that I will put my thinking cap on about and see if we can perhaps address later.
Thank you.
Thank you.
Anyone else?
Mr. Chair? I have a question.
Representative Folsom.
Thank you, Mr. Chairman. Thank you, Mr. Freiberg, for taking my question. As I was reading this, what came to my mind was the whole situation, of course, in New York State, where infected patients were sent back to the nursing homes, which caused even greater spread of the virus in a vulnerable population. Would there be room in here if someone did not take the time to think through what that would do, and it was ordered for them to do it, but could they still be held liable? You know, I'm just thinking about the whole situation in New York and how this might play out in a situation like that.
Yeah. So that's a great example of where you can't legislate an answer, as this body certainly knows better than I, to every possible permutation of the facts. And that's a great one that will probably have to be dealt with down the road in the courts. We tried to provide language that would allow us to have a conversation around those sorts of topics with the second to last sentence indicating that this only applies when there's an attempt or a reasonable attempt at compliance, and that language is used earlier on. That is intended to convey the fact this is not a blanket immunity, that when you follow, that you necessarily everything relating to it is somehow inoculated from liability, but rather the party asserting immunity would have to make clear in plain and convince a finder of fact that they indeed were complying with the guidance, or reasonably, that's the key word, attempting to comply. Unreasonable attempts or actions beyond the four corners of the actual guidance that may be derivative of that guidance would not likely provide that kind of immunity. So there's going to be a fact-by-fact analysis on each case, and that's why that language was put in there. So that's something to be worked out through the courts later, but we thought this was a good framework to at least clarify some of these parameters of liability limitation and then deal with the actual nuanced situations later through the courts. So that's a great example of where we'll have to figure that out later, but this gives us a great jumping off point to make the arguments much more clearly than the AG's opinion, which again is helpful and persuasive, but not dispositive, gives us.
Thank you.
Thank you.
Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. As a follow-up to Representative Folsom, it occurs to me that there are actually two parts here, and one is the reasonable efforts of the actors we're talking about to follow an order, but the other is the contents of the order. And am I correct in understanding that this bill simply speaks to the facilities that are and practitioners that are trying to carry out the order rather than those who issued the order, whether correctly or incorrectly to begin with?
100% correct, Representative Weber. That's exactly what it's intended to address, not the latter, only the former.
Okay. Thank you.
Thank you.
Anyone else? Thank you very much. Anyone wishing to testify to Section 3, please raise a hand.
David Creer and Laura Byrne and Paula Meniden.
All right, David Creer, please, from BIA of New Hampshire.
Hi, thank you very much for allowing me to speak. And I'm actually really happy I got to go after John Freiberg, who did a much better job than I would have. So my testimony will be very short. The Business and Industry Association of New Hampshire, I should say I'm David Creer, Director of Public Policy at the Business and Industry Association of New Hampshire. BIA supports Part 3 of this bill. We have no position on the rest of it. And the reason being is that healthcare facilities are just trying to do their best with providing care during a pandemic, which is quite a feat. And they shouldn't be subject to lawsuits as a result of trying to comply with emergency orders and trying to do the best that they can during the pandemic. With that, I'm happy to take any questions. But like I said, I think John Freiberg did a much better job at answering those questions.
Seeing no questions, thank you.
Great, thank you.
Chair recognizes Marissa Chase from the New Hampshire Association for Justice.
Good morning, representatives. Can you hear me okay?
Yes.
Yes.
Thank you. For the record, my name is Marissa Chase. I'm the Executive Director for the New Hampshire Association for Justice, a statewide professional association of attorneys. And I want to thank John Freiberg for the time he took in working with our organization and coming up with that carefully crafted language you see in Part 3. Our fear was that this, originally codifying the Attorney General's opinion without, this better language, I think, that John and some of our folks hammered out together, that it could be used over broadly to construe into acts not taken during an emergency. So again, we are happy with this language. Again, want to thank Attorney Freiberg and ask the committee to support the language as is.
Thank you very much. Any questions? Thank you for your testimony.
Thank you.
Chair recognizes Paula Minahan.
Good morning, Chairman, members of the committee. For the record, Paula Minahan, Senior Vice President, State Government Relations with the New Hampshire Hospital Association, representing all our hospitals in the state. We wish to comment on Part 3 only of Senate Bill 149, and we are very supportive of that section regarding health care facilities providing care in a declared emergency. And as Mr. Creer said, I will do the same. Attorney Freiberg did an excellent job outlining what that section does. And I did, so I will not repeat that. I just wanted to express our strong support for this section of the bill. I did provide a link to the Attorney General's opinion just for your edification. And as Ms. Chase said, they did amend the bill, working together with Attorney Freiberg, which we completely support. But I just thought it would be helpful for the record to have the Attorney General's original opinion back from April of 2020. And again, we support the bill, and thank you so much for allowing us to provide our comments.
Questions from Ms. Minahan? Seeing none, thank you for your testimony. Is there anyone else who wishes to speak to any part of this bill?
Laura Byrne.
Laura Byrne, yes, thank you.
Hello, can you hear me?
Yes.
Oh, great. Hi, thank you for taking my comments. I'm Laura Byrne. I'm the Executive Director of the HIV/HCV Resource Center in Lebanon, New Hampshire. We're an AIDS service organization, and we run syringe service programming in Grafton and Sullivan County and in Vermont. And it was my understanding that this bill could possibly pave the way for overdose prevention centers, although that part got taken out. So I was going to request adding it back in. Overdose prevention programs are an evidence-based harm reduction strategy that allows an individual to consume drugs under the supervision of staff trained to intervene if that person overdoses. And every year we see our clients overdosing and die. So it would be just one other great strategy to reduce the likelihood of fatal overdose. They also enhance connections to critical social services by offering referrals to substance use disorder treatment, housing, medical and mental health care, other social services. There are about 165 overdose prevention programs operating in 10 countries in the world. Research has also demonstrated that these programs decrease the use of emergency medical services and reduce public drug use and syringe debris. So I just wanted to request if there was a possibility of forming a study commission to study the impact of opening overdose prevention center in New Hampshire. Thank you.
If anyone wishes to work with Laura Byrne on an amendment that is ruled germane to the bill for us to look at when we exec the bill next week, please contact Ms. Byrne.
Thank you.
Thank you. Representative McKay.
I may have missed this, but under the fiscal note, it says that they have been unable to come up with a fiscal note, and that when available, it would be sent to the Senate. I wonder if there is a fiscal note, and if so, we should know that.
I'm reading it that this is the Senate's fiscal note, but I don't know.
Is that, are we looking at the same thing?
Yeah, we will be executing this bill next week, and that's something that the fiscal note writers could be asked.
So there, Mr. Chair.
Yes.
If you look on the general court website, the current.
We're talking, recognizing Representative Cushman, who is doing some research.
I was just looking at the bill on the general court website, and it does have a fiscal note, and it there are zeros across every section of the fiscal note.
Is this fiscal note the same as this fiscal note?
I didn't get that one.
I didn't get that one either.
Yeah, I've never sent it. So, but probably.
Representative McKay, do you have that fiscal note? Okay, gosh, I mean, why should I be the chosen one? But I have a fiscal note, and Representative King does as well. So,
I said I may have missed it.
I wonder if it's.
I have it. It was sent to our email. It was emailed to us.
That's probably what I did.
okay, yeah, right. Yes, Representative Folsom.
Chairman Pearson, with regards to Laura Barron's request, Senator Gray, he's not here, so I can't ask him, mentioned that they took that out, that section out, because there was a bill, another bill that covered that. Does anyone know what that bill number is by any chance?
Senator Gray said that he would be getting back to us with what that bill is. And once again, we have until next week to nail that down, because if another bill covers this, the point becomes moot. And if not, if we discover that in the next few days, that either this doesn't exist or it isn't to the degree we'd like, then any one or more of us can work with Ms. Byrne to come up with an amendment that we will look at during the exec session next week.
Point of procedure, Mr. Chairman.
State your point.
Thank you. Couple of things, one of which is I wonder if Ms. Dyer could be asked to resend the fiscal note when she has a minute. And secondly, I wonder if you could perhaps call Senator Waters, who is waiting to testify on this particular issue and who has actually sent us the bill as originally drafted, so he might be able to clarify an awful lot of those issues.
Thank you very much. Senator Waters, is Senator Waters in the room?
Also, if I can just point out, Christina has just sent that SB 149 fiscal note, and I've just checked it. It is what's currently on the PDF of the website.
Okay, is Senator Waters in the room?
Yes, Mr. Chairman.
Thank you, sir.
Thank you, Mr. Chairman, members of the committee. Senator David Waters from District 4, and I was the original sponsor of the bill that became part of this omnibus on harm reduction overdose prevention program. And I thank the committee for giving me a moment and the advocates who wanted to bring this before you for a moment to talk. You had some description of it a little bit earlier, and if you look at the language of the bill, you'll see what was before the Senate. And I just want to note that Senator Gray and all the members of the Senate Health and Human Services voted in favor of this. And it passed the Senate on the floor from the Policy Committee 23-1. It was sent to Finance, and there was some objection raised to it in the Finance, and that turned the vote when it came back to the floor. Senator Gray, I won't speak for him, but there were several parts removed from this bill, and it's possible that there were some other part that had other things in legislation. But I will say that we do not have harm reduction programs and overdose prevention programs like this anywhere else or any other bill that I'm aware of. And what the point of this bill is harm reduction. And, you know, I really applaud Governor Sununu for setting up the Doorways program. I serve on the Governor's Commission on Alcohol and Other Drugs, and certainly New Hampshire has made great strides and many efforts and spent, you know, money and also received money through the federal delegation to help deal with the opioid crisis. And we have made a lot of progress. But people in the recovery community feel that the one missing piece all along has been harm reduction. That if we create these sites where people can consume drugs under supervision, where they can receive medical advice and care if necessary, that this is a great next step in fighting the opioid crisis, and frankly would save lives in New Hampshire right now. The important thing to note about this proposal is that it is entirely enabling legislation. It enables a municipality to make a decision through a vote of the public body after public hearings to institute such a program. It may in fact look very familiar to you because it is patterned almost exactly upon the legislation you remember Representative Hannan and Senator Gray and I and others worked on for the needle exchange program. So it's set up in just that way, that there would be criteria established through rules by Health and Human Services as to what kind of organization would be able to host such a site. And there's very particular listing here of the kinds of facility and also the kinds of staff and particularly the kinds of services that would need to be offered there. Again, quite similar to what we see in the needle exchange program. What is also crucial here is that this program could be adopted by the public body of a municipality only after it had taken certain steps, particularly with local law enforcement, with Health and Human Services and others, to ensure that public concerns are met and the public good is served by it. It also asked that Health and Human Services would conduct a review and study of such a program, so we would have some real data as to how it works for us. As was mentioned, there are 165 programs in 10 different countries. For a little context, the United States, Philadelphia was on track to establish one, and there have been 2 different court rulings down there, and the governor asked them to delay due to COVID in implementing it. So that's a little uncertain, though I will say that the new administration has mentioned harm reduction programs and overdose prevention programs for the first time, and there's some sense that they will be looked upon favorably by the federal government. So it'll save lives. I think it's a program that, as described here, would work. That's why Health and Human Services in the Senate voted for it unanimously, and we had a 23-to-1 vote on the policy. But some objections were raised about providing such a service. Some objections were raised about whether they could be safely operated. And some objections were raised about really philosophically saying that this is people who is addicted, it's their own fault, and the state has provided a lot of services, but shouldn't do this. So I don't mean to represent what some of my colleagues said, but I think it's important for you to hear why what was a unanimous vote, nearly as unanimous, was overturned at another point in time. I think it's worth considering for your committee. If it decides that it doesn't want to add this back into the bill and wants to consider a study, I'd be happy to work with the advocates on that. But again, Mr. Chairman, I really want to thank you so much for allowing the opportunity for this to get to discuss before you, which is a large bill and a busy day. So I'd be happy to take any questions.
The chair has a question. This is Representative Mark Pearson. It has been said that the substance of your Part 3 is covered in another bill. What is that other bill?
Thank you, thanks for the question. I won't speak for Senator Gray, but I'm not aware that there is any such bill. And as I said, there were several parts of this that were removed, and perhaps that's what he's remembering. But I don't want to speak for him. But that was not something that was brought up either in the hearing or on either of the debates on the Senate floor.
My follow-up question is, the bill that we have before us presently, subject to an amendment on Part 2, is probably going to sail out of here, that's my guess. But if your Part 3 were added, it sounds like there may be a sticking spot in the Senate. And if it were added, it might jeopardize the entire new bill. Might a better way be adding a line item that makes a study committee on harm reduction facilities, in your opinion?
Well, thank you for that follow-up. And I respect the wisdom of the House, and I think this is an important way to save lives. And if it seems that a study based on what is outlined in here would be a way to move forward, I think that is an excellent idea. And thank you.
My fear would be that if we passed it with your section 3 added, and it goes to a committee of conference, the Senate might reiterate its objection to your part 3, and the whole thing dies. So that is the reason behind my maybe a study committee to bring forth a harm reduction program bill as a standalone bill might not only serve what you're trying to do, but keep the present bill we have before us alive.
Thank you for that. I'd be happy to work with any member of the committee to craft such an amendment with the advocates. And thank you again.
And thank you, Senator. And if there are folks in this committee who would like to work with Senator Waters for an amendment to add a study committee, please be in touch with him.
There are still questions.
Senator Weber's hand up.
Thank you. I have a comment on the process of committees of conference. There's no reason why, if one gets into a committee of conference and that particular aspect of the bill becomes a sticking point, it is absolutely possible that the whole thing dies. But the other possibility, of course, is that it's just removed again. So it's not an all or nothing proposition, but I concede that there are issues of that need to be tactics that need to be considered. But my question for Senator Waters is that when the section was removed in the Finance Committee, I understand some of the policy objections, but were there actual finance objections in the Finance Committee, or were the objections there on a policy basis?
Thank you for your question. I'm not aware of any objections on a financial basis. Health and Human Services didn't bring forward any concerns about cost. And it was felt that there'd certainly be a lot of grant support for this if a municipality decided to move forward. It really was some objections, which, it had passed 23-1 before, but some objections arose after that. And that happens sometimes, doesn't it? But there were not finance objections that I'm aware of any ever being made.
Thank you very much.
Representative Woods.
No, my hand's not up. Sorry.
It might be floaters after my eye surgery. Okay. Is there any other hand up?
Just former Representative Hannan wants to testify.
Former representative and alumnus of this committee, Hannan, you are recognized to speak.
Thank you, Mr. Chairman and members of the committee. My name is Joe Hannan. Like you heard others say, that I was very involved with the syringe service bill with Senator Waters and Senator Gray, and many of you also on this committee. The fact that it was removed, I understand some of the objections, but I do think that at the very least, it needs to be studied at a little bit more of a level than just a committee level. I think it should be studied as a commission. I have submitted actual language that'll save everyone some time. Everyone wants to work on a bill. I already have the language completely drafted. If you'd like to amend it in some way, that's fine. I'd be happy to discuss it, but I submitted that to Representative Soloway, and I believe he shared it with other members of the committee. I'm not sure if everyone has it yet. So I've been actively involved with syringe service programs in the state, and that was a big step in harm reduction in New Hampshire. In 2020, according to the Office of National Drug Control Policy, overdose deaths rose by 16.6% based on comparison between January and April of the previous year nationwide. In New Hampshire, that wasn't the case. Manchester saw a 28% decrease in opioid-related overdose deaths in 2020 compared to 2019. There was a syringe service program that was instituted not long before that in Manchester, and also we had one previously in the Seacoast. We had done a survey of our residents, and over 3,000 overdoses had been reversed by members of our exchange program in the Queen City. 3,000 overdoses since the inception in that city. That's more than were reversed in the hospitals and by the paramedics in that area, not to diminish their efforts, but the efforts were most substantial in the front lines with the people who were actually involved in the process. So I'd like to also say that if we do a study commission, we can study the standards for best practices, look at the data that's been out there. Like the previous speaker, Laura Byrne, said, this has been involved in at least 10 other countries. There are over 165 programs around the world. We could also discuss and study the feasibility of implementing these programs in New Hampshire. Where can they be best utilized, if at all? So even if you're not in favor of such a program for whatever reason, that commission would have the ability to discuss whether it's actually feasible and where it can be best done in New Hampshire. I'd be happy to take any questions, but this is something that is absolutely life-saving. If we can reduce overdose deaths and overdoses in general by having these kind of facilities in the future, possibly, we could decrease HIV, hepatitis C transmission, overdose deaths. We can increase referrals to treatment and recovery services and other services for social services for people that are high risk or homeless, uninsured, or low income. And also, and this is a very timely issue, overdoses and infections and other problems associated with improper substance use could be actually do contribute to hospital usage, and increased uses in the hospital can actually take away the time of healthcare providers to treat other illnesses like COVID infections and other life-threatening illnesses. So this does free up the healthcare system we have. It also will save an incredible amount of money, and not just money in tangible assets, but in the fact that it will also save lives and help get people into treatment and recovery. So the language is there. If I'd be happy to work with anyone in the future, and I'd be happy to take any questions whatsoever. Thank you.
Representative Folsom.
Thank you, Chairman Pearson. Thank you, Mr. Hannan, for taking my question. I have recently been appointed to the Drug Overdose Fatality Review Commission. So I would really like to get the language sent to me for your amendment. I have not familiarized myself too much yet with this new commission I've been assigned to, but would that be an appropriate commission that already exists that could review this?
Absolutely. I don't believe it was on. It's actually on the list. I have 12 members, but on it, obviously, this is just a basic framework. A lot of it was taken from the syringe, the Commission to Study Hypodermic Needles and Syringes, which I was the chair of that commission. We did change it a little bit to add a few members, but I'd be happy to add that commission to this list.
Okay, yeah, if you would
Follow up.
send me that. I'm sorry.
Yes.
Yes.
I'll send it to all members of the committee.
Further questions for you, Representative Soloway?
Thank you, Mr. Chairman. Thank you, Representative Hannan, for taking my question. So a two-part question, please. Senator Gray alluded to prior legislation that obviated the need for this section of the bill. Do you have any familiarity with that legislation?
I haven't talked to Senator Gray recently, but I will ask him. I haven't seen any specific legislation, and I went through the last Senate calendar to see if there were amendments, but maybe there's something else that I missed.
Okay. Thank you. A follow-up, please, Mr. Chairman. Would it be appropriate for us to bring in two amendments? This is the recommendation of one of my colleagues, Representative Weber. One that would bring back the original language, and a second amendment to establish a commission so that we can go either way. We then have a choice in executive session.
Options are good.
Okay. Thank you very much, and thanks to Representative Weber.
Thank you.
I saw a hand. I thought I did. I guess I didn't. Representative McKay.
Like Representative Folsom, I also was recently appointed to the Opioid trust fund. And it's I think it has like 23 members. It's a huge organization. But again, it deals with financing. And it's brand new. Senator Rosenwald is the first chair. I'm the vice chair. So again, I think it's pertinent to this question.
Thank you, Representative McKay. Last call. Seeing no hands from anyone, this closes the hearing on Senate Bill 149. For the record, by the deadline, 35 people signed in support, 2 in opposition, 1 neutral. And in terms of when we next meet, I have been shooting for next Tuesday, and I'm told that is not available. A room with equipment is not. So they suggested Monday. I reminded them the deadline for notification is passed on that. And now we're trying to figure out between Wednesday and Thursday, and when I know, you'll know. But we've got some possibilities of amendments to come forth on this. Please get them done earlier rather than later and circulate them to all of us so we can read them ahead. Now I open the hearing on Senate Bill 74 relative to advanced directives for healthcare decisions. And again, listed as prime sponsor, Senator Sherman, but as Dr. Sherman, he is busy today. Who's going to introduce Senate Bill 74 to us?
Remote Senate State House 100 has its hand raised.
Remote 100.
Hi, Representative Pearson, Chairman Pearson, members of the committee. For the record, my name is Jenny Horgan. I am the legislative aide to Senator Tom Sherman. And if it's all right with you, I'd like to introduce Senate Bill 74 on behalf of Senator Sherman.
It is certainly all right with me. Go ahead.
Wonderful. Thank you, Chairman and members of the committee. I'm very grateful and happy to be in front of you all to see so many familiar faces today. Senate Bill 74 is relative to advanced directives for healthcare decisions. And I have a letter that we did submit to the committee that Senator Sherman requested that I read into the record, if that is okay.
It is okay.
All right. So to the honorable members of the House Committee on Health and Human Services and Elderly Affairs, for the record, my name is Senator Tom Sherman, representing Senate District 24, which includes 11 towns on the New Hampshire seacoast. I apologize for not being able to be there in person, but I am scheduled to be working at the hospital in Endocopsey today. I've asked my legislative aide, Jenny Horgan, to read this introduction of my bill, Senate Bill 74, relative to advanced directives for healthcare decisions. This bill was brought to me by a coalition of people who work in healthcare, the legal profession, and patient advocacy. The goal of the bill is to update the New Hampshire statute relative to advanced directives, surrogacy, living wills, post, and other processes that ensure New Hampshire residents' healthcare directives are documented in the event they are no longer able to make their own healthcare decisions. There are several people here today with a great deal of expertise on these issues who will be testifying before your committee. They should be able to answer any questions you may have. While the bill does make several adjustments in terminology and some processes, the only significant policy change is in access to potentially life-saving research studies. This represents one of the lessons learned through the COVID pandemic. Representatives of Dartmouth-Hitchcock are prepared to answer any questions you may have on this component of the bill. I would like to take this opportunity to express my profound gratitude to the many stakeholders who spent more than 20 hours meeting and wordsmithing this bill to address every concern raised. This included representatives of the hospitals, hospices, palliative care providers, elder law attorneys, the Catholic Diocese, and many other provider and advocacy groups. Having worked with patients for more than 35 years as a doctor and having helped so many of them and their families work through these difficult and often painful decisions, I know firsthand how important this process is to ensuring that we respect patients' wishes. I believe this bill is essential to making that process as clear as possible for patients, their families, and providers. Finally, I would like to thank the committee for hearing and considering the bill. I am available if you have any questions that remain unanswered after today's testimony. Respectfully submitted, Senator Tom Sherman. And that would conclude my testimony, Mr. Chairperson, and I would respectfully ask that you wait for any questions to be given to the experts, as they are much more well prepared to answer them than me.
You read so well, though. Thank you. The chair recognizes Paula Minahan, again from the New Hampshire Hospital Association, to speak in support of this bill.
Good morning, Mr. Chairman, members of the committee. For the record, Paula Minahan, Senior Vice President, State Government Relations with the New Hampshire Hospital Association, representing all our hospitals. We are in strong support of Senate Bill 74, and we do want to thank Senator Sherman for agreeing to sponsor this important piece of legislation. We also would like to extend our thanks to two co-sponsors on your committee, including Representatives Marsh and Woods. I will provide you with a bit of background on the work of the New Hampshire Healthcare Decisions Coalition and why they believe RSA 137J needed to be amended. This bill before you today is a result of many months of thoughtful work by the members of the coalition, some of whom are with you today and will be testifying. They are experts in the various professions of palliative care medicine, healthcare law, and caring for patients. I also have with me today my colleague, Peter Ames, who's the Executive Director of the Foundation for Healthy Communities, which is an affiliate of the Hospital Association, whose staff is responsible for overseeing the Healthcare Decisions Coalition. I will ask Peter to speak, if you would oblige, in a minute to explain the focus of the coalition. But before that, I would like the committee to understand that the coalition worked over the summer to draft some modifications to the statute as Senator Sherman outlined, some of the goals were to make the language of the various forms, living will, durable power of attorney for healthcare, clearer and use customer-friendly language, remove time constraints on surrogacy and add surrogate in addition to an agent throughout the statute, substitute practitioner in place of using listing various healthcare providers to make it easier, included POST and other sets of physician orders as allowable forms of portable, durable power, do not resuscitate orders. Clarified that the living will is a guidance document that clarifies individuals' wishes, and that the overriding document is the durable power of attorney for healthcare. Established 18 years old as the minimum age for surrogacy and being an agent, and uses terminology to reflect what is currently used in medical settings. Also, Senator Sherman asked that the statute use gender neutral terminology, which we did throughout the document. It is a very large bill, and I understand that, and that's why we have a lot of individuals on that can address the legal and the clinical components, so I will defer to them. But I just wanted to mention that after the bill was heard in the Senate, Senator Sherman did bring together a number of interested stakeholders, again, that will be testifying. We did have extensive discussions. Some of them went over 2 hours at length. And so with everyone's input encouraged and considered, that is the final product of the work of the stakeholder group is what you are seeing in front of you today. The amended bill did pass out of the Senate HHS committee 5-0, and then subsequently passed on a unanimous vote of 24-0 in the Senate on April 1st. And we are very proud of that, because that shows to me the significant input from all the stakeholders that were interested in this topic. I do want to make clear that we did not attempt to change longstanding policy relative to this statute. And as Senator Sherman had indicated when he agreed to sponsor the bill, he does not want to weaken the statute. He wanted to make it easier for patients and their loved ones to understand the forms and to complete them, to properly express their wishes, and for the providers that care for these patients to follow those wishes. We are in very strong support of Senate Bill 74, and we ask that you support the bill. Thank you for the opportunity to comment. And if you would oblige, I would like to ask my colleague, Peter Ames, to speak with the committee for a few minutes.
Chair recognizes Peter Ames, and thank you, Ms. Minahan.
Great. Good morning, Mr. Chairman, members of the committee. My name is Peter Ames. I'm the Executive Director at the Foundation for Healthy Communities, and I want to thank you for this opportunity to speak with you this morning. The Foundation for Healthy Communities is an affiliate of the New Hampshire Hospital Association, as you just heard. We are a quality improvement organization dedicated to advancing health for all people in New Hampshire through engaged partnerships. One of these partnerships is our Healthcare Decisions Coalition, which is dedicated to helping patients make clear, thoughtful decisions about their care in a way that best reflects their values. We support providers and families in helping patients understand their options and choices. The Healthcare Decisions Coalition has been in existence since the early 2000s, and its primary focus is on educating medical providers and the public about advanced care planning and the relevant forms. This coalition is comprised of professionals that represent healthcare, emergency management, legal, ethical, and patient advocate constituencies. The coalition is a forum to discuss relevant issues related to advanced care planning and addresses many timely topics that come up on this issue. One of our key deliverables is we hold trainings twice a year for professionals in the state on the advanced care planning forms and how help their patients with these conversations. We publish these commonly used advanced care planning guide and the forms, and so we received many inquiries regarding the form and the state law. This gives us a good sense of the questions that are out there, both with healthcare professionals as well as the public. And from this, and what you'll hear from the coalition members, is that we have seen where some of the shortcomings may be and confusion is caused. The coalition members have raised the suggestions outlined in the bill as a result of what we have heard from the public and from healthcare professionals and those that deal with the form and the statute. We believe that these changes before you today will help ensure that the wishes of the patients, whatever they may be, will be clearly understood and executed when the time comes. With that, I again want to thank you for this opportunity to speak to you, and I'd be happy to answer any questions you may have.
This is the chairman, Representative Mark Pearson. Do you have the bill in front of you?
The bill in front of me. I can pull it right up.
Thank you.
Now I have it up, yes.
Good. Page 23, lines 30 and following.
Lines 30, yep. Related to a surrogate, yes? Is that the correct line?
In accordance with, an agent or surrogate may revoke the DNR or a post for a principal who lacks capacity to make healthcare decisions. But presumably that person was capable of making those decisions when those decisions were first made. It says to me that when a person no longer has the capacity, people can change the desires of the principal, of the individual. That's what it seems to say to me. And in this paragraph, it's at a healthcare facility. In the next paragraph, it is outside a healthcare facility. Same language, except the venue has changed. This to me seems to say that when a person no longer has capacity, people can go against that person's express written desires. Is that correct? Am I reading it correctly?
I'm going to have to defer that question to some of the legal experts who I know will be testifying later. What I will say is what we want to do is ensure that the person that a patient designates as their surrogate has clearly understood lanes that they can operate in. And so that's what we are wishing to clarify. But as far as the precision of your question, I would ask to defer that to some other legal folks who will be testifying later. My apologies.
Any questions of Mr. Ames? I see a hand waving. It looks like Representative Knerk's hand.
Thank you. And if Mr. Ames is the appropriate person, that's one thing that I wanted to check on page 4, line 34. where we have the definitions. In that, we have the definition of POLST, which states that it means a form that contains a set of emergency orders. But would it also be appropriate for us to define what the acronym stands for? Because I could never find the acronym actually spelled out in the bill. And I think that acronym meanings do change over time. And POLST is a little newer than DNR. Would there be any objection to just simply identifying that it's, physician ordered life-sustaining treatment, to just have that in parentheses so it clarifies what the acronym stands for? Would that be okay?
Yeah, I think as far as changing the bill, I'll leave that to other folks to make the decision if that would be appropriate. POLST, as you mentioned, is a acronym, and it's a commonly used one in the field, but I understand your point about making sure it's clearly understood because it does represent.
Thank you.
Chairman, may I, this is Paula, may I speak? Can you hear me?
Yes, you may.
So there are others that could address this. I believe Dr. Phil Lawson is on the phone, and I think he can address this. POLST is now considered not really an acronym. Representative Knurk is right. It used to be, but nationally they're moving to just having POLST be actually the name, if you will, moving from an acronym to the what it just referring to POLST as a name in and of itself. So we actually had some experts that deal with POLST a lot. And again, if Dr. Lawson is on the phone, I think he can address this more effectively. But that was intentional as to why we created the definition the way we did. We actually had quite a bit of discussion about that actually. But I'll let Dr. Lawson talk about that.
Chair is going in a different direction. Representative Folsom.
Thank you, Chairman. Thank you, Ms. Minahan. Can you please tell us what the original an acronym for POLST was?
It is physician order life-sustaining treatment, I believe. And maybe practitioner order. I'm not 100% sure, but life-sustaining treatment. Again, Dr. Lawson is a palliative care doctor and utilizes POLST forms. He can explain how they are utilized, but that's I believe what the original acronym. There is a statute for POLST in our state law. It is really more kind of enabling legislation. It's not, but it's something actually that came up during one of our discussions that statute may need to be modified to be more clear and kind of bring it up to the national standard, which New Hampshire is trying to follow. A number of states follow the POLST national standards because Representative Knurk is right. This is a new, relatively new addition to physician ordering emergency medical orders. So it did come up, but not in the context of changing this particular statute.
Representative, thank you, Ms. Minahan and Mr. Ames. And are there any other questions for Peter Ames, Executive Director of the Foundation of Healthy Communities? I don't see who's behind the waving hand.
Representative Marsh.
Representative Marsh. Oh, okay.
Thank you. Thank you. Paula, you may be able to answer this question better than Peter did, but the chair asked about the sections of the bill on page 23 and 24, whether they would allow someone to revoke someone's DNR order at a later date when they became incompetent. Am I correct that under current law that is allowed, but the way this bill changes existing law is it adds the phrase in accordance with RSA 137J6, which if I turn to page 8 in the bill, is a requirement to act in accordance with the principal's wishes and best interests. So in fact, what this bill does is limit the ability for someone to change someone's orders when they lose competency later in life.
Yes, I agree with you, Representative Marsh. I was doing the same to make sure the cross-reference. But again, there are some lawyers on the phone that I think could also address that question. If Attorney Hannah is on the phone or Attorney Hillman, I think both of them could properly address that as well and clarify any other legal questions. So thank you for that question.
Thank you. Then the chair will recognize Attorney Hillman to speak to this point. And if you have prepared remarks for something else, please hold on to them just to address that question.
Chairman, but Representative Merchant still had his hand up for these people testify.
I understand. Thank you. Please call up Attorney Hillman.
Yes, this is Attorney Benjamin Siracusa Hillman. Would you like me to just address the question?
Yes.
Regarding page 23 to 24? Okay. Good morning. My name is Benjamin Siracusa Hillman. I'm an attorney at Shaheen and Gordon, and I was one of the members of the stakeholder groups that worked on the bill, and I'll look forward to testifying at greater length later on in the meeting. But regarding the question that was asked, I agree with the clarification that the representative stated regarding the change to existing law is to actually add the phrase in accordance with RSA 137J6. I would also add, though, I think more significantly, and Dr. Lawson can perhaps address this as well, a do not resuscitate order or a POLST order. Those are medical orders done by a physician or other practitioner. So as distinct from a durable power of attorney for healthcare, living will, or other directive document signed by an individual patient, the orders being referenced here are medical orders. So the statute does not, the proposed bill does not give an agent or surrogate the ability to revoke an advance directive, the ability to revoke a durable power of attorney for healthcare or living will signed by the patient. What it does do is it allows the agent to consent or the surrogate to consent to a physician revoking a physician order. And again, that has to be done in a way consistent with the principles, best interests, and expressed wishes.
That really doesn't quite explain it enough for me. If a person, friend of mine, signs a statement, do not resuscitate me, is that the end of the story? Or may others countermand that?
If an individual signs an advance directive and in that directive provides instructions that they do not wish resuscitation, that directive itself cannot be set aside by the agent. That directive the agent would have no power to revoke that directive. But what we're speaking of here is a medical do not resuscitate order, which an individual cannot do for themselves. It has to be done by a practitioner. And so if an individual's practitioner does a do not resuscitate order consistent with the wishes of the individual, and the individual is incapacitated, the agent or surrogate, if based on a determination that that was consistent with the patient's wishes and best interests, would have the ability to consent to the practitioner revoking that order. So they cannot revoke a written statement of the individual, but they can consent to a medical practitioner revoking the medical practitioner's order, do not resuscitate or POLST order.
Let me nail it down. If an individual says, do not resuscitate me, may a doctor change that?
I'm sorry, I couldn't understand the last thing you said. The connection wasn't great.
If an individual signs, of sound mind signs a DNR, let's leave agent out of it for a minute. May a physician revoke that?
An individual cannot sign their own DNR. It has to be done by a physician. So there is no such thing as an individual doing their own DNR. An individual can sign an advance directive. So an individual can express their wish in the directive that they do not wish to be resuscitated under various circumstances. But then for that to have practical effect, it is typically embodied in a medical order by their practitioner. The practitioner has the ability to alter or amend their medical order, but not the individual's own underlying statement that gave rise to that order.
Representative Cushman.
Thank you, Mr. Chairman. Can you explain in what circumstance a doctor would be revoking such an order?
I would like to defer to Dr. Lawson as a medical provider who would be able to give a better answer to that question.
Okay, while we're trying to nail down this answer, the chair will then recognize Dr. Lawson to speak to this.
With respect, Mr. Chairman, several of us had questions of the person who was testifying that might clarify this if he were allowed to finish with all of our questions. It's very unusual to jump from person to person to person to person in the course of testimony. I've never seen it done before, ever. So I just want to register that, but I did have a question that I thought might help clarify if I could have asked it of the original person, but you're the chair.
Well, it's unusual for me to do the handoff where one testifier calls on another testifier who calls on another testifier, but I find myself doing this because I believe myself, and I'm looking at a few other people, do not have an answer to our question that explains it adequately to us.
But normally we finish with the first person and then the next person who comes takes up the work, as it were, and answers the questions that were not appropriate for the earlier person, rather than calling people in and then putting them back out again. And it's generally the practice that we hold the questions for the person who's the appropriate person, but we don't just call that person up to testify on one question and then send them back and go back to the person before.
I do thank you for that, and I'm going in a different direction. I'm calling on Dr. Lawson to try to nail down an answer to this question. Under what circumstances may a person's expressed desire, do not resuscitate me, can that be overruled by someone else? So I've been told that Dr. Lawson can answer this.
Sorry, I hope you can hear me now.
Yes, we can.
Great. So I'm Dr. Philip Lawson. I'm a palliative care consultant at Littleton Regional Healthcare. I'm also an emergency department physician and practiced as a primary care clinician at Amanusa Community Health for about 20 years. I do have extensive experience in this, and I'm one of the trainers that Peter referred to in his introduction. In answer to this question, the short answer is yes, but the long answer is in very rare circumstance. I think Representative Cushman asked for a specific circumstance. One might be a situation where a person had an advanced cancer, had a temporary loss of capacity, had signed a do not attempt resuscitation order, understanding their prognosis was poor, and a new therapy arose that was exceptionally effective and could significantly change their prognosis. And the durable power of attorney in that circumstance may interpret the individual's wishes to be one where they would want to change that order. There are innumerable and unpredictable potential circumstances from a medical perspective that could lead to a change in prognosis. And it is impossible to fully predict all the potential circumstances that may occur in the future in regards to what is going to occur to an individual regarding their medical treatment. And for this reason, although there are concerns, as you imply, with the ability of a durable power to override a previous request, in sum, the medical field certainly believes, and it is our experience, that the benefits significantly outweigh the risks and harms when it comes to the issue of a durable power of attorney's authority to override a previous statement. That has always been the case in existing law, and it is always the standard of practice. In SB 74, our goal was to strengthen that by the reference to the necessity for an individual, including the agent as well as the medical team, to honor the wishes of the patient, to refer back to that section as Representative Marsh discussed. So it is an issue, Representative, but in the opinion of the medical community and certainly the Healthcare Decisions Coalition, the benefits of continuing to allow that authority outweigh the potential harms. I hope that answers your question.
It does, Doctor. Now that the chairman's happy, everybody can be happy again. We go back to, where were we with people's hands up? Was it with Peter Ames or Laura Minahan? Those of you who once had your hands up want to put them back up, and who were you wanting to speak to? Representative Weber.
Well, I'm now wanting to speak to the good doctor, if I may.
Oh, yeah.
As a follow-up to your line of questioning. And I have two, if I might. The first is just a straight question. Is it possible that one of the important functions of this language is so that if the surrogate who knows, or the agent or the surrogate who knows the patient well, believes that a practitioner acting in all good faith simply got the patient's wishes wrong, the agent or surrogate may require the practitioner who in all good faith got it wrong to do what the agent or surrogate really thinks that the individual wanted? Is that one of the purposes of this?
Yes, I mean, and that always has been the case, Representative Weber, as well. A agent or surrogate, or anyone, in fact, acting on behalf of a patient, although legally we refer to the hierarchy of legal authority, in reality, medically, we have family meetings. We get together, everybody, and we sit down and we work for consensus to best understand the values and the goals and wishes of the individual who is unable to advocate for themselves. And that's the standard of care. But yes, and if there was irreconcilable differences where a clinician, a practitioner, could not agree, that would be a situation that would go to an ethics committee. And as an example, that would be where the next step would be to help resolve that. There are very few situations, and in my experience, we are a unfortunately overly legally driven, profession medically. And so I have not encountered in my 30 plus years of practice a situation where a clinician absolutely, refused to respond to a surrogate agent, when an appropriate family meeting, ethics committee, and other, potential avenues suggested other forms were the way to go. What happens in those scenarios is the clinician exits or refers to another clinician to take over care. That's the standard of practice when there's an irreconcilable difference.
And may I ask a follow-up, Mr. Chairman?
Yes.
This would be a hypothetical, and it's based on my lived experience back in the days when we only had living wills. But I had an aunt who told me from the time I was 18 until the time I was 35 that she never wanted to be taken to the hospital, never wanted any treatment, never wanted to leave her home, and she never wanted to be resuscitated or have any kind of invasive treatment whatsoever. And when she experienced a bowel blockage when I was 35, she asked to be driven to the hospital. She consented knowingly and voluntarily to a series of fairly invasive tests. And the question became, and as that was going on, she became unable to speak for herself. So I got a phone call. And I had a document that said she did not want any invasive procedures whatsoever, but I also had somebody who had just that week consented to 3 of them, and who everybody I spoke to who knew her well said, she is still fighting. She really wants to fight. What do we do now? And I would have, in that case, I was going to advocate against what her living will said. Would this provision cover that situation?
Yes, most definitely, it would. So the living will presently, as proposed, is a document of guidance.
Mm-hmm.
It does not carry legal authority, the living will section, unto itself, but acts as guidance for the agent or surrogate. Again, the agent or surrogate must act in the best interests of the patient as best understood at the time. But your example, Representative Weber, is a good one and not an unusual one. And it goes in both directions. You know, people can't predict when they make decisions, when they complete an advance directive, their environment, the people they're talking to, the people that are counseling them and assisting them in the process, you know, are assessing a situation at the time that can't adequately predict or know what the future will hold in all sorts of realms. I mean, just think of the pandemic and, you know, all that's changed over the course of it in regards to medical treatment. There are incredibly unpredictable changes in events and environments that must allow us to act in the best interest of the patient at the time as we can best understand it, with the best guidance that we can have. And this document, we have tried to simplify, we have tried to make clear, and we've tried to allow for that standard of medical practice to occur, and for the document not to force treatments that would clearly be contrary to the best interests of the person if they were capable of telling us that at the time, as we can best understand them.
Thank you. And as a former elder law attorney and former ethics committee panelist, thank you all for your work on the bill.
And thank you, Dr. Representative. On this very narrow issue, before we go back to our usually scheduled program, anybody with a hand up on this specific issue? I think I see Representative Merchant's hand up.
I do. It sort of speaks to the issue. The issue I have is I listened to this conversation. In the bill currently, we have inserted forms, although the language does say that could be substantially equal to the form. My concern as I listen to this conversation, that this is very dynamic, and forms probably will have to change. Once the form goes into statute, it's very difficult to change the form. Would it be possible to have the forms developed by the Department of Health and Human Services through rulemaking, therefore allowing through the agency and rulemaking authority over time to change the form and modify it based upon this healthy conversation we're having today, so we don't somehow inadvertently get ourselves into a pickle because we have a form in the statute that really becomes difficult to change if we need to change it. By the way, if you want to look at the forms, it's on page 16, starts on line 33 and goes on. I just would like to see it move towards a rulemaking authority by the Department of Health and Human Services so that they would have the ability to create a form in through rulemaking. And again, the form can be done through rulemaking that is substantially like it, but over time, as things do evolve, we're not locking ourselves into one type of form that may ultimately need to be changed. And again, I'm not an attorney, but sometimes when you look at a form that goes into statute, and if you change it, even though it does allow for it to be substantially changed, I think by default, people are going to go to the form in the statute because it's legally, again, I'll look to people like Representative Weber or somebody else as an attorney, but I think they're going to default to this one because it's in statute.
A wonderful question. Who's it addressed to?
Address it to Peter Ames, to Mr. Ames.
Thank you, Representative Merchant, for the question. So we have operated with the form in statute currently. So that has been a place where people have gone to reference the form. That's what we produce off of. So We're looking just for these changes to be added to the form now, which again are trying to keep the longstanding policy in place and just provide for clarity. So we're comfortable with the changes as they are amending the statute because we feel it captures what needs to be addressed at this time.
And this is Paula Minahan from the Hospital Association. We also, there are other statutes that have forms in them. I'm thinking of next of kin. There's another, I worked on that a couple years ago. That form is actually embedded into the law. There are other, I mean, we have done this in other statutes. So we actually, I think rulemaking would add a level of complexity that I'm not sure would be helpful. And I would actually, I mean, not to do it right this second, but when Attorney Hillman, he works with this every day in his job as an elder law attorney. So I think he can address this as well as to why it works the way it currently is contemplated. So thank you.
Representative Marsh.
Thank you, Mr. Chairman. This is for Dr. Lawson here. As someone who spent a great deal of time in his career working with people who may have had a long-standing DNR order, but may have had an acute issue they wanted to take care of, would I not be correct that the distinction you were trying to make clear to the committee was the physician's DNR order might be temporarily suspended for the purposes of taking care of an acute issue, such as, for instance, a person in a long-term care facility who wanted to have cataract surgery?
Yes, Representative Marcia, absolutely. There are numerous circumstances where DNR orders are rescinded. Intraoperative is one of them. So almost all institutions, for example, when a patient is going under anesthesia, by policy of the institution, have a order to rescind a DNR. And there are numerous circumstances where people choose to have DNRs rescinded. There are people who choose to be a DNR in the community, for instance, but be a full code while they're hospitalized, where your chances of success statistically are, about 3 times, 4 times as good while you're in the inpatient. So there are numerous circumstances where patients will request rescinding or changing a DNR order. It is a fluid process.
Thank you for that.
Well, where are we?
Knurk has his hand up.
What's that?
Yeah.
Knurk wants to ask a question.
Representative Knurk.
Thank you, because I had a question that was really very similar, because a DNR, because you have a hopeless situation, is very different than an intraoperative arrest. Now, you said the patient can rescind in various times, but it sounds like you're saying it automatically can occur, usually most institutions intraoperatively, or that they have that choice of in a hospital versus out of hospital arrest. But I didn't see that on the form of how they parse that out. Is that something that would be taken care of individually with the practitioner, between the provider and practitioner, or how do they parse out those differences, which are somewhat difficult, I think, for people to understand the difference between a simple arrest intraoperatively and an arrest when you are on your way out in the act of dying, is the phrase that is used here, where it's a very different reason. Can you clarify how that would work?
Yes, I take it that's addressed to me, Representative Knurk.
Yeah, I presume. Yes, I think Dr. Lawson, that'd be best to you.
Yeah, so absolutely. So there are situations like you discuss where it is by policy and automatically done. And then there are situations where it is an agreement between the patient and or their surrogate or agent and the clinician involved. And it is a fluid process. It's unfortunately too complicated, and there are too many different situations to try to stipulate it in law. And I'll give you an example of a analogous situation, and that is a person's capacity. So, by law, you either have capacity or you don't. But in reality, from a medical sense, you can have capacity to make certain decisions, but not have capacity to make other more complex decisions. And your capacity can wax and wane. So as people with, for instance, mild to moderate dementia sundown, using the street term, or get more delirious in the evening, they could have capacity in the morning and not have capacity in the evening. So these things are fluid, and like most medical things, are complicated, vary over time, and cannot be legally, parsed out without getting into big trouble, in my experience.
I do not see anyone's hand up, but we'll give one last call to discussing DNR before we go back to how we normally do things. Is that a hand up or just a scratch? Okay, that was a scratch. But Representative Gay.
Thank you, Mr. Chairman. And thank you all for taking my question, because I'm not sure who to direct it at. All of this is new to me, so I apologize for the noviceness of my question. Where is it spelled out? What RSA does it spell out that the medical provider, whatever terminology you want to use for the medical person in charge of a patient, where is this set in stone that the medical provider has the final utmost say in interpreting the DNR rather than an agent of the patient? It was cited in some of the answers that that's the standing right now.
Representative Weber, do you wish to address that? I saw your light on. No?
Me? If you want me to, I'll be glad to take a stab at it. It's unusual.
So was the box around you was lit, which usually means somebody is trying to speak. So that's why I called on you. Or defer it to someone.
I would be happy to answer it.
Thank you.
The DNR order, as the attorney spoke, is a medical order written by a practitioner. The word in the law is practitioner. And so the practitioner writes the order. Like, that's actually what happens. So nobody else can write an order. An agent can't write an order in a medical record. Only a practitioner can. And that's, I mean, it's as simple as that from my perspective. Maybe Ben or one of the attorneys would like to answer in more complexity.
Any of the attorneys able to answer Representative Gay's question?
Chair, with
if this is,
Yes, go ahead.
I'm sorry, I don't know if it was directed at me or at Representative Weber. I guess I would just add that I don't have anything to add to what Attorney Lawson said in terms of the distinction between the agent's ability to make a decision and what needs to be embodied in an order by the physician.
Follow up?
Yes, thank you for taking my additional question, which is, how exactly do you go, what is the process to go from a patient's DNR, which is, let's say it's supported by its agent or whatever the right word is for the person speaking for the person who wrote the DNR. How do you go from a patient's DNR to a medical DNR? What drives the provider's decision to write the DNR? Do you have to, we're always told we have to bring those orders to every doctor. When I take my mother to many different doctors, we had to make sure that each of them was aware of what her documents were. But how do you transfer that into the actual medical order? At what time is that transferred? How does this happen? Thank you.
Yeah. I can answer that. I think I'm probably in the best position Dr. Lawson here again. So this is a common issue. Many people misconstrue an advance directive for a medical order, and advance directives are not medical orders. The advance directive is purely a document that states wishes for the future, and an advance directive does not come into effect until the patient has been documented to have lost capacity and to fulfill any of the preset components of the advance directive. So an advance directive itself is not a medical order under any circumstances. So you could say anything in an advance directive, and if you suddenly died at home, emergency personnel are obligated to initiate CPR, irrespective of what's written in your advance directive, because it is not in effect, because you have not been documented by a medical practitioner to have lost capacity. So that's the first thing. An advance directive is a directive for the future. It is not a medical order. The medical order is the DNR or POLST form. And those POLST forms or DNR forms, the pink or yellow forms, are completed by the practitioner at the request of the patient or their agent or surrogate, depending on the circumstance, or advised by the practitioner. So the process has to be a meeting, an appointment or a meeting or an in-hospital consultation or wherever the venue is, to have an appropriate discussion around the benefits and risks associated with such an order, and then the order actually being written. And the accepted orders in the state of New Hampshire include the pink portable DNR. Assuming SB 74 moves forward, it would include the yellow POLST form, which has a DNR, and then any order within an institution that is consistent with the policies and practices of the institution. And those are the only accepted medical orders. So it is the process by which an advance directive, which I think you're talking about, Representative, moving to a DNR order, is a specific interaction between a practitioner and a patient and or their family and or surrogate or agent, where that order is written. It's really, really common misconception. About probably 50% of more of the patients who come to see me in palliative care consultation have an advance directive. That's all they have, and they think they have a DNR order, and they don't. And they will receive CPR when EMS is called, when 911 is called from home, irrespective of what that advance directive says. It's a good, I appreciate you bringing up the point, because hopefully it's educating quite a few people. What they say in their advance directive is not a medical order until it has been made into a medical order.
This is very helpful. Thank you. I think I'd like to attempt to go back to the normal way of doing things and call on a few other people who haven't spoken yet, coming back to the original group that we brought in on one specific thing. With that, the chair would like to recognize Robert Dunn, who is part of this group and represents the Roman Catholic Diocese of Manchester, New Hampshire.
Diocese of NH, Manchester.
So welcome to Mr. Dunn.
Good morning, Mr. Chair, members of the committee. Thank you for the opportunity to testify. I'm Bob Dunn, the Director of Public Policy for the Roman Catholic Diocese of Manchester, and I'm speaking today in support of SB 74. I won't go into too much detail because I know there's a lot of folks that are going to go over the various provisions of the bill with much more of a fine-tooth comb. So I just want to make a couple of comments here at the outset. First off, our views on end-of-life care start with the fundamental conviction that each human being was created in God's image and likeness and that therefore every person at every moment of life has a priceless dignity that can never be diminished or taken away, even when a person is in the extremities of illness or death itself. And so from a Catholic perspective, we believe that this calls us to avoid the opposite extremes of the deliberate hastening of death on the one hand, and the use of treatment that under the circumstances doesn't have a reasonable hope of benefit or constitutes an excessive burden on the other. And so the diocese has actually published a booklet that's called 3 Beliefs that explains Catholic views on end-of-life care and that tries to assist New Hampshire Catholics in setting up their durable powers of attorney for healthcare. And based on that experience, we think that SB 74 makes improvements to the advance directive law that's in place today. And I know you're going to hear about these in more detail. I'd highlight things I think that you'll hear about how the bill clarifies that end-of-life treatment provisions in an advance directive are connected to the person having an advanced life-limiting, essentially what we would probably colloquially refer to as a terminal illness. And it importantly lays out how a balancing of burdens and benefits is involved in the making of decisions regarding end-of-life care. The provisions that you've been hearing about already that kind of help to make it the case that decisions are being made on an updated basis on the most recent information that folks have are also notable. And the bill clarifies that those out-of-state orders and posts are only effective in New Hampshire to the degree that they substantively conform to New Hampshire law. And finally, I just want to point out very significantly that SB 74 once again reiterates that our law doesn't condone or legalize physician-assisted suicide. Now, I do want to note that there are certain aspects of the current law, specifically provisions that relate to permanent unconsciousness and medically administered nutrition and hydration, which we have opposed over the years because these provisions don't accord with our views on what should be considered basic obligations of care. And because those provisions are largely unchanged by Senate Bill 74, I do want to emphasize that in supporting Senate Bill 74, we're not altering our position on those provisions. But as I said, we think that the version of the advance directive law that would be in effect after the passage of Senate Bill 74 would be an improvement over the version that's in effect today. And that's why we're supporting the bill. So thank you for your consideration of our views. And with that, I'll close.
Any questions for Mr. Dunn from the committee? Well, thank you, sir, for all your hard work on this group and for your bringing the position of the Roman Catholic Diocese. The chair would now like to call, we have a few people signed up in opposition, and I want to get to them before we go any further. I believe former Representative Kathleen Souza is on the list wishing to testify.
And anyone who wants to testify could please raise your hand to bring you to the top of the list.
Is Kathleen Souza in the meeting?
I'm not seeing her on the attendees list.
Okay, then Representative Erica Leon from Derry.
Thank you, Mr. Chair and honorable members of the committee. For the record, I am Representative Erica Leon of Derry. I stand in strong opposition to this bill, as it turns a weighty decision into an overly simple form. What looks like a simple designation of medical decision maker actually flips current policy on its head. Right now, it's easy to say that only your designated agent can make these choices by filling out only Part 1 and not Part 2 of the current form. With this bill, there is no clear way to do this and no language to protect that as a specific declaration. That is a huge problem. If you pass this, will we need a bereaved family members to sue to see how it plays out in court? This morning, I emailed the committee my concerns in this bill in bullet point format. I have many serious concerns about how this bill shifts consent from opt-in to opt-out on experimental therapies and honoring statements of incapacitated patients, on how it reduces the rights of practitioners to follow their conscience, on how it blends Alzheimer's disease with an irreversible coma, and how it removes family beyond the agent or surrogate from care planning decisions when they are incapacitated. Perhaps even more terrifying, right now, if a patient wants their agent or practitioner to ignore what they say when they are incapacitated, they need to specifically opt in by writing that on the form. If you sign the forms as proposed in SB 74, your doctor and your agent can ignore your pleas for care or your refusal of treatment. A patient with Alzheimer's can be ignored if they just sign the form as written on SB 74. I understand just how weighty it is to stop fighting death, as my father's advance directive allowed the family to make the decision and then stay with him for his final moments. Final days where we could say those necessary things and to literally hear him say, "I love you" with his dying breath. This bill, had it applied to us, would have let the hospital not treat his sepsis and denied that closure to all of us, especially closure to him, as it had been over 2 decades for the family that was in that room to be together. So this bill makes the form so simple and uncomplicated that an average patient won't understand just how much autonomy they give up. The form looks like any other rote form that patients sign. With some of the changes, it actually allows a doctor you've never met to sterilize you if you're in a coma from an accident, and it should not be that easy to sign away those rights. I urge you to kill this bill by voting inexpedient to legislate. Please, just pull the plug. Thank you, and I will take questions.
Any questions for Representative Leon? Representative Gay.
Thank you. Representative Leon, could you again cite some of the points per line that you are saying would have interfered with your family being with your father, or the sterilization, something referenced, because this is rather detailed. It would be very helpful since you have cited them.
Thank you, Representative Gay. I do understand that I dropped a lot of things on you, so it's good to back these up. If you go to page 6 and start at line 29, this is where it changes the capacity and the ability to refuse treatment or to ask for treatment. Right now, the part that's struck out starting at line 36 and continuing to page 7, it requires that the principal, it says that treatment may not be given or withheld from the principal over the principal's objection unless the principal's advance direction includes the following statement initialed by the principal. Even if I am incapacitated and I object to treatment, treatment may be given to me against my objection. The new language says that the agent or surrogate acting on the principal's behalf consents to treatment or withholding of treatment from the principal, even over the principal's objection, unless the durable power of attorney for healthcare provides otherwise. That puts the onus on somebody who is filling out what will be a 2-page sheet that looks like it's just naming the person to make those choices, to know that that's within the law, especially because that's not even within the disclosure statement. If you'd like me, Representative Gay, would you like me to to pull up another one of those? Like the sterilization, that one's on page 8, line 12. So right now, in page 8, line 12, it still prevents the agent from consenting to psychosurgery or electroconvulsive shock therapy. And instead of just striking out an experimental treatment of any kind, it also strikes out sterilization. And that's in direct conflict with the disclosure form that is provided for in the statute. So the disclosure form would be in conflict with the underlying RSA, with the fact that sterilization is struck out. And the part that would have made that change for my father is right now you have to, when you fill out the advanced healthcare directive form, there's the two sections. There's the durable power of attorney for healthcare, and then there's a living will. And in New Hampshire statute, the way that it's written now, the living will just gives that direction for a physician assistant, or an advanced practice nurse to make those decisions about incapacity and then making those end of life decisions. So if you don't want to have a doctor that you may not have ever met before make those choices for you, then you just do not sign that part and you are not giving those rights away. That is not something that's provided for in this bill. In the new statute, as amended by SB 74, I honestly would have to hire a lawyer to know how to put that into my directive, because I don't want to give away that autonomy. I would rather be in limbo until they can find somebody to make that choice for me than to allow a doctor, well-meaning as they may be, to decide that I shouldn't have that sustaining care.
Follow up?
Would you be so kind as to put these concerns into writing to send us, since it is complex?
Thank you, Representative. I'm sure you've had a huge number of emails about this bill. I sent one to you all this morning from my legislative email that does have the bullet points of the lines. I do apologize. One of them, I forgot to have the page reference. So in the one where it's the language striking out the right of a principal to reserve these end-of-life decisions to only their agent, that's on page 11, lines 16 to 34. I had forgotten to have that page as I was typing this up.
Thank you very much.
Thank you.
Any other questions for Representative Leon? I do not see any hands except for the hand of Representative Cushman.
Thank you, Mr. Chairman. Thank you, Representative. Can you speak to your concerns about the incapacity blending between, say someone who has Alzheimer's disease with imminent death?
Thank you, Representative. Yes, this is the biggest concern here is the ability to override somebody's, the one that we looked to before about overriding their wishes and their expressed interests. Because if somebody is in a coma or something else like that right at the end of life and they're delirious, that's one level of incapacity that would make sense. I could see a time where you would ignore what somebody's saying because they might be talking about all sorts of other nonsensical things. And a provider might want to override those decisions because they clearly don't have much of a grasp of reality. You also, right now with the incapacity, there's not any sort of separation from major neurocognitive disorders like Alzheimer's. There are other states that do have a provision for major neurocognitive disorders where there can be treatment that's given against the patient's will, either for being put into a locked memory facility, for being given medications that they don't otherwise consent to. But that's not within the same blanket statement like we are trying to put into law here. That's something that's well considered for these long-standing incapacities, and there's just not much treatment of that here. We're not respecting the difference between an Alzheimer's patient and somebody who's just on the verge of death.
Thank you.
Thank you.
Any further questions for the representative? I do not see any. None? Thank you, Representative, for your testimony and answering our questions.
Thank you.
Let's see, where were we? Let's circle back to Paul Minahan.
She's already part of the group. She can just talk.
Thank you. Let's circle back then to Peter Ames, if you're still with us.
Yes, thank you, Mr. Chairman. my remarks from earlier cover everything I wanted to address. So again, thank you for the opportunity.
Very well. Anything further, either from you or for you, for Mr. Ames? Seeing nothing.
I have my hand up.
I'm sorry. Yes, go ahead.
I'm not sure who this would be most appropriate for, but there was just one spot that I was a little bit confused and just wanted explanation. Page 26, lines 20 to 23. If you could just clarify what that means and why it's there. I just was a little bit uncertain. I mean, it sounds like it gives permission for a person to not treat, a practitioner to choose to not treat a patient. Is that all it's doing?
I could ask you to reference those lines once more for me.
It's page 26, lines 20 through 23.
Thank you.
It appears that it just says that the practitioner is not obligated to treat someone who lacks decision-making capacity, and I'm curious why that's there.
Yeah.
Yep, so that piece is part of current law. So we're not looking to change that aspect of it. Just clarify the words you see there. Yep.
Okay, thank you.
Representative Cushman.
Thank you, Mr. Chairman. I have a question for you. So I see there was language, and I apologize, I'm not finding it right at the moment. But it removes the right of providers and facilities to opt out of DNRs or living wills. Can you explain why that's supported in this bill? Page 23, line 16. It's page 23, line 16 and 17.
17.
It's page 6, lines 3 through 6, and page 10, lines 30 to 34.
Okay, page 6. Yeah, if I could represent, I might want to defer that to Attorney Kate Hanna, who probably best speak to that aspect of the change.
And would the person, I did not catch the name that you referred us to?
Yep, Attorney Kate Hanna.
Okay, I will call then Kate Hanna, Attorney Kate Hanna, if you're in the meeting, to explain for the representative page 6, lines 3 to 6.
I do not see her in the list.
Okay.
Mr. Chair, I would ask that people be allowed to testify, that we get to all people and let them testify completely, because I think there are people lined up who are going to explain these things, who are the appropriate people to explain them, and who have them in their testimony if only we could get to it as a whole.
I'm looking at the list of the people before me who have signed up to testify. I've called on virtually everyone, but let me call on those I have not called on. The chair recognizes Gina Balkus, who's a lobbyist with Granite State Home Health and Hospice Association, and you may bring your testimony to us, Ms. Balkus.
Good morning, Mr. Chairman. Can you hear me?
Yes.
Good afternoon. Actually, it's not afternoon yet. It's still morning. I am Gina Balkus, CEO of the Granite State Home Health and Hospice Association. We advocate on issues that affect home care, hospice, and palliative care providers and the patients they serve. Our association members care for individuals from birth through end of life, primarily in people's homes. And we are part of the Healthcare Decisions Coalition that carefully considered this statute, and we worked with stakeholders to draft improvements. The association strongly supports Senate Bill 74. Medicine has changed much during the past 30 years since New Hampshire enacted its advanced directive laws, but what has not changed is the respect for the individual's right to choose medical treatment they want and decline medical treatment they do not want, and ensuring that an individual's wishes are honored at end of life when the person may be unable to articulate their wishes is the core of the legislation that the late Senator Susan McLean championed in the late 80s and early 90s. And it remains the core of Senate Bill 74 that was passed by the Senate. I think it's important for you to know that New Hampshire's current law is clunky and often difficult to understand. Senate Bill 74 improves New Hampshire's advanced directive law by clarifying definitions and simplifying much of what I would call the legalese in the existing form. It will also make it easier for healthcare providers to honor patients' wishes without having to seek legal counsel or judicial orders. And it will allow for smoother handoffs between providers, allowing medical orders to follow the patient across the continuum of care. One major improvement is on page 15 of the bill. The disclosure statement, which must accompany the advanced directive document, has been revised from the lengthy legal jargon that is currently in the law to concise, simple language. It covers all the same points in the current law that an individual should know prior to signing an advanced directive. Another improvement relates to surrogacy. In the existing law, there is confusion as to whether the surrogate has the same authority as an appointed agent in all circumstances. Some legal counsels have advised that a surrogate, such as a wife, a husband, or an adult child, may not be able to consent to withholding or withdrawal of life-sustaining treatment because New Hampshire's existing law only allows an agent to do that with express written permission in an advanced directive. But here's the catch-22. A person becomes a surrogate because there is no written advanced directive. So Senate Bill 74 eliminates the requirement that an individual expressly permit in writing the withholding and withdrawal of life-sustaining treatment, although somebody can certainly write that into their document. This has been a cause of great confusion for agents, providers, and especially for family members who are surrogate decision makers. It has also been problematic when providers encounter an out-of-state advanced directive that does not have this requirement. Senate Bill 74 recognizes DNR orders, PULSE, and their counterparts from other states. And this means that a practitioner order for life-sustaining treatment can accompany a patient in whatever setting they may be, a hospital, a nursing home, or at home with a home care or hospice providers. And this is so important to honoring an individual's wish across the continuum of care. Lastly, we strongly support the provision on page 26, lines 24 through 29, that extends the authority for a surrogate decision maker from 90 to 180 days. This is important for hospice patients. It makes it less likely that families will need to go through the guardianship process in their loved ones' final days. On behalf of New Hampshire's home care, hospice, and palliative care providers and the patients they serve, I ask that you recommend Senate Bill 74 as ought to pass. And I will take a stab, Mr. Chairman, if you allow me to answer a couple of the questions that have come up. So one of the points that I just wanted to make is that actually on page 6, I think it was Representative Cushman who asked about page 6, lines 3 through 6, that says any healthcare provider or residential care provider which does not recognize DNRs or living wills should post a sign. that was deleted because, to be honest, we know of no provider that has such a sign. That was actually put in sort of haphazardly in the Senate during several years ago when the statute was being revised. But there is still in this bill, there are provisions that allow both a practitioner as an individual to basically transfer a patient to another provider if they feel they cannot comply with the living will. And also for a provider, and in this statute, a facility is defined as a provider. An individual practitioner is defined, like a physician or a nurse practitioner is defined as a practitioner. So it's still in there, it's just this sign requirement is taken out. The other thing that I wanted to just point out is that, and I'm looking on page 8, in response to one of the speakers who testified earlier, page 8, line 5 still maintains that an agent cannot consent to voluntary sterilization. It is still in the statute. It was crossed out someplace else in the statute because things were moved around. That's all. And I will be happy to answer any other questions that, well, I will attempt to answer any questions that others might have.
Representative Day.
Yes, thank you, Mr. Chairman, and thank you for taking my question. If a practitioner finds that they're not comfortable following the patient's directives, you said they can transfer that patient to another practitioner. Is that a requirement in this bill that they do if they do not feel like they can follow what they've been asked to do?
They do have to inform the agent or the surrogate, and I'm actually looking for the section right now. I'm sorry?
Page 9, lines 30 through 34 was crossed out. That requires the informing of the patient and the patient's family. But it's been struck from this bill.
You said page 9?
Yep, lines 30 through 34, but that's where it's struck. So I don't see.
Yes, it was, I believe it was moved to another section, and I'm just.
5 and following seems to pick up the theme.
I think it's on page 9, line 35 on, where it talks about making the necessary arrangements without delay. It immediately follows the struck section.
Yes, yes.
Okay.
It is definitely in there that the provider, that the practitioner must inform the family or the agent or the surrogate and shall assist in arranging for transfer to another provider, to another practitioner. So it is in there. Any sections that were struck were simply moved around.
35 and following as fulfilling that.
They are still required to fulfill that, yes.
Yeah, we see it. We see it. Any other questions from Ms. Balkas?
Yes, Mr. Chairman.
Sounds like Representative Merchant.
It is. Thank you, Mr. Chairman, and thank you, Mrs. Balkas. And talking about experimental care, when I look at the page 17, folks, and looking at line 34, it says life-sustaining treatment within the limits of generally accepted standards of care. Experimental therapy normally does not become accepted general standards of care until it's been accepted, generally speaking. That's why it's experimental. In saying that statement, then per se excludes the use of experimental care, because if I select that, I'm not specifically addressing the issue of experimental care. So should the form include an option in there for the patient to select experimental care in addition to generally accepted care?
So I am going to yield to either the attorneys who are on the call or to Dr. Lawson, who may be on the call. I'm not sure if Lindsay Courtney from Dartmouth-Hitchcock has signed up to testify. The experimental treatment provisions of the statute or of special concern to Dartmouth-Hitchcock.
Chair Matthew Hode from Dartmouth has his hand raised and can probably answer that question.
Yes, from Dartmouth Hitchcock, Matthew, last name?
Matthew Hode, H-O-U-D-E.
Matthew Hode from Dartmouth Hitchcock is recognized to answer that question.
Yes, thank you, Mr. Chairman, members of the committee. For the record, my name is Matthew Hood, Vice President of Government Relations at Dartmouth Hitchcock. I was raising my hand to testify to the experimental treatments and clinical trial sections in general, which I'm happy to do, but I will hold on that to answer Representative Merchant's question pertaining to whether or not the form has been updated to give that specific distinguished category of choice, and the answer to that is yes.
If I may, Mr. Chairman.
Follow up?
Thank you, Mr. Hood. So there's no conflict between generally accepted healthcare standards and experimental care?
So I know that this is becoming a common theme in this hearing, that I would defer that question to one of the physicians, or frankly, I could get the question answered by our legal counsel. What I thought the question was, has the durable power of attorney form been amended to reflect the agent authority to consent to a clinical trial? And the answer to that is yes.
So if I understand, Mr. Chairman, if I may, under the durable power, that's where it's addressed, not in the living will.
It's in the my understanding, and I'm happy to be corrected, but my understanding is that is in the instruction to the durable power form. It's in the statute. If you look at the form further down, as you had pointed out, it's there.
I'd like to get a legal opinion, because when I read this, I hear your point. I see it as a conflict, because I don't see experimental care becoming generally acceptable healthcare standards until they've been through the experiment and things have been signed off on, if you will, accepted by the medical community at large. So in saying that, the way it's worded, I just think it could be ambiguous and possibly conflicting with what's there.
If I may speak to the experimental treatment and clinical trials section with Representative Merchant's follow-up question in mind, it may provide clarity for that.
Just about to ask you to do that.
Thank you very much. And by way of background, this issue came to light in the early stages of COVID-19 because there existed situations across the country, but frankly also in the state, where patients were suffering severe symptoms of COVID and were brought into the hospitals, Dartmouth-Hitchcock certainly, but not alone, and other hospitals as well, where there were potential experimental treatments available, but providers were unable to administer those because the patient was unable to give consent, whether they were intubated or otherwise. Even if there was a spouse or an agent who wanted to consent on behalf of the patient, that could not happen because of the prohibition in statute to give an agent giving consent to experimental treatments. This was literally life or death, and we're appreciative of the governor's office giving an executive order that suspended essentially that prohibition with respect to those suffering severe COVID symptoms. The legislature followed suit and largely codified that executive order, but it sunsets at the end of June this year, which is why this provision was added to Senate Bill 74. Without, I acknowledge, the limitation to COVID. And so let me speak to what the provision would allow, which it would give authority in certain limited circumstances for an agent or surrogate to consent to experimental treatments or clinical trials. They include that the situation be life-threatening disease or condition, or a serious disease or condition that would result in impairment of function, that there's no alternative therapy available, and that it's authorized by an internal review board consistent with relevant state and federal regulations. And finally, this is applicable where the advance directive is silent, such that the principal can decline in the document, and such authority would not be available. So working with other stakeholders, stakeholders at the Disability Rights Center and others, we constrained the language with respect to authorization of agent surrogate for experimental treatments or clinical trials. I'll close with that section because I think Ms. Balkus referenced that the prohibitions that existed with respect to sterilization and involuntary commitment remain. There was a strikeout of the sterilization piece in one place, but it remains in section B of 5. So I just wanted to reiterate that. And I'm happy to answer questions that I can.
Does anyone have a question that he can answer? Let's see, Representative Cushman.
Thank you, Mr. Chairman. Thank you. Can you tell me if this bill were to pass, would everyone who has completed the current forms for advanced directives and durable power of attorney then need to go back to a lawyer and have the process started over?
Thank you. That's a great question, Representative Cushman. I appreciate it. It was a discussion of topic on the numerous calls that were referenced. But that's a question I'm going to defer to the attorneys on the phone call to answer that question.
Thank you.
My understanding, just briefly, is that the answer is no, but I want to defer so you have a fuller legal answer to your question.
I see Representative Nelson's hand up. And please unmute.
At this point, I'm totally confused because there seems to be some conflicting ideas. One of the things I thought I heard earlier was that the person could have in writing that they do not want to be resuscitated, but the hospital or whatever can override that. But on the other hand, what I just heard doesn't seem to go that way, and I'm just confused as to what's happening because there's, I don't know, maybe just me.
Well, Representative, I've been on the hearing for the duration. So, with respect to the conversation about what a hospital or a provider can or cannot do, you've heard the same things I have. With respect to this provision, a principal can do any number of things. They can say, I want any manner of experimental treatment. Doesn't have to be life-saving, doesn't have to be a serious illness or condition. That's one scenario they can do. They can also say, I don't want any, and that is to be respected. And then the third is they can be silent. And it's the situation of silence that I'm discussing, which is what are then, in the absence of selection, is an agent or a surrogate entitled to do with respect to clinical trials or experimental treatments. I hope that clarifies in this scenario.
Well, I guess when you said that hospital, whatever, can give experimental drugs without would override everything if the hospital wanted to. That seems to conflict with some of the things that were said earlier. That's just me. Sorry about that.
Yeah, no, well, I would want to be clear for the record that is not what I intended to say. In fact, the reason that we raised this issue and sought inclusion in Senate Bill 74 was that our providers could not give experimental treatments in the absence of consent, and the agents could not because the statute precluded it.
Thank you.
Any further questions for the speaker?
Chairman?
I think I see Representative Merchant's hand up.
Thank you, Mr. Chairman. I'll also go back to Mr. Hood. Would you be opposed to modifying the form language in the bill so it specifically says that the patient consents to experimental care in addition to life-threatening? So there's two options there. One is strictly looking at the generally accepted, as well as an option for including experimental care. That way there, it's specific on the form, so the patient has to sign off on it, not something that's embedded into the bill somewhere else that refers back to it. So the form itself is very clear that I agree to experimental care as well as general accepted healthcare at the same time. So there's two options for the patient. One, strictly generally accepted care. Two, that provision plus experimental care.
So Representative Merchant, I'm certainly amenable to clarity of language. And the only caveat that I would give is that this has been a thoroughly involved stakeholder engagement process, and I can't speak for the entirety of the group. That being said, we can convene to determine if that would be amenable to the larger group, and we will endeavor to do that.
Thank you. If you decide to pull together a group before we accept on it, I'd be glad to be part of it.
Might I suggest, Mr. Hood, that at least in addition to bringing your group back together, you bring those legislators who have had various questions as to this is not clear, so that any amendment to the form could be done by both us who wish to participate and the group who pulled all this together. And the reason I suggest that is I would hate to have just us do it.
I'm sorry, Mr. Chair, I just missed the last part of what you said. I apologize.
I would not want just us or just we legislators in an exec session to modify the form. So if your group wishes to come back to modify the form, it should include any legislators that have objections so that our concerns about what's not in the form would be incorporated. That's more of a statement than anything else.
Thank you. I heard that this time.
Right. Thank you. Representative Weber was next.
Thank you, Mr. Chairman. And I think we are getting very much into the weeds here. So for Mr. Hood, am I correct in understanding as an overview that what this amendment to existing statute does is that overall it clarifies ways in which a principal may want to specify any one of the whole range of things that they either want to have happen or that they do not want to have happen, and that then there is language, and if they have specified, then that is generally speaking, except in very narrow situations, what's going to happen, and that the rest of the statute deals with what you do when the principal has been silent about their wishes and how you best aim to give effect to what it is or was that the principal has stated that they wanted either now or in the past.
Yes, if I could say two things, Representative Weber. One is with respect to the summary that you just described and the section that I spoke to, the answer is yes. The other piece that I'd like to point out to Representative Merchant and the others on the call is there are instructions, and maybe you saw this, but on page 16, it starts on line 14, and then there's what I think was intended to be very clear. I want to participate in medical clinical trials, and then I don't. And so when I reach out to Representative Merchant, my hope is that I will ascertain if that lacks clarity in this context.
And may I have a follow-up, Mr. Chairman?
Yes, please.
If I can remember what the follow-up is, because my brain just bounced.
Sorry, Representative, I took you on a detour there with a number 2. I apologize.
That's okay. And here's my follow-up question as somebody who is very aware of hospital procedure. Is it not true that there are many, many religious groups, humanist groups, groups who promote thinking on these very difficult issues of end of life decision-making, who get together, just as we had testimony from the Catholic Diocese, that they have an entire booklet of guidance for those who wish to make sure that their advance directives follow their beliefs, that there are any number of other groups who help potential patients long before they become patients explore what they might or might not want to include in one of these documents, and that it is not at the behest of an attorney or anything else, but that you can add directions in that reflect your own personal thoughts that come out of any number of different kinds of discussions, none of which are specified in the statute.
Yes, clarity from any source is welcome.
Representative Marsh.
And one further follow-up, if I can. Is it not true that sometimes those discussion groups result in the execution at the end of them of a document personal to the individual participants?
I'm sorry, Representative Weber, could you just restate the question?
Well, let me state it a different way. When I was on the ethics committee at Brattleboro Memorial Hospital, we often had workshops for people on how to fill out these documents. And it was just community members, y'all come. And at the end of those meetings, sometimes community members would want to fill out the forms right then and there. And it was the way of ending that series of meetings, should they choose to do so. Is it not true that there are various groups of various sorts that do that now with respect to these documents?
I'm sure that there are. My testimony is constrained to Dartmouth Hitchcock's experience, and Dr. Burstein, who's no longer practicing in the Nashua area, was a leader in the advanced directive space for Dartmouth Hitchcock, and he certainly, and we tried to raise awareness about the importance of engaging in the process of planning for that event.
Mm-hmm. And I guess what I was trying to focus on and lost sight of is that does not necessarily mean having to go out and hire a lawyer. There are lots of other ways to engage in the planning process with people who have been involved in it that are no cost, thoughtful, and with various resources available to people.
Yeah, yes.
Thank you.
And our medical center, this is Representative Pearson in the chair, our medical center in Kingston regularly has these workshops and helps people work through the forms. Representative Marsh.
Thank you, Mr. Chairman. I was intending to ask Matthew whether page 16, lines 12 through 15 was precisely the choice that Representative Merchant wanted to add by amendment, and I believe he already answered the question.
Thank you. Anyone else from Mr. Hood? Or Dr. Hood, excuse me.
Nope, nope, Matthew. Want to be clear, I am not a physician. I am a lawyer by training.
Councilor Hood. Anyone else?
It's very kind, Mr. Chair.
Welcome. I do see a hand up for Representative Weber. Is it a new hand or an old hand? Do I see any other hands up?
All across the
I'm not
bottom,
seeing any hands up on my screen.
like 6 or 5.
We have,
My apologies. I had my hand up. I had not lowered it, and then I got a phone call. So my apologies both for the noise and hand.
some attendees with hands up, but they're all people that you've previously called. So
Okay. I will circle back to them. I want to make sure that everybody on my list who wishes to speak to us has the opportunity. And the last one I have on the list that is given me is Mr. Robert Wells of Manchester. And if you're still in the meeting, thank you for your perseverance, and we're calling you to speak if you wish.
Thank you. My name is Robert Wells. I live in Hopkinton, New Hampshire. I've been practicing in the field of estate planning for almost 50 years. And I would like to defer to Ben, who has the detailed information that you may want on the bill itself, since he and Ginger Sheehan were members of a committee, of which I'm also a member, that really worked hand in hand with the group to bring this bill to fruition. So I don't have that kind of detailed information, but let me make a comment. One of the concerns I have had as a practitioner for these many, many years with respect to the healthcare directives is a concern about the medical community and how they can respond to the current document. The current document is not helpful to the medical community because they have to keep going back to the document as a patient progresses through various stages of illness. With the new document we have, the medical profession is more able to deal with the patient in a way consistent with what the patient may want, and with an ongoing dialogue with the agent with respect to what the principal may want. So I think this change is very, very helpful. I go all the way back to Susan McLean when she in 1980 got introduced and passed the living will, which was then vetoed by then Governor John Sununu, but fortunately his veto was overruled. Subsequent to that, we have had the evolution of healthcare powers, post, et cetera, et cetera. But what this bill does is it allows the physician and other medical practitioners to deal with a patient and in discussion with the agent in a way which is very, very effective. We now know that our primary doctor is not in the hospital. It's a hospitalist who's in the doctor or in the hospital, or an intensivist. They may not have the communication with the patient in terms of what he or she may want. So the agent then becomes critical with respect to what the principal wants. As I help clients work with these current documents, and would in the future with the future document, is you have to have an agent who is an effective advocate for you. Not someone who just sits there and doesn't do anything and just accepts whatever comes their way. They must be an advocate, and they must be able to confront the medical community with concerns and with issues. And I think that happens. And I know all the doctors that I know and other medical practitioners do everything they can. But it is not easy for them to keep going back to the healthcare directive as time moves on with respect to the treatment of a patient. So this new document, practically speaking, takes care of that problem. Having done this for so many years and having worked with so many patients, so many clients whose parents or children or others who were involved with a healthcare power and the living will, they are also very, very thankful we have this document. But they do confess that it is complicated sometimes for them to deal with the medical community because of the manner by which the current document is written. So I would strongly urge that you pass this tremendous work, hours and hours and hours of work by so many people to get us to where we are today. It would be a shame to turn this back. I do believe strongly that a patient's rights are protected. People are not going to go out and act willy-nilly with respect to the termination of someone's life. I think that is highly irresponsible thinking on anyone's part. So again, I would advocate for the passage of this, but I would turn over to my colleague, Ben, to answer specific questions about the development of the document because he and Ginger Sheehan were the members of our committee who work so closely with this group. I'd be happy to answer any questions.
Remind me again of Ben's full name, please.
It's Benjamin Syracuse Hillman. He spoke earlier.
Thank you. All right, I will call back Benjamin Syracuse Hillman and take it from there.
Great. Thank you, Chair and members of the committee. So I'm Benjamin Syracuse Hillman. As I mentioned earlier, I'm an attorney at Shaheen and Gordon in Concord and Dover. Focus my practice on estate planning, elder law, and probate litigation. I'm testifying today on my own behalf, as well as on the behalf of the New Hampshire chapter of the National Academy of Elder Law Attorneys, which is a membership organization of about 80 attorneys who represent elders and persons with disabilities in our state, as well as the group that Bob Wells just mentioned, the Legislative Working Group of New Hampshire Trust and Estates Attorneys, which is an informal group of about 40 attorneys who convene approximately monthly to work on legislation. Both groups strongly support SB 74. Ginger Sheehan from the Trust and Estates Working Group and I, on behalf of that group, and NALA, actively participated in the working groups that Senator Sherman convened following the bill's initial introduction. There was an in-depth process featuring a robust exchange of views from stakeholders representing many different perspectives, and the legislative text was worked through very carefully to try to accommodate all of those various interests and to reach compromises between differing interests. And I'm glad we've gotten to a place where each of the various groups that participated, although some were actually opposed to the bill at the beginning, including NALA that I was a part of, came to a place where we were in support of the legislation. The resulting legislation substantially modernizes our advanced directive law. I think most importantly, from my perspective, it takes a set of forms that was confusing and required a high level of education and knowledge to read and digest, and substantially modified those forms to make them easier to read and understand. And we expect that individuals, whether they're working with an attorney, a medical practitioner, a social worker, a family member, or by themselves to complete this form, will now be able to do so in a manner that better reflects their wishes and expresses their preferences as compared with the existing form. The disclosure statement at the start of the form also has been made substantially clearer, more user-friendly, and the use of jargon has been brought down to a minimum. So again, our hope and our expectation is that it just makes it much easier to use and understand. A couple of the questions have touched on changes, and I'm going to try to address some of the specific questions I heard earlier in a moment. But for now, I wanted to mention, I mean, the purpose of the legislation in part was to change certain defaults that were contrary to the preferences of the vast majority of individuals completing the forms. And the result of those defaults was that it was often likely that the form was completed in either a contradictory way or in a way that did not actually reflect the preferences of the individuals completing the form. And I know, Dr. Lawson may be able to speak to that more as well. But in streamlining and simplifying, our goal was to make it as likely as possible that an individual completing the form is expressing their wishes affirmatively about who their agent is, and in the case of the living will, what they would want, in the event that they were unable to make healthcare decisions for themselves. You've already heard about the clinical trial and experimental treatment provision and the importance of those. I think the legislation also takes account of the fact, you've heard about this as well, that there are now a wide variety of types of documents in use by which an individual can express preferences about their care. And it makes clear that an agent or surrogate is required to honor and respect those expressed preferences, whether they're in the living will or in a different document or orally. And a couple of other things about the legislation, it cleans up inconsistent uses of language and inconsistent terms that had crept into the statute, as well as redundancies as a result of prior piecemeal changes. It also allows for the virtual witnessing of advance directives, and while we expect that the vast majority of individuals will continue to sign these directives before 2 live witnesses or a notary, as historically has been the case, the statute does enable those who are not able to do that, perhaps because they're homebound or otherwise unable to assemble witnesses or a notary with them in person, to be able to execute directives with remote witnessing. And that's something that has been happening during the pandemic in other contexts as a result originally of the executive order and then subsequently legislation. And I know those of us in the estate planning field, while it has not substituted for in-person signings, which remain an important and primary part of how this takes place in situations where they're necessary. It's very helpful. And finally, the legislation, as you've heard, updates the surrogacy statute so that those individuals who have not chosen agents, which I think is actually a majority of folks in New Hampshire, will be able to have a person empowered to make medical decisions while still maintaining important limits on that authority. And the same guidance and limitations that apply to agents will also apply to surrogates. The authority of a surrogate will end after 180 days unless the patient is determined to be actively dying, which you heard Gina Balkus testify about earlier, why that's important. And that's up from 90 days in current law. This was a carefully negotiated balance, which the folks involved felt allowed for surrogate decision-making on a short and medium-term basis, and allowing for families to avoid needing to rush to get a guardianship for purposes of making end-of-life decisions during what can already be a very difficult time in one's life and one's family life, but also maintaining the limit on surrogacy so that surrogacy does not become a long-term alternative to a guardianship of the person where someone has not done an advance directive. And the law maintains existing protections that allow any interested person to pursue a guardianship petition, at which point, once appointed, a court-appointed guardian would be able to act instead of a medical practitioner-appointed surrogate. I do want to address some of the questions that I heard come up earlier in earlier testimony and earlier questions. Some of these have been addressed by others, but I think there's a few we haven't really gotten to yet. So one is what appears at the bottom of page 6 of the bill. It's in J5 Roman 4, this idea of treatment against objection. So in New Hampshire law right now, it provides that if one is incapacitated and objects to treatment, treatment may not be given over their objection unless there is an affirmative statement in the advance directive authorizing it. And this provision, which as far as I know is very unusual, I don't know that any other states have this sort of provision, can make it very difficult when you have an individual who has been determined by their physician to be incapable of making medical decisions for themselves and does have an agent acting, but who nevertheless articulates, a verbal objection to, and that could be either to treatment or to the lack of, to a lack of treatment. And regardless, even if those objections are entirely incoherent or not in someone's interests, the way the law is worded right now, they have to be honored or respected, and then the only real option is to go to court and get a guardianship, so someone has the power to override those. In addition, because of that, there are a number of facilities in our state, particularly facilities that treat patients with severe dementia or that have memory care units, who, if there's an advance directive and the no box is checked, meaning no, I do not authorize treatment over my objection, will require the agent to go to court and get a guardianship before they'll admit someone under the agent's authority. Their reasoning being, well, if the patient says, take me home, I want to go home, I want to sign myself out, the agent would have no ability to consent to the individual staying in the facility. And so a lot of facilities are not willing to take that risk, even if that's not a present issue. I have found in my practice when I explain to folks the implications of this and the implications of this question, I'd say well over 80% choose to allow treatment over their objection, meaning to allow the agent to make the final decision. And so, the agent under J6 is required to listen to the principal, required to adhere to their wishes, however expressed in writing or orally. And so we felt on balance, there was adequate protection for patients' wishes being honored, while still not putting individuals who need medical care and their agents in a difficult position. That said, I heard testimony saying, well, no, you don't even know that now when you sign the form, and that is not the case. At the top of page 16 in the disclosure statement, it explains that you can add that back in, that you can put that limit on your agent if you wish to do so. And again, in my experience, it's well under 20% of individuals who want that limitation in there. We heard questions about removing the rights of hospitals and facilities to opt out. And I think, as was pointed out, at both the bottom of page 9 and at the top of page 10, there is language in the bill that acknowledges, how that works, requires transfer both for the individual practitioner at the bottom of page 9 in Roman 2, and then in what will be new Roman 3 on page 10, addressing the healthcare provider or residential care provider being able to opt out. There was a question, I think, from Representative Cushman about, will people need to complete new forms? 137J16 in the existing statute, which is not being amended by SB 74, referring to documents executed prior to enactment, says nothing in this chapter limits the enforceability of an advance directive or similar instrument validly executed under prior New Hampshire law. That was considered and deliberately left in so that we recognize that, there's going to be, even if this bill passes, the old form will probably remain prevalent in circulation for at least the next decade. And we want to make sure that, individuals who have done these forms in the past and expressed their wishes will obviously continue to have those wishes honored, and they can do a new form if they wish, but no one's going to have to, rush to their doctor or their PCP to do a new form, the day that this law passes, if it does. I believe that, and then finally there was Representative Merchant, your question about the living will and could it be amended. I don't want to speak for the broader group. I'd certainly be willing to be part of a dialogue about that, and I think that would be helpful. The one thing I can say is we did consider having a separate section of the form relating to experimental treatment, given the various options that the statute gives, and ultimately decided against that for the reason that the medical practitioners in the group advise us that this is a fairly rare circumstance when this comes into when this becomes relevant for an individual, and the more questions, the more sections we add to the form, the more confusing it becomes, the less likely it is somebody successfully completes the entire form. And so our goal was really to keep the form as simple as possible to maximize the chance that someone can complete it and complete it accurately and reflecting their wishes, while putting in the disclosure statement itself, which is required to be with the form, the various other options and explanations. So on page 16 in the disclosure statement, it says the law allows your agent to put you in a clinical trial or to agree to new or experimental treatment, and states the conditions that are the default, and then says you may change this by writing in the form, and then there's two options below. And so, rather than having that be a separate section of the form, that's how we decided to address it. I do see, Representative Merchant, what your comment about why, in the living will, having that language in A might be inadvertently read to limit someone's ability to consent to experimental treatment. I would point out the living will is not legally binding. It's designed as guidance, and I do think the law, the statute itself, and the disclosure form makes clear what the agent's authority is in this respect, but I'd certainly be open to a dialogue about, can this be made even clearer? Because obviously bringing in questions from folks seeing this for the first time, it's always helpful to step back and reconsider, could another tweak be made? Because, we tried very hard and we spent many hours, but I'm sure we didn't get it done perfectly. Thank you for listening, and I'm happy to take any questions.
Thank you, Mr. Holman. I think it's very helpful for the committee to know the time and effort and compromises that went into preparing this bill. Do we have questions for Mr. Holman? Go ahead.
Thank you, Chairman. Mr. Holman, thank you for taking my question. This is a really simple one, but these are the kinds of things we get asked. Earlier, people spoke to workshops that have happened where people can go to and get guidance on how to fill out these forms, and they want to just fill them out right then and there. And but this is a legal document. What if a person shows up at the hospital because they haven't gotten to the lawyer yet, turn it into a legal document, but they've got it all written out by hand? Would that have any standing at all?
Yes. I mean, the document needs to be either witnessed by two individuals or notarized. So something that someone has purely handwritten, wouldn't qualify legally as an advance directive. That said, if they had an agent or a surrogate appointed under 137J6, there is a requirement that the agent or surrogate make healthcare decisions in accordance with their knowledge of the principal's wishes and religious or moral beliefs as stated orally, in writing, or otherwise communicated by the principal. And then if those wishes are unknown, in accordance with their assessment of best interests and in accordance with accepted medical practice. So I think in that case you refer, if I was, I don't generally advise hospitals, but if I had a hospital at my client saying, can the agent honor this? Can this be honored? I would say absolutely, because that's the principal's communication, as long as there weren't questions about authenticity, but that's the principal's communication, and under J6, the agent or surrogate would need to honor it.
Thank you. And that surrogate can be assigned by the caregiver. I'm looking for the list of possible people that they could pick from, starting
Page
with
25.
Yeah, starting with closest relatives. So, say cousin Sally knows me really well and saw me write this out, and we talked about it. And the doctor said, "Hey, she seems to know you well. You seem to know her well. You could be the surrogate." And then it would have some impact then for the surrogate to say, "No, look, we've discussed these things and written them down. It just wasn't signed by an attorney or a notary."
Exactly right. So if there was no valid appointment of an agent, no formal document designating an agent, then the surrogacy statute would come into play, and you have that order, that hierarchical order in the statute, and then once that person is designated formally as the decision maker, they are then charged with adhering to, all of those things I referenced in J6. So yes, I think practically, if this person is the closest person and there isn't a higher level, spouse or an adult child or parent, who can come in, then and we get to that level, and it even goes down to friends. So it doesn't have to be even a relative. That the idea of the surrogacy statute is that person can then, be the one who makes decisions. In the event of family conflict, where you have more than one person who is claiming to speak for the principal, that's when you're going to have to go to court and get a guardianship. But let's say even in the situation you described, say you had someone who was higher up on the list who didn't, who the cousin said, well, they don't know them as well. I should really be the decision maker here. The cousin could still go and petition for guardianship and argue to a probate judge that really they should be the decision maker, not the adult child who hasn't been involved in their life for 20 years. And then that's a decision that, the medical practitioner is not going to be in a good position to make, but that's why we have probate courts and probate judges who can assess and make, a decision that they feel is in the best interest of the individual.
Thank you for clarifying that.
Very good. Are there questions for Mr. Hellman?
Yes.
Representative Cushman.
Thank you. I have a question on the concerning overriding a patient's wishes. So you gave the example of someone who has advanced dementia and that the need for this override to be in the bill came from policies of memory care units and the like, requiring family members to go get a guardianship. I have a little trouble with taking that up because I sort of think that it should be required to go to court to override a patient's wishes. Could you expound on why you would believe it's appropriate to not require a more serious and thorough investigation and determination of that guardianship?
Yes, thank you for the question, Representative Cushman. I think the way I would think about it is, from my perspective at least, is, what is the way that the legislature can best honor individuals' preferences? And in my experience, the vast majority of individuals who complete an advance directive do so because they want another individual to be able to make decisions for them, a trusted family member or close friend, to be able to make decisions for them in the event that they've been determined that they're not able to make decisions for themselves. So I think there are a number of safeguards. One is that the whole advance directive is not in place unless one's practitioner has determined, based on, the prevailing medical standard, that this individual does not have capacity to make decisions for themselves. So if someone has capacity to make decisions for themselves, it doesn't matter what they've put in the document. They're the ones making the decisions. But if we're in that box where the document has been activated and an individual is making decisions, the vast majority of people want that individual to be able to make decisions for them, even contrary to what they are expressing at the time. For those people who do not feel that way, who say, no, I do not, it makes me uncomfortable, I do not want to give up that level of autonomy, even if a doctor's determined that I can't make decisions, I don't trust that, I still want whatever I express verbally to be honored, the form and the law still allows for that. So they can still put in their durable power of attorney for healthcare. No, my agent cannot make decisions over my expressed objection, or, if I articulate the decision that I want, even if I've been found incapacitated, my agent can't make a decision to the contrary, without going to court. I'd say finally, even for individuals who have expressed, the view that they want an override to be able to happen, in what I'm deeming sort of like the 80% of New Hampshire folks that I've interacted with, if you then got to the point where they felt like their agent was acting contrary to their interests, they or another family member could always petition the probate court. I mean, if they have capacity, they could revoke the directive. If they didn't have capacity, and again, we're sort of assuming that if it's activated, that at least their doctors determine they don't have capacity, either they individually or with the assistance of a family member or friend, nevertheless could petition the probate court to have their directive revoked, or have somebody else appointed. So to me, it's a question of both preserving autonomy for the individuals who want to make that decision, while also not putting the vast majority of people in a position where, like, they've named an agent and they think that agent can make decisions for them, but in fact, there's this limit that they didn't really understand or contemplate, and now the agent has to go to court and get a guardianship.
May I have a follow-up?
You may have a follow-up.
Thank you for answering my question. I believe that you alluded to that it's disclosed in the disclosure, but that they have the option to explicitly state that they don't want their desires overridden by an agent. But is there, I believe this bill, and so can you tell me if this bill removes the requirement to make sure that the person signing reads the disclosure? Yeah,
so I think I understand the question. So just to point out, for clarification where it is in the disclosure, it's the bottom of page 15 and the top of page 16. The bottom of 15 says, you know, with few exceptions, your agent will make decisions for you when you're unable to make them for yourself. And some people do not want to allow their agent to make some decisions, and you can write in. And then the last write-in item, which is lines 5 to 6 on page 16, says to agree to treatment even if I object to it in the moment after I've lost the ability to make healthcare decisions for myself. So I just wanted to clarify that that's where it is. Getting to the specific question, you know, and then the form itself says you can write in limits. And I'm sorry, now that I went on the tangent, I forgot your specific question. Do you mind articulating it again? I'm sorry.
Okay, I know that the form itself says you can write in your own instructions, but it doesn't say explicitly you can write what the disclosure mentions. And is there a provision in the bill and on the form that requires the person signing the form to read the disclosure?
I understand. I get the question. So the current statute requires that the disclosure be signed. We removed that provision in the proposed bill, and I'm on page 13, lines 27 to 29. So we maintain the provision saying that every person wishing to execute an advance directive shall be provided with a disclosure statement, but remove the provision saying that they're required to sign a statement acknowledging that they've received it. And the reason why we propose to remove that is because you know, we were trying to eliminate barriers to completing and making a valid advance directive. And under current law, an individual not only has to sign the disclosure statement, they have to sign the durable power of attorney for healthcare, and they have to sign the living will. So in theory, there were, you know, 3 separate places an individual had to sign, and in the effort to make the document easier and not have sort of artificial legal barriers to completion, we said, you know, there's one, we're going to have one signature place. So there is not a separate signature place for the disclosure statement, but there is still that affirmative requirement that the disclosure statement accompany the advance directive.
Could I speak?
Who is this?
This is Bob Wells.
Mr. Wells, I will recognize you later if you raise your hand, but we don't let the public ask questions of members of the public. That's not the way the committees are run. Do you have any further follow-ups, or are you done?
I'm just wondering if the sponsors of the bill, I guess it's for the sponsor, so.
Thank you. Any further questions for Mr. Hellman?
I guess I would just add, if I may, Representative Cushman, I mean, certainly, you know, as I said, there were a lot of decisions and compromises that went into this, but if a group does get convened to discuss some of the concerns that have been addressed, and you feel that having a separate signature place for the disclosure statement is something that would allay that concern, you know, I think certainly all these things are open to discussion, right? You're the legislators. It's ultimately up to you, you know, what you wish to happen. So I just wanted to give the answer as to why we made the decision, but not to say that, you know, the concern isn't a valid one or one that, you know, could be considered or addressed.
Take extra time.
Thank you very much. Seeing no further hands, Dr. Lawson, Representative Weber, you have a question.
My question is simply to ask the chair at the appropriate time to recognize Mr. Wells, who is a member of this rotating panel, to give his answer to the question that was just posed to Mr. Hillman, because he also had some clarification, I believe.
The chair's intention was to recognize Dr. Lawson and then Mr. Wells, so we will get to that.
Thank you.
Are there any further for Mr. Hellman before we move along?
Thank you. And I think I can answer that question as well, or maybe what Bob was going to suggest. But I did introduce myself when answering questions previously. I did want to. Sorry.
Go ahead, Dr. Lawson. You're supposed to wait until you get recognized by the chair.
Oh, I apologize.
Very good. You may, I didn't know who was speaking because somebody just started in before I recognized you, but you may continue.
Thank you. Yeah, so Dr. Lawson, I practice at Littleton Regional Healthcare in a number of roles and have sat for its existence on the Healthcare Coalition. I did want to just recognize before the committee, Attorney Kate Hanna, who's spent exorbitant amounts of time, probably in the range of 50 hours volunteer time on this, and is unable to be here due to personal health reasons. But I just wanted to recognize her for the record and her incredible institutional knowledge and expertise and participation in this. We all, Ben, Kate, myself, and others have spent exhaustive hours addressing this with multiple stakeholders, going word for word, really through the law multiple times. Ben addressed most of what my testimony was focused on, so I will not duplicate that, but I did want to focus on a couple things. Number one, Representative Cushman, in regards to an answer to your question, the bottom of the DPOA statement specifically says, please review the disclosure statement that is attached to this advanced directive for examples on how you might limit your agent's authority. And we felt that in combination with the inclusion or necessity to include the disclosure statement would be adequate for people who may want to have some limitations or have some questions in regards to how they might limit the durable power. It's important to understand that all the issues around experimental treatment, around treatment against objection, the override clause you're referring to, these are all things where you're not making specific statements about what you want, you're making specific statements about the authority you're giving to your durable power, whether the durable power is going to be able to allow certain things or not. It's really important to understand, and Peter Ames may be able to state this year's data, but of people who present to hospital, it's well under 50%, like high 30s% who have an advanced directive. The majority of the people we care for do not have an advanced directive, do not come in, and often come in without capacity. And the law needs to address those people in respectful ways that can respect their best wishes as best we can understand them. And as an example, the treatment against objection clause, when the default is that they have to sign to allow treatment against objection in the moment, that provides an incredible barrier to this wide range of exceedingly demented, advanced dementia, patients suffering from advanced dementia who present, do not have an advanced directive, are swinging at the nurses, pulling out their IVs, highly agitated. And this is every day in the hospital. This is not an unusual thing. This is every day. And to not be able to treat them and to not allow the family to okay us giving medication to treat their agitation or to help calm them is abominable. It's horrible. We can't legally do it. Honestly, we do it anyway. We take the legal risk, but it's definitively against the law as it's stated. And if we were to replace that default to force signing to treat against objection, we would be back in that state. This is one of the most important improvements, in my clinical opinion, in the law, is that adjustment to make the default the allowance for the durable power of attorney with the medical team to come up with the best possible approach to challenging situations, as opposed to not allow any treatment against objection. Our multiple psychogeriatric patients who suffer from dementia and paranoia, they cannot be transferred to specialty care, to a psychogeriatric unit, if they have not signed that. So that's over 50%. And actually, most of these folks who suffer from these conditions don't fill out advanced directives for what should be obvious reasons. They don't have the support, they're generally indigent, they are suspicious to begin with. And they cannot be treated in a psychogeriatric unit. They end up sitting in a regular, like our critical access hospital, often for months at a time, because we can't transfer them because they are saying, no, I don't want to be transferred, despite the fact they're suffering from an advanced psychiatric condition that's profoundly impairing their capacity. So these are, hopefully that explains sort of the reason for adjusting that treatment against capacity default. That is not, I've read at least 50 different advanced directives from jurisdictions throughout the world and most of the US states, and this is very specific and only in New Hampshire. I understand live free or die, but unfortunately, this, in my opinion, clinically pushes it to a state that harms far more than helps. So that's kind of my point on the treatment against objection component. Speaking to Representative Layout's concerns, I had trouble understanding them, and some of them were misrepresentations. But in existing law, the durable power of attorney has the authority to override the living will the way it is now. That's very specific in present law. And so this document, does explicitly try to simplify the situation. Our goal here primarily is to give people the opportunity to get past the barriers to at least completing the durable power of attorney, so they can at least decide and speak with who they want to make decisions for them, and to put down some specific statements about their wishes. But we expect that other forms, as Representative Weber referred to, and there are numerous available, where they can be assisted to go into much more complexity and much more depth about their wishes in specific circumstances. The moment we add those to the durable power of attorney form, and I would be strongly against adding the experimental treatment options in the actual form, the moment we do that, it provides a tremendous barrier. Experimental treatment for people who've lost capacity outside of a pandemic situation is exceedingly rare. And having to go through that discussion, if you're filling out an advance directive with a patient, and the complicated possible options, is going to provide a significant barrier to completion when it's something that we very rarely encounter. So that was really focused on the pandemic and situations of that sort, where experimental treatment or yet to be unproven treatment may be appropriate and meet the standard of care. So that kind of covers the stuff that hasn't already been covered. I wanted just to refocus on the relevance and the importance of J6 and the strong belief of the committee that we have to do everything possible to respect and to honor a patient's values and wishes. That's the goal here. And this adjustment and improvement, significant improvement, in my opinion, in the law does that. It's been a process of tremendous compromise, of tremendous work on the part of a huge number of people for really the better part of the last year. And I really appreciate your time and the ability to speak, and would like to answer any questions or certainly be available offline by email or otherwise to discuss, the clinical or medical aspects of it. So thank you for the time.
Thank you, Dr. Lawson. Representative Weber, did you still have a question, or you intended to lower your hand?
I guess I'll go back to it. Again, it was the treatment against what the patient is declaring when the patient may not have capacity to make for decision making. And would this address, am I correct in thinking that this would address the situation that I encountered when I served as guardian for elders that I had not known previously, but who needed a court-appointed decision maker? And if I spoke to one of those people and asked her, do you want an operation? She would say, no. So that's declaring that she doesn't want it. If I asked the question, Dr. Smith says you need an operation, is that okay? She would say yes. And then if I asked, so you do want an operation? She would say No. So that gets us into a terrible bind. I mean, in that situation, I simply had the decision-making authority, but I was bound even then to follow her wishes as best I could follow them. So does this not resolve the problem of the answer you get depends sometimes in the real world on how you ask the question?
Yes, I think that's correct, Representative Weber. Just to clarify, it's not may have lost capacity. It legally the patient has lost capacity. Yeah. They have to have been formally assessed, and that has to be a formal process by which they've been deemed to have lost capacity. So this, this is a tremendously confusing, part. This is to go through this with patients every time you fill out an advance directive is incredibly confusing, and people get caught up in this. This only refers to people who have been deemed to have lost capacity. So you're out of it. You cannot understand your medical condition. You cannot understand the options for treatment or the potential consequences of choosing those options. That has been formally assessed. You've lost it. You don't have that ability, right? That's the preset situation. This doesn't apply except in that situation. It is in the moment. It doesn't refer, as I understood Representative Leah to suggest, to statements made in the past when you did have capacity. It only refers in the moment to the specific actions, verbal, physical, otherwise, that the patient may be showing in their state of loss of capacity. And those statements are often confused. They're often contradictory. They often change minute by minute, hour by hour, day by day. And so it's very, very difficult to interpret. And absolutely, we all know that individuals, particularly loved ones, can significantly change what people who are confused say by the way they ask the question. And that can happen. And I believe that the present setup of the default being to allow treatment over objection after loss of capacity, with the option to say otherwise with a limit on the durable power, I believe that puts us firmly in the best position to honor wishes. I encounter frequently situations where that has not been completed by those who either haven't completed an advance directive or didn't sign that component of Section B of the present advance directive, where patients are suffering, where either practitioners are forced to do an illegal act or they follow the law and the patient suffers tremendously to the shock of the family members of why the clinical team is not intervening. I encounter that, that comes up frequently. The alternative case where there is, a situation of someone who has purposefully not signed it and we don't act, according, that is definitely a concern. It's definitely a risk. But again, go back to J6 and focus on J6. That's the core. We keep referencing back to it because of how important it is that we do our best as a team of people caring for someone to honor their wishes as best we could. And if we believe that not responding to their objection after loss of capacity is the best, that's how we would proceed. The present law allows that, no matter what the patient has signed. Sorry, the present SB 74, allows that, whereas the previous law does not, that we're presently under.
Thank you for that. Are there any more questions for Dr. Lawson? Representative Merchant.
Thank you, Mr. Chairman, and also thank you, Dr. Lawson. It sounds like the critical piece here is having the conversation with the patient while they're still able to comprehend their decisions. As I listened to Representative Weber being appointed by a court, the more documentation in some way along the way that the patient has consented to whatever we're talking about, it sounds like it's easier on the legal system. It's also easier on the medical system. So is that a fair statement of trying to ascertain from the patient as much as possible what their options are and what they want to do with those options?
Yeah, sorry, you're, Representative Merchant, you're breaking up a little bit there on my line. But I understand your question to be is it not easier on the court and the clinical team if the patient has had conversations beforehand that have stipulated their wishes?
That's correct.
Yeah, absolutely. And this balance of, for sure, and the balance of how much to emphasize those conversations in the DPOA form, right? Versus to look at other more effective venues and strategies is a somewhat challenging, discussion. And that we certainly came down on the side of making the DPOA form as simple and straightforward and easy to complete as possible with the best possible defaults and options for the form to be a venue for that extensive discussion, but not force that form to be the venue for extensive discussions. Does that make sense? So, our goal is to be able to get more like, 75, 80% of more people completing at least the DPOA form and giving an opportunity for them to stipulate at least basic wishes, at least who they want to make decisions for them. And an opportunity at that time to stipulate much more, but not place barriers that would significantly limit the chance that they're going to fill out this form. And then the other avenues, whether it be 3 wishes, the Catholic document, which is an excellent document in my opinion, and Conversation Project, 5 wishes. There are numerous different online free, strategies to stipulate wishes that would be adhered to and can do a much, much better job than trying to enforce it through a legal avenue of a DPOA.
Thank you.
Are there any further questions for Dr. Lawson? Representative Cushman.
Thank you, Mr. Chair. I am Dr. Lawson. Thank you for taking my question. I understand that getting a guardianship in place is important for these advanced dementia patients, and it's better to have everything in place beforehand, and it can be challenging to do it after the fact that someone is in an advanced stage of dementia. However, this bill doesn't, if this is the heart of the bill and it's the core of the bill, it's not really explicitly stated that way, and it leaves it open to apply to others besides those who have advanced dementia. So I'm wondering, was there any discussion about making it specific to advanced dementia? Because another concern is if a person has, say, delirium from an acute infection and it's misdiagnosed as dementia, and then the physician and their physician's assistant, who's pretty influenced by the physician, and now they're given authority under this to be one of the signers to say that someone's without capacity to make decisions, then, and that person objects to something, I just see a problem here, and I wonder if that was addressed and the specific language to dementia was considered.
Yes, thank you, Representative Cushman. And in fact, in the living will section, we had specific language around dementia, but in compromise with certain subgroups, that language was specifically removed as an option, about when you would or wouldn't want life-sustaining treatment as an option. Your point is well taken. I do believe the law would not allow a PA under the authority of a physician to be one of the stipulating. I believe it specifically suggests that the physician assistant isn't under the authority of the physician, just to be clear on that, or at least it did in the last draft I had. So I don't think that situation could occur, but I would have to be a physician assistant who's not under the authority. So we specifically discussed that at some length too. Yeah, and there are situations absolutely where there could be misdiagnosis, where a group of clinicians, as well as and including family members, may make a mistake. It absolutely happens. But Again, it's sort of a balance of benefit and risk. So we did look at this in regards to specifically dementia. There was talk even about a separate dementia directive. Again, I would suggest, and our plan was really to allow all those to come under J6, so that, you know, there is the dementia directive. You know, you can pull up online. I think that's exactly what it's called, the dementia directive, that allows for this kind of decision making, along with the other tools. It's one of the good tools, but not to embed that specifically in the law. And it was challenging because, as Bob Dunn has testified, there are significant stakeholders who strongly believe that we should not be separating dementia in any way in regards to how we address, you know, decisions around these issues. That a dementia patient should be treated exactly the same, no matter how advanced their dementia may be. So that was a specific compromise. Trust me that, like, we've been through, and I don't mean that, very much respect all the representatives and you know, input on this and statements, but all these things in excruciating detail have been discussed at length.
Thank you, Dr. Lawson. We appreciate that. Are there any further questions for Dr. Lawson? Seeing none, I said earlier that I recognize Mr. Wells. If he has something further to say, he may do so.
He's muted.
He's muted, and if he doesn't wish to say anything, he's certainly free to not say anything.
No, excuse me, sorry. Again, my name is Robert Wells. I'm a senior director in the Trust and Estate Department at McLean Middleton. I've been practicing in this area for 50 years. I'm also the past president and member of the board of directors of the Office of Public Guardian, which office handles the great majority of appointments by the probate court to deal with individuals with disabilities. Historically speaking, I think it's extremely important for this group to know that before we had that provision that Ben so carefully explained about the treatment against objection, we didn't have it. At that point, I worked with then Judge Marr, who was the chief judge of the then called probate court, to add this provision. And the reason it was added is that the court was being absolutely overwhelmed with emergency guardianship proceedings because there was no provision for acting against someone's objection. So what this bill does is expands that to make sense out of avoiding having to go to a court for an emergency guardianship when a person has named someone that they trust to make those statements, again, against objection. And what are we generally talking about? We're generally talking about people in a nursing home who refuse to have a flu shot, refuse to have a COVID shot, who don't want to have some type of treatment. If they don't have it, they would be required to move away from the home. So what we have here is a very practical adjustment to our statute to allow greater authority for an agent to act to avoid proceedings in the court. What is also important to know is for those of you who deal with the probate court is absolutely overwhelmed with work and lack of staff. And you impose additional obligations on them, they are not able to perform as we would hope they could perform. That's not your fault. That's a failure of proper investment in our court system, from which we all now suffer. So I think it is extremely important to pass this bill with this provision about treatment against objection. I do not believe it will in any way impact a negative group of people in any way, shape, or form. But historically, we need to understand why we have what we have and why we need to have this additional provision.
Thank you, Mr. Wells. Are there any questions from Mr. Wells? Seeing none, is there any other members of the public who wish to speak? The only hand I see up is Dr. Lawson's, and he just spoke. I think he forgot to lower his hand. Okay, he just did. If there are no other hands raised, I will now close the public hearing on Senate Bill 74, and the committee will be in recess until 1:30. Thank you, everyone.
Yeah.
First.
How much longer do you have?
No, this bill is a monster. You're all set, you're on duty. It'll be good here.
Yours?
Thank you. My checklist, make sure I got it.
Right.
John Williams on this.
Yes, he was on there.
He's what?
Yes, he was on here already. Do you want me to give him?
Yes.
I don't think you went to confirm.
I'm a co-sponsor.
Well, there's no chances.
So much.
All right, here we go. Okay, I'm going to open the hearing on 162, but before I do, and lest I forget, on the previous bill, Senate Bill 74, we had 25 sign up in support, 3 sign up in opposition, and no one declared neutrality. On the bill before us, 162, we have 5 signed up to support, 6 signed up in opposition, and no one in neutrality. Over the lunch hour, besides testifying on a bill of mine, I met with Aaron Goulet from the Speaker's office, and he has said that we can have Monday, May 17th, for our next meeting, which I hope will be simply only executing bills. So I'm opening the hearing on Senate Bill 162 FN, and the chair calls on Senator Bradley to present his bill, please.
Good afternoon, Mr. Chairman and members of the committee. Hope everybody is doing well this morning. Jeb Bradley from Wolfboro, and pleased to be here and sponsor Senate Bill 162. I was asked by the Department of Health and Human Services to sponsor this legislation, which makes a number of technical changes to various laws. Some are broader than others. John Williams and his team will go through the bill section by section and give a delineation for you. Let me just hit a couple of the highlights that the Senate made changes to. And by the way, the Senate went through my committee, Health and Human Services, then it went through the Finance Committee, and the final vote of the Senate on the bill was 24-0. So the first issue that the Senate looked at was Section 5, which is on the first page of the bill, near the bottom of that page, the Emergency Service Plan. This is a requirement, or in the original bill, of licensure for both physical and behavioral health by hospitals. There was a lot of discussion in the Senate about how to do this and make sure that there was collaboration between hospitals and the Department of Health and Human Services. And so, as you can see on line 28, we called for a plan to be drafted that made sure that there was collaboration between the parties, the hospitals, and the department. So there are a number of sections dealing with therapeutic cannabis. I think Mike Holt will outline those. These were a request of the department dealing with therapeutic cannabis. Skipping ahead, there was some question raised in the Senate on page 10, section 48, about the interstate compact for placement of children. I just want to stress this is not a new law. This is existing legislation that has been repealed and reenacted. And I think when folks understood that, any questions disappeared on that score. There was some discussion, jumping ahead to page 28, section 53 and 54, about the auto injectors. The camps came to us and we added the language that you see at the bottom of page 28, which shall be reasonably accessible. And that's replicated elsewhere in the bill. Section 55 and 56, these are important issues for the Division Children, Youth, and Family. And I'll just leave it at that and let Mr. Williams and others talk about it. On page 32, starting in line 14, the Medicaid work requirement, there's been a lot of discussion about that. Right now it's under suspension due to an injunction in federal court. So this language just clarifies that if a court holds it's invalid, if the Center for Medicare and Medicaid Services withdraws approval, then the program will be suspended. And that just clarifies what could in fact be the case if it gets changed in Washington. Two other things. Section 71, which is the next to last section on page 35, page 35, excuse me, was added as a result of a discussion that occurred in Senate Bill 140, which was Senator Rosenwald's bill about the possibility of licensure for case management. And again, like with the hospitals, if there is going to be a discussion about licensing case managers, we wanted to make sure that everybody had a seat at the table, and that's what Section 71 does. One other thing that I would add that did get dropped from the bill was a section that would have required mental health providers to provide transitional housing. There was a lot of controversy about that. We dropped it because of a commitment that the department and Commissioner Shibinette have made to deal with that in terms of contracting. And I believe that there will be more information coming out about that shortly from the Commissioner's office. So Thank you very much, Mr. Chair, and happy to answer your questions.
Any questions for the senator? Representative Marsh.
Yes, thank you, Senator, for referring before our committee and bringing this bill to our attention. My question refers to sections 12 and 13, which you just referred to.
Page.
That's on page 3. And what this does is it strikes out language from one of my bills a few years ago and replaces it with the language that this chapter shall not apply to individuals who have been issued a registry identification card and so forth. My read of the new language is that this means that youth who've been issued a registry identification card will now legally be allowed to go and buy cigarettes at the corner store. And is that your intention? I rather doubt that that's actually your intention here, but I wanted to...
Not my intention, and obviously that's a question for Mr. Williams and others when they testify.
And as a follow-up, Mr. Chairman?
Follow-up.
Would you be dreadfully upset if I put in an amendment to remove sections 12 and 13 from this bill?
Probably better to try to rewrite it to make sure that the department's intent is captured, but if there's no other way to do it, then I would agree with you.
Thank you very much.
Any other questions? Representative Weber.
Thank you, Mr. Chairman, and thank you, Senator, for taking my question. Just to be completely sure that I understand, on page 32, lines 14 to 17, if we pass those as they stand, then even if it is court action or some other action that we here in New Hampshire cannot control, if any entity invalidates the work and community engagement waiver, then the whole program is suspended. Is that correct?
The work program, not Medicaid expansion, the work program.
Okay, the workforce program. Thank you for clarifying that. That relieves my mind considerably.
Well, I would hope so. Yeah, you had me there for a minute.
I was really worried that the whole thing was going straight away and I did not read it quite carefully enough. Thank you.
Any further questions? Thank you, Senator.
Okay, thank you very much.
We get past them.
I had a nice conversation with Mr. John Williams recently, and he told me that he has field tested a walkthrough the bill in the Senate, and it made things go very quickly and very smoothly. So, having tried it off Broadway, the chair now recognizes John Williams to walk us through the bill.
Mr. Chair and members of the Health and Human Services Elderly Affairs Committee, for the record, my name is John Williams. I'm the Director of Legislative Affairs, and I come to you today in support of the department requested omnibus bill. And it is a thoughtful approach to bring together the department's entirety of its policy legislation in one bill. For those of you who are in this session or part of the membership of the legislature back in 2019, you may recall pre-pandemic times that we brought forward SB 289, which was the department's omnibus bill at that time, and it worked exceedingly well in terms of the use of your time and energy. So, Mr. Chair, with your permission, if we could have Researcher Dyer, Ms. Dyer, bring up the text legislation, what we will do is give a high-level walkthrough of the pieces of Senate Bill 162, give some context, and also I have with me several other members of the department that I will call on to provide you with background information on the various sections of the bill. I also wanted to thank Senator Bradley for his graciousness in bringing forward legislation, and also for the work they had done in the Senate to actually get a very good bill in front of you here today. So if we can enlarge the screen just a little bit, Ms. Dyer, for those of us who are a little bit challenged with reading glasses. Fantastic, thank you. So section 1 of the bill is a series of 9 different sections throughout the legislation, and they are a cleanup of dedicated funds that are administered by the Department of Health and Human Services. There is a joint legislative committee on dedicated funds. They've been in existence since around 2014, 2015. And on a 5-year basis, every agency has to go through a rotation to justify their various dedicated funds. One of the things that will be important to understanding all of these 9 sections is that there are 2 parts that are essential for a dedicated fund. One is you have to have a fund in the enabling legislation with the agency. So, and in addition to that, you have to have a corresponding fund with the Department of Treasury. So I'm just going to repeat that again for clarity, that you have to have 2 pieces of legislation for every fund. One within the enabling legislation for the agency and program area, and then a corresponding fund within the Treasury account. And those funds in the Treasury account are found under RSA 6:12. So in section 1 of the bill, where you see application for receipts, this is essentially creating the Treasury account necessary for the funds that are identified on line 3. And as you see in the lines, the bold italics is the new sections that are requiring this. The first one under 45732B, that involves a recently passed legislation that was not requested by the department, but certainly one that the legislature passed. And that was involving the special marriage efficient license. So again, that's a special marriage efficient license. And respectively, the underlying bill failed to have the linkage with the second required account within the Treasury Department. And therefore, we're bringing a technical cleanup so that it actually has a place for the Treasury to receive those funds. The next one is from legislation from 2015 that involved what they call the Joshua Law. It's embedded in the Criminal Code of New Hampshire, and it involves violation of protective orders, and that a portion of those fees collected as a result of that have a place to be deposited. Again, we're not creating the fund, but we're just trying to find a home for it within the Treasury statutes. And so you'll see eventually at the very end on line 4, it makes reference to the existing fund that is actually, when we get to, I believe, it will be in a later section of this bill, you'll see that we made a corresponding change to link up those funds that you find within the 173B, which are the Domestic Violence Coalition funds that are administered by our agency and provided to the coalition. So in Section 2 of the bill, you'll see also the exact same thing happening, except for these are funds that are housed within our Division of Public Health Services. We have our radiological health that are identified in RSA 125F, and then we have our shellfish, such things as clams and other shellfish that are identified in 143-22A. And then we have a corresponding piece that comes back to our Food Protection Services licensure. So again, they're just linking up all of these funds and fees that are being collected into a specific dedicated account. Those funds exist. This is just creating the Treasury account to go along with it. So moving along to Section 3 of the bill and Section 4, these relate to human resource items within the department. Section 3 is building on the progress that our agency has made over the last 4 years to identify unclassified positions within the department to make sure that our working and legal titles align. Believe it or not, at one time we had a information systems director who was identified in statute as a dentist. And so we needed to clean up so that the titles within our agencies align with the actual people and the work that they do. So in this occasion, we're seeking an amendment to the specific unclassified position in the GD grade for a Medicaid enterprise development. And that staff would work directly with Henry Lippman within his agency. Section 4 of the bill deals with compensation of certain officers also under the same statute that deals with unclassified positions. And it is the vision of Commissioner Chivinet to take away the specific qualifiers for the existing commissioners so that you'll see that we would be removing from the 3 associate commissioners that we have within the department, we would take away the qualifiers are at the end because the goals here are for greater efficiency in government to allow the commissioner or any commissioner to be able to align nimbly those particular associate commissioners were needed and to make those adjustments very clearly. And so the descriptors that were added within the last 5 years somewhat limit and hamper the department's efforts to have flexibility to address those needed resources as directed by the commissioner. So on line 15, you'll see that we strike the extender and it carries on to line 16 of Human Services and Behavioral Health. That leaves us with the Associate Commissioner position. The second of 3 Associate Commissioner positions was of Operations. We're striking that. And then you'll see on lines 19, the Department of Health and Services Commissioner for Population Health, striking that. Now, there was a Scribner's error already in existing law that they had provided for an additional 2 commissioners' positions within our agency. So we need to clean up and make sure that it reflects accurately the 3 associate commissioner positions within our agency, and therefore striking the Scribner's errors for a 4th and a 5th associate commissioner position within the agency found on lines 21 through 24. So, Mr. Chair, with your permission, if I could bring in Attorney Melissa St. Cyr, who's our Chief Legal Officer for the department, and she is prepared to provide commentary on Section 5 of the bill.
Thank you, John. Good afternoon, Mr. Chair, members of the committee. For the record, my name is Melissa St. Cyr. I'm the Chief Legal Officer for the Department of Health and Human Services. As for Section 5, the department had asked for legislation to maintain or obtain parity for mental health and physical health in our hospitals in New Hampshire. And the original language just required that both physical and behavioral health be considered and offered in emergency when somebody arrives at the emergency room. And Senator Bradley, and working with other stakeholders, we changed the language to allow for the parties to get together, the hospitals, the department to get together and make recommendations for future legislation to help obtain that parity, that mental health parity. Thank you.
And Ms. Dyer, advancing to Section 6 of the bill, this section and 2 other related sections identify a much needed position within the agency that's already in existence, which is a bureau chief that would be with the emergency preparedness and response within the department. And so what this Section 6 does, and then 2 other related sections to the bill, is to allow the department to get the best qualified candidate. And when I say that, in terms of the recruitment process, we may be looking for individuals who are either in emergency services under the Department of Safety or law enforcement. And currently they're under the Group 2 state retirement. So this would allow the department to hire an individual who's currently in Group 2 and to bring them in, and for that particular candidate, if they were to be successful and employed, to maintain their Group 2 employment, which is really critical because there would be a disincentive if they were to come into our agency and lose their Group 2, only to have to go forward with the Group 1 retirement system. It also allows, and not to the exclusion of other candidates, but it allows the department to look very clearly at who's most qualified to fill that position, and whether they come in new to the department and come in as a Group 1, or we find somebody who has experience under the Department of Safety under Group 2, this allows the department to hire that person who has the best qualifications to fill that position without any inherent disincentives for applicants or candidates to seek those positions within the department. Moving to Section 7 of the bill, we have radiological health programs. We saw earlier in Section 1 of the bill that this is the corresponding section that deals with the dedicated non-lapsing accounts as it relates to radiological health. Section 8 of the bill involves the offices of ombudsman. And many of you are aware that within our agency, we actually have 2 different ombudsmen. We have a general ombudsman who represents the public clients and works on their behalf to resolve specific issues that they may be having with the department. And in addition to that, we also have, which is not affected by this section, our ombudsman for long-term care and services. And they're called OLITCO, the Office of Long-Term Care Ombudsman. And they look at issues as it relates to complaints that may be received regarding the treatment of loved ones and care in the nursing facility setting. But again, this one deals with specifically those involving customers, clients of the department. And we wanted to make sure that the statute clearly identified that the primary and singular goal of the ombudsman is to represent those interests. Under current law, however, it also includes the word employees, which causes some confusion because there's already an existing process either through the human resources, through the division of personnel, through admin services for a process for the fair treatment and regular help of and support for our employees, including also our Employee Assistance Program, otherwise known as EAP, for the support. So this is a cleanup to clarify the role of the ombudsman to representing clients within our agencies. The next section, section 9, is a grouping of another project. We had discussed earlier a project within our agency to clean up our dedicated funds to align the funds with the treasury accounts. There is also an exercise going forward within the department to identify all of the department's reporting requirements, including those reporting requirements that are either duplicative of our works, they're outdated, or they're redundant. And so we have brought before this committee a series of requests for repealing some of the outdated reporting requirements that are out there, and this includes one of them in section 9 of the bill. Section 10 of the bill includes the status in the retirement account. And again, this is a corresponding piece that we spoke of earlier regarding the Group 2 as it relates to the Bureau Chief for Emergency Preparedness within the department. Section 11, that is a repeal of the Housing Security Guarantee Program. And we already have a process for funding these programs in a completely different source that's been very efficient, very effective, and therefore we're requesting the repeal of those sections that are not utilized by the department. And included with that is the corresponding dedicated funds within the Treasury statute. At this time, Mr. Chair, if I could ask that Mr. Michael Holt with our Division of Public Health Services, Therapeutic Cannabis Manager, if he could now walk the committee through the sections that involve the Therapeutic Cannabis Program and also to address the question that was raised by Representative Marsh relative to sections 12 and 13. And I just would like to say we look forward to working with you, Representative Marsh, and the committee on any amendments as they may be related to those sections, particularly if you believe there's an unintended consequence as currently written. So, Mr. Holt?
The chair recognizes Mr. Holt.
Yes, thank you very much. My name is Michael Holt. I'm representing Health and Human Services. I'm the administrator of the Therapeutic Cannabis Program. This is department requested legislation, so obviously the department supports this bill. So as introductory remarks, I'll keep them brief, but this bill would make a number of changes to the therapeutic cannabis law. Most of these changes were proposed in the last legislative session and were passed by the full Senate both last year and this year. These changes in large part are in direct response to a performance audit of the therapeutic cannabis program conducted by the LBA in 2019. The LBA recommended that the department reduce burden for patients and caregivers, streamline and simplify administrative processes for applying to the program, and seek legislation where necessary to achieve these goals. This legislation is in direct response to the LBA audit recommendations. To that end, many of the changes proposed in this bill are technical in nature, and I don't plan to go through each minor technical change unless there's a question, but there are some policy proposals included which support the LBA's audit findings and the department's response to that audit. Now, if we go in order of what's on the screen now, we go to a non-LBA audit related matter, and this is sections 12 and 13, which this is a technical change to better align and remove conflicts between two chapters of state law. This is a new proposal this year, which builds on work from previous sessions related to youth access to tobacco products called Tobacco 21. So this bill would create an exception within RSA 126K the Youth Access to and Use of Tobacco Products Law relative to the use of therapeutic cannabis. It establishes that the Youth Tobacco Law does not apply to registered patients and caregivers of the therapeutic cannabis program, nor would it apply to the state's licensed alternative treatment centers, and this is important, with respect to the therapeutic use of cannabis. This chapter-wide exception is necessary because the therapeutic cannabis law allows people under 21 years of age to be patients within the program, and because the ATCs dispense products and accessories that overlap with products that are regulated by the youth tobacco law. So in response to Representative Marsh's concern here, the phrase on lines 20 to 21 with respect to the therapeutic use of cannabis are critical to address his concerns, that this language in no way would exempt people under 21 from the balance of the tobacco law. It would maintain the prohibition for this population against the purchase and use of tobacco products regulated by 126X. And so again, that line 20 to 21, it's an exemption with respect to the therapeutic use of cannabis. The New Hampshire ATCs do not sell cigarettes, and a person who's under 21 cannot show their registry ID card at a convenience store and buy tobacco products. If this language is found to be unclear or not sufficient, I'd be happy to work with Representative Marsh on clearer language, but in no way is this intended to exempt the under 21 population from the tobacco law. So moving on, there are a few more policy proposals here. One policy proposal would allow medical providers to certify their patients for the therapeutic cannabis program for up to 3 years at a time. The current duration of a provider's written certification is 1 year. This bill would not mandate a 3-year certification. Rather, it would allow providers the medical discretion necessary to issue longer duration certifications when appropriate. Note that providers already have the authority to issue shorter duration certifications of, say, 6 months, and they have the authority to rescind a certification at any time. The next policy proposal in the bill would increase patient access to the state's alternative treatment centers. There are a number of references throughout this bill that are impacted by this policy change. Currently, there are only 7 ATC dispensary locations in the entire state, and patients are restricted to accessing only 1 ATC at a time. This legislation would allow New Hampshire patients to access all the ATC dispensary locations in the state at any time. The last policy proposal I'd like to mention, again, not audit related, but would allow authorized employees of the department to possess and transport therapeutic cannabis for inspection, investigation, and regulatory compliance purposes. Currently, department staff are not permitted to conduct these activities on cannabis products without the regulated entity, the ATCs, maintaining control of the products being inspected. This bill would allow authorized department staff to identify cannabis products at the dispensary or at the cultivation facility for quality control purposes and illegally transport those products to a testing laboratory in the state. And that concludes my prepared testimony. I'm happy to answer questions after the full presentation is over.
And Mr. Chair, that brings us to page 7 on line 27 to section 33. And I just would ask Ms. Dyer if Director Henry Lippman is with us at the present time. He was doing a briefing before Senate Finance for the Division for Medicaid Services. And if he has concluded that, he's going to jump on the call with us right now to discuss the section 33 of the bill.
He's with us and able to speak.
Good afternoon, Henry Lippman, Medicaid Director. I'm hoping you can hear me okay.
Yes.
The provision in Senate Bill 162 is identical to the provision that was passed by the House in HB 2. The purpose of this provision is to support the compliance with RSA 167-64, which was the agreement between the state and the hospitals with respect to compensation for uncompensated care. Back in 2018, when this was adopted, it was expected that the way in which the state would pay hospitals may need to evolve over time. And what this provision allows is for Medicaid enhancement tax, to the extent it's already used to pay providers, would be allowed under the Granted Advantage program for purposes of complying with the settlement agreement between the hospitals and the state, and as codified in this statute, RSA 167-64. Again, I think I just highlight that it is an HB2, identical as it is into Senate Bill 162. I'd be happy to take questions here if there are any.
Yeah. I don't see any hands up.
I appreciate you continuing to support this, as it's very important for our compliance and commitment with the hospitals. Thank you.
And Mr. Chair, if I may proceed with section 34.
Please proceed.
Thank you. So section 34 is related to section 65 and a couple of other sections. So when we get to that regarding the administration of epinephrine, we will cover this in more detail. But essentially, this is repealing within the Department of Health and Human Services this particular authority that's being transferred, proposed to be transferred to the Office of Professional Licensure and Certification, and we'll get into more detail when we get to section 65. The next section dealing with the Communicable Disease Mosquito Control Fund, if Ms. Dyer, if we can go to lines 5 and 6, you'll see that it relates to certain funds that were to be deposited, not lapsed, back on June 30th of 2009. Since we're doing a thoughtful cleanup of all the other funds, we just figured this would be a good thing to add to the list as well, where it's outdated and it's already passed. The next section deals with the shellfish. We had already discussed in section 2 of the bill the funds, and this is the corresponding fund within the actual enabling legislation under the Food Protection Services. We do have members from our Food Protection Services with us in case there's questions around any of these items, but you'll see also section 37 also relates to the same dedicated fund, as well as sections 38. So Ms. Dyer, if we can scroll up, please. Section 39, nursing home administrator patient account. This starts approximately 3 or 4 sections of the bill that deal with our legal and regulatory services under our estate recovery unit. The estate recovery unit is supervised by an attorney, and essentially what their job is to make sure to ensure that taxpayer dollars are recovered appropriately. And what I'm referring to is where in cases where individuals receive medical assistance, including long-term care, nursing facilities, that there is an obligation, obviously, if there are assets out there for the department to recover, including placing liens on properties to collect for those expenditures. And so all this does is it changes the jurisdictional amount from $5,000 to $10,000 on those estates that have a very little amount within the estate. So you'll see that change throughout, and when we come to them, we'll stop, pause, but we have them as it relates to the nursing home administrators, the guardian statutes, and another statute that we'll get to. We did have a conversation, with the bar community, and certainly working with them, they are appreciative and understanding of the goals that we're trying to reach, and so thank you. So moving along to section 40, of the bill, that just deals with the effective date, so that when the courts are making orders, that it's very clear as to when that particular moment takes place, that the new provision of the $5,000 to $10,000 takes place. It's a very thoughtful approach in terms of a very clear effective date. The next one involves the cleanup of unnecessary reports as part of RSA 151E as it relates to utilization of non-nursing home services. So that's addressed by other reports that the department already does. The perspectives under Section 42, Protective Services Adults and Reports to Adult Abuse. This is a bill that we brought last session that was tabled, but it was postured for passage. And what it relates to is the department within our Bureau of Elderly and Adult Services has a unit that protects adults. So it's called the Adult Protection Services function of our agency. So if there are complaints about a vulnerable adult, whether age, disabled, we investigate those upon a receipt of information that we need to conduct an investigation. Under current law, however, it's currently drafted that the individual who's the vulnerable adult has to be alive at the time that the report is being investigated. And unfortunately, there was a set of circumstances where an individual who was charged with an adult who had dementia or some related disorder had a requirement to watch that person at their residence in community-based care every 30 minutes. Unfortunately, and the allegations are that that time period was not adhered to. And on a hot summer day, unfortunately, that adult a vulnerable adult, got into their vehicle and expired due to heat. So based upon the fact that that individual died, there was a barrier to adding that person's name upon an investigation and a finding of abuse and neglect to our registry, so that that person could in fact seek employment in a long-term care facility or in a community-based without being caught on the registry. So this was an important consideration and a very important piece that was tabled last session, and we're happy to see it in this bill right here. Sections 43 are also outdated reporting requirements, as you'll see from sections 1 through 4. One of those sections actually relates to a following section that we're going to discuss in a moment, which is RSA 165:20C. And when we get to that section, we'll talk about it, which is coming up very soon. So section 44, A2 assisted persons expenses to amend RSA 160:20A, that's a cross-reference to removing the repealed 165:20C. So that's just a OLS catch on where it needs to be caught in other statutes. The public assistance financial disclosure by applicants and recipients under RSA 167 for lowercase a Roman 6 also addresses that same issue as it relates to that issue. So if we can scroll down, Ms. Dyer, so I can get to the appropriate section. Oh, right. So this section here in the very bottom is striking out a reporting requirement that has since passed and no longer. So this is part of our cleanup on the reporting requirements. So, Mr. Chair, we've now reached on page 10, line 16, section 46 as it relates to the Child Protection Act. And with your okay, I'd like you to recognize Attorney Rebecca Ross, who's our General Counsel and Legislative Liaison for our agency's Division for Children, Youth, and Families. And she can take you through this section as well as the following sections that actually make up the bulk of the bill as it relates to the Interstate Compact.
The attorney is so recognized.
Thank you, Mr. Chair and members of the committee. For the record, my name is Rebecca Ross. I'm General Counsel and Legislative Liaison for the Division for Children, Youth, and Families. Section 46, investigative interviews, addresses a narrow but critical gap in the child protection system by allowing courts to expressly have the authority to order an investigative interview or examination of a child in order to complete an investigation of abuse or neglect. It is always the division's position that we work with families and work cooperatively with them, even when we're investigating. But in the rare instance that we are unable to get access to a child we need the court to have the ability to order an evaluation of that child. Right now, the law as written allows us to access the home with a court order, but it does not actually allow an order to speak with or examine a child. And this is critically important for small children who may not be in school or daycare full time. If they are within a home that we are unable to access and unable to have them evaluated, we cannot complete our investigations. So we believe this would be used rarely, but in critical cases. The next section is section 47, and this was made at the request of another bureau of the department. It amends the DCYF Central Registry, which is our registry of findings of abuse and neglect. This would allow employers who are providing services to the developmentally disabled population to check to ensure that their employees who are providing services to a vulnerable population do not have a prior finding of abuse or neglect on a child. The next section is section 48, is the Interstate Compact for the Placement of Children. And as Senator Bradley said, this is not a new law. This is seeking to adopt an updated version of the law that will not become effective until 37 or 35 states have adopted it. So far, there are about a dozen that have adopted, including the neighboring state of Maine. There are a couple key reasons why this is important to New Hampshire. The last time this was amended was 1995. So it is definitely out of date and in need of updating. It will be particularly helpful in addressing the accountability between states, so that when we have a child who we're looking to place in another state, potentially with a relative, or vice versa, someone wants to place a child here with a relative through our system, it establishes better cooperation, collaboration, and communication, including electronic communication that is not currently permitted, so that we have more timely information if we ask another state to provide us with that information, and we're held accountable to the other states who are seeking our assistance. So we are looking to be one of the proactive states to adopt that. But again, it would not be effective until 35 states have adopted it. And John, I believe that's the end of my sections until section 55.
And Attorney Ross, thank you very much. And Mr. Chair, proceeding along, that takes us to page 28, down to line 15, which is section 51, involving our child daycare licensing. And I would ask Attorney St. Cyr, if she's still on, if she can walk the committee through that section of the bill.
What page? Yes, may the attorney proceed. This is page 28, line 15 and following.
That is correct.
The attorney may proceed.
Thank you again. For the record, again, Melissa St. Cyr. So as for this change in section 51, childcare licensing currently licenses school age programs, which are basically child daycare agencies that are provided for school aged children. And currently our statute has restrictions on age. And so we have asked that those restrictions be changed to 4 years and 8 months of age or older, so that those children who are entering into kindergarten can seek out a child or a school age program and become enrolled in a school age program prior to them entering kindergarten. So that is what this change is seeking to do. Thank you.
And Mr. Chair, that takes us also to, related to our child care licensing, to section 53 of the bill. And this involves the accessibility or availability of an EpiPen, as well as an inhaler you'll see in the following section. And I just wanted to recognize the good works done by Miss Melissa Clement within our agency, who's our child care licensing person who oversees that unit. And she, along with her supervisor, Doreen Shockley, worked very positively with the camp community, along with Henry Vehu, who represented one of the key stakeholders, to come up with an accommodation. So we appreciate that. And so what this essentially says is that those items, whether an EpiPen or an inhaler, need to be readily accessible to the camp, so that obviously from a public health, public safety standpoint, that they have their needed inhalers and EpiPens. That takes us to section 55 of the bill on page 29, line 10. Again, that is section 55. And I invite Attorney Ross to review this section with the committee.
Attorney Ross.
Thank you again. This peer support section is codifying the confidentiality requirements for the peer support program that DCYF has developed to support and maintain a healthy workforce. As many of you know, over the last few years, we have been trying to grow that workforce and decrease the training folks and having them leave shortly after they're up and running. This portion of the bill mirrors the provision that is available for first responders who are exposed to crisis and trauma in their jobs. And we feel that this is an important support for our staff who are working with families day in and day out. And we'd ask that you provide them with the same confidentiality so that they can seek the help that they need when they're exposed to situations through the course of their job. And I'm happy to answer any questions about this section.
And Mr. Chair, if there's no questions at that point, if I could have Attorney Ross also continue on page 30, starting at line 31. This is section 56 of the bill. Again, page 30, line 31, section 56 of the bill. And it deals with contracting or procurement for services through our Division for Children, Youth, and Families.
Yes, Attorney Ross, please continue.
Thank you. This section codifies the work that we're doing moving toward contracted residential providers rather than vendor service providers, and will allow us to tailor the contracts and the services to meet the specific needs of the population that we're seeing, and move away from more of the one size fits all. It's consistent with the work that's being done with system of care and the other system redesign. And it's purely codifying that we're moving toward that contracting model.
And Mr. Chair, that would then take us to page 31, line 3, section 57 of the bill. And with Attorney Ross still on, this is part of the cleaning up of either outdated, redundant, or unnecessary reports. And this one relates to informational materials relating to missing children. So I would just invite Attorney Ross if she had any commentary in support of why that language is no longer needed, or the report.
Yes.
Thank you. Other than it was a very old statutory requirement and has essentially been replaced with the work that we're doing with our human trafficking position and some of the other more up-to-date reporting that we're doing, we don't believe it's a necessary reporting requirement. And there's other information that is more readily available and more useful at this time.
And Mr. Chair, that will take us to sections 58 through 60, which all relate to each other around developmental services. And we have Attorney Melissa St. Cyr with us. You may recall your committee had a retained bill that you worked on considerably. So pieces of this actually relate somewhat back to the good works that you folks did within the last couple of sessions as it relates to gaps in services, particularly for children between the ages of 18 and 21. And needing these particular services. So I would turn it over at your direction, Mr. Chair, to Attorney St. Cyr at this time.
Attorney St. Cyr.
Thank you so much. The sections 58 through 60 relate to RSA 171A, which is our funding mechanisms for our developmental disabilities and acquired brain disorder services that are provided by the department. There are sections 58 and 60 are cleanup. Section 59 was the department had identified that there was a gap in funding for those aged 18 to 21. There were certain services such as housing that were not included in the funding as written, as the current statute is written. And therefore, we had requested that the funding for those individuals for that age group for 18 to 21 be included in this change. The advocates, other stakeholders have some concerns around those. So this language was changed that individuals from area agencies, the Department of Education, the DRC, and others would, as well as the department obviously, would get together and discuss the aged 18 to 21 and come up with potential language for future legislation and resolution. And so that's what Section 59 does. Thank you.
And Mr. Chair, if there's no questions for Attorney St. Cyr at this time, that takes us to line 26 on the same page, page 31, which is section 61. You may recall this relates back to section 1 of the bill on the dedicated funds cleanup. This is the housing of the language within the enabling legislation for the fund for the domestic violence grant. So this is just the reciprocal cross-reference to those funds. Section 62 is the Grant Workforce Program, and Representative Weber acknowledged from the questioning that she had with Senator Bradley that it does in fact what it says it does here relative to no requirement if there's no funding, and it's only about the Grant Workforce Program, not the enhanced Medicaid whatsoever. So that then, if there's no questions, takes us to page 32, line 18, section 63 of the bill relative to health facilities licensure. And so what this section does on section 63 is it cleans up a rare, and I'll repeat that, a rare Scribner's error by the Office of Legislative Services. That last session, they passed legislation to better identify the appeal process and the standards that the department utilizes around special healthcare licensure. And so the problem with the bill as it was enacted, that the effective date for repealing the old manner for the review happens on July 1st of 2021. And the new standard to be applied was effective on July 1st of 2020. So we just need to align that the old way of doing things needed to end at the same time, contemporaneous with the new way of approaching the licensure. We do have Attorney St. Cyr, who worked very, very closely on this legislation, and I would invite her to add any commentary, because I gave you the very high level what we're trying to do here relative to an effective date that just need to be changed.
Attorney St. Cyr.
I don't know if I have much more to add. Just having the two provisions in contradiction of each other, they can't both stand. Both of those provisions can't stand together and actually make sense and can't be executed. So this cleans that up. And so I think that's all we need to tell you, but I'm certainly happy to answer any questions.
So, Chairman, the next section is on line 22, and it relates to section 64 under milk sanitation. I do have, if there are questions for the committee, Ms. Colleen Smith, who is just an incredible person who works in our food protection services, if there are questions. But essentially, we just need to clarify the term of wash stations as it relates to, the sanitation of milk trucks that transport milk. And that also relates to section 65 of the bill. And this gets back to our conversation that we had on dedicated funds. So this is just one of those items, part of the dedicated funds cleanup as it relates to the following section, section 66. And that now takes us to page 34, line 27. Again, that's page 34, line 27. As it relates to section 67, guardians and conservators. This is the corresponding change to the jurisdictional amount for states that are minimal estates from $5,000 to $10,000 for that particular threshold. And then that takes us to page 35, section 68, dealing with the escheatment statutes under unclaimed property and abandoned property. Also, the same jurisdictional change from $5,000 to $10,000 throughout. Section 669 is the applicability on the effective date, so that it's upon when the court's looking at it, it's upon when those affidavits or claims are filed. And that takes us to section 70 relative to the retirement system. And this is the third and final piece as it relates to recruitment of qualified positions for our Bureau Chief for Emergency Preparedness and Response, and allowing those that are in Group 2 specifically to be able to apply for those jobs without losing their Group 2 membership. That now takes us to the Department of Health and Services plan for legislation. And so this final section here was an accommodation working with Senator Bradley and Senator Rosenwald as it related to case management services. And like earlier items working along with the Hospital Association as it relates to emergency services, this section allows us to work with the provider community and agencies around case management and to report on November 1st of 2021 with ideas. I do think I inadvertently did skip over one section that dealt with the transfer from our agency to the department, rather the Office of Professional Licensure and Certification, as it relates to training for the administration of epinephrine. And as most of you are aware, there are 3 different settings that are set up in current statute for the administration of epinephrine. And the first setting is related through K through 12 schools. And then there's a whole section that deals with post-secondary, so at universities, what needs to be done relative to the training and administration of epinephrine or EpiPens. And there's a third that is a non-academic setting, such as an Appalachian Mountain Club Lodge or other settings that may need the use of an epinephrine or EpiPen that currently was housed within our agency. The prior 2 that I discussed, we certainly provide information, we're resourced, but they were administered by a different state agency. The Department of Ed, for the most part, as it related to the educational settings. This one, however, had our agency tagged with being the ones who have to administer the training for this program. And in a very collaborative discussion we had with the Office of Professional Licensure and Certification, they recognized and agreed that it was better suited with them under the Board of Medicine to provide direction for training for the use of epinephrine pens by physicians in those non-educational settings. So it was a great exchange. We worked along with attorney Lindsay Courtney, who is the executive director for OPLC. I would invite attorney Melissa St. Cyr if she had any other thoughts, because she had worked along with others in the department around that section.
I don't have any additional thoughts. Thank you, John.
Well, Mr. Chair, it did take us a little bit longer, and I think we probably did even a more thoughtful job with your committee on the initial walkthrough, but we were able to do this time check here within 1 hour of over 26 to 34 different legislative initiatives. So at this time, if there are questions from the committee, either I or others are certainly available to field them as needed. Thank you.
See a hand up? I don't know who it is. Shapiro. Representative Shapiro.
Thank you, Mr. Chair, and thank you, Mr. Williams, for that extraordinary detailed presentation. I have 2 questions. On page 1, number 5, you mentioned parity between mental health and physical health services in emergency rooms. Is this another attempt to deal with the emergency room boarding crisis?
And Mr. Chair, in response to Representative Shapiro's question, if we could recognize attorney Melissa St. Cyr on that question from Representative Shapiro.
Attorney St. Cyr.
Thank you, Representative Shapiro, for your question. The department's goal in this is, in this legislation, was to allow for mental health parity in our hospitals. When somebody arrives at the emergency room to receive services, whether it is a mental health or a physical health, that they receive the same care, attention, and level of care that they would no matter whether it is physical or mental health. So that is the whole reason behind the legislation. If it assists with the ER boarding crisis, wonderful, but it really is to ensure parity.
Follow up? First, I would say if parity is created, that would certainly be a help, because right now a lot of people are getting very limited or no mental health services in the emergency room. I'd like to move on to page 32. This section about, I guess it would be 62, starts on 31. The section about the work and community engagement program with expanded Medicaid. And I am just curious why it is written the way it is written, to say if the work and community engagement waiver is held invalid, when my understanding is that it already has been revoked by the current administration.
And Mr. Chair, if I may respond to Representative Shapiro's question,
Yes.
is absolutely correct around that. We just need to make sure that we clarify that within the context of the proposed legislation. And certainly is a timing issue. We put together this legislative proposal back in the fall, so that is some of the factors that are involved. We also, I can certainly have Director Chris Santinello, who is at a telephone ready standpoint, if you need additional information beyond that, and certainly I could have her discuss with you offline those services that are in fact still being provided through the Department of Employment Security to support those individuals.
Thank you.
And Representative Weber.
You're on mute, Representative.
Sorry about that. Now I have questions raised by the answer to Representative Shapiro, because I'm not understanding, Mr. Williams, what you meant when you said there are still supports. I guess my brain has bounced with respect to this provision, because I'm wondering what supports the Granite Workforce Program is currently providing, because I thought that what we were talking about was the work requirement. So there are supports in addition to the work requirement that are provided through this program, and they would also be suspended. I'm really needing
Mr.
more
Chair.
information
Mr. Chairman.
about this provision.
Yeah, we do have Director Lippman, who is at the ready to address Representative Weber's question.
And then just, Mr. Chair, I do have my original question beyond that.
Hopefully, this is Henry Lippman, Medicaid Director. Hopefully I can clarify here. I think connected to Representative Shapiro's original question, connecting to Representative Weber's question, I think at issue here is that CMS has withdrawn the waiver with respect to the community engagement requirement. There is, however, still a Supreme Court case that's in that has not been disposed of. It's technically held in abeyance. It's in all likelihood, not going to potentially be heard, but it's still an open case at the Supreme Court level. Is kind of where the community engagement stands. CMS has revoked the 1115 waiver for community engagement in the states where it had granted it.
Mr. Chair, this is Melissa St. Cyr. I can also follow up a little bit more to that if you would like.
Yes.
Great, thank you so much. Currently, the way that the statute is written, the Granite Workforce Program is a piece of the work and community engagement that was created. Although the work and community engagement has been withdrawn, the approval for the waiver has been withdrawn. The way that the statute is written, that doesn't subsequently also withdraw the Granite Workforce Program. They're linked, but our statute didn't link them enough to allow for, if the community work requirement, if the community engagement went away, that the Granite Workforce Program also would. So we're trying to make that link because they are in fact linked, but the statute didn't quite make that link. In addition, the New Hampshire Employment Security does have a role in some of the items that the Granite Workforce Program initially was created for. And we've been working very closely with New Hampshire Employment Security to conduct some of those activities. Although the Granite Workforce Program is going away because of the fact that the community engagement requirements are going away, New Hampshire Employment Security does continue to do some of the things that was conceptualized for the Granite Workforce Program. Hope that helps.
Thank you. And then, Mr. Chair, may I revert to my original question?
You may.
Thank you. On a completely different subject. To return to the group 2, the folks who, upon moving to administrative position, can keep their group 2 retirement systems, which I recall dealing with again and again every single time a new person was hired through normally through ED&A. How many positions are we talking about? There was one, I saw the reference to Homeland Security, but are there other positions that these provisions would apply to, and how many positions total would it apply to?
And Mr. Chair, this is John Williams. I can respond to Representative Weber's question. And so it actually only relates to one position that we're seeking recruitment. And the title for that position, as you'll see in the first section that I'm trying to catch up very quickly to where it's located, deals with a bureau chief essentially for emergency preparedness within the Division for Public Health Services. So it is only one position. However, because the recruitment could come from the Department of Safety, from an emergency management person from that entity, there's a specific provision in RSA 100 that relates specifically to what they call firefighters, for want of a better word. There's another section also in section 100 that relates to law enforcement and police. And so that section also needed to be amended so that it would allow for the recruitment and retention of group 2 if they came from either one of those 2 areas. And then that, I'm sorry, that completes my answer.
Thank you. So the maximum exposure to the concerns which might be expressed on behalf of the retirement system goes only to one specific position, no matter how many different places you have to put it in the statute, depending on where they're coming from. Is that right?
That is correct.
Okay, thank you.
Any further questions? Wow.
Hi, thank you, Chairman. I'm not quite sure who would handle this. I was very interested in the interstate compact for the placement of children, since it is a rather large section of this omnibus bill. Just for some background information, who developed this, and how many states are already in it? Who sets the standards for the home visits and placements and all of that?
And Mr. Chair, if we could invite Attorney Rebecca Ross to come in and to respond to those questions. But as Senator Bradley said in his overview of some of the key sections, that there already is existing law that it relates to the compact. What this does is it updates the current law that has not been updated in some time. So it's not creating a new law out there. And it also requires that a certain number of states have to sign on and ratify this for it to to be effective. But I think Attorney Ross is in a much better position to provide a level of detail to Representative Folsom's very good question.
Good afternoon. Thank you, John. Thank you, Representative, for the question. This is drafted by a group that all of the states belong to. It is, as John said, updating the current version that we adopted into law in 1985. It provides for the adoption of regulations once the requisite 35 states have adopted. So the states that have joined will work together to come up with the regulations to implement the act. So we don't have those yet, but we would be a participating state in developing the specific regulations for the different parts of the program. We would still be, like we are now, using our own foster care and adoption home study rules and doing things the New Hampshire way. Other states would still be using their process, and it sets the minimum standards and the obligations that are required when working with the other states. I hope that answers your question.
Thank you. When the 37 states sign on, first of all, it's been since 1985, so that's quite a few years, and we're not at 37 states yet. Is there a hope to when that might happen? And then also with that, is once it does reach 37 states, does it become a federal program at that point?
It doesn't become a federal program at that point. It's still something that we, as New Hampshire, choose to be part of. But so since 1985, we've had a version of the Interstate Compact for the Placement of Children on the books. This proposed draft has not been in the works since 1985. This is more recent, although I don't have it in front of me. It has been a number of years. It stalled, and there was increased enthusiasm over the last couple of years through the national organization to bring it back and work toward the electronic communication system. Right now, we do things by fax. It's very slow. A lot of things go back and forth by mail. There are undue delays because we don't have a system in place to be able to communicate essentially in real time. We also don't have, the current compact doesn't have any enforceable deadlines for other states. So we could have a child in New Hampshire with relatives that are in the best position to take care of that child in another state. And we are at their whim as to when they complete that home study and get back to us. This will correct that and include penalties for not cooperating and working with states in a timely manner to get that permanency for children.
Representative Gay.
Thank you, Mr. Chairman. Thank you for taking my question and clarifying this. So I'll say some things and then you tell me whether I have this right or not. Currently, we do have compacts, maybe not called a compact that way, but we do have arrangements with other states for transferring children to other places where they'd be better, they have somebody to care for them. But we don't have anything to hurry them up if they have a long delay that's acceptable in their state, we're stuck with that. So I'm going to guess, so that's question one. The other question is, this sounds like, if we're talking about 37 states, this sounds like a federally proposed program that just never has gotten the 37 states to sign on, which seems to me a little strange since it would benefit people. I don't understand why it requires all 37 before you can initiate the program. So is that indeed a federal program and we're stuck with the requirements?
No, right now we have RSA 170A, which is our current version of the Interstate Compact on the Placement of Children. So we we do have one in place, and absolutely that's what we operate under. And that's what all of the states are operating under right now. There's been a proposal through the states that are members of this organization to update that, and that's what this is. So the decision was made that we essentially need 2/3 of the states to decide to move forward with the new program, and that's what we're in the process of right now, is each state working with their own legislature to ratify these changes. And as soon as there's essentially 2/3, then that would be operationalized. Until then, there's not sufficient buy-in for the states to update the process. So that's very common with these interstate compacts and how they're developed and operationalized. And so it doesn't make it a federal program. It does bring us into compliance with how we work with the feds for placing kids out of state, but we're not out of compliance by operating on the old agreement either. And this is a group of states working together rather than a federally mandated law that is being imposed on us.
Representative Folsom.
Thank you. Thank you, Ms. Ross, for taking our questions on this. It's something that definitely interests me because I used to live in Alaska and had to deal a lot with placement of Native American children, and that there's a lot of red tape involved in that. So that's why this caught my eye. But what is the name of the organization that you all belong to, that all the states participating currently belong to?
The ICPC is through the American Public Human Services Association, or AFSA.
You said some letters there right at the beginning, and I didn't have those.
American Public Human Services Association, APHSA. And I have the link to their webpage, and has the comparison of the old and the new version and some additional FAQs and information. I'm happy to send that on if that would be helpful.
That would be wonderful. Thank you.
You're welcome.
Anyone with any further questions?
Representative.
Sorry? Representative Weber.
Thank you. And as a matter of clarification for Ms. Ross, is it not true that if 37 states ratify the compact, it doesn't bind any of the states that have not ratified the contract? Is that correct?
That's correct. It would just be the organization moving forward with the compact.
So and is it not true that sometimes, despite the fact that this is an interstate compact, states have individual variations in their version, even though it's sort of based on a cohesive whole? So each state really does very much retain control over its own procedures.
Yes, absolutely.
Thank you. And then may I have one on a different subject, sir?
Sure.
At some point, somebody mentioned that we were transitioning from vendor services to contracted services, and I'm not sure I got those terms right. It had to do with services for, I think, developmentally disabled persons. And I just wanted to know what the difference was between vendor services and contracted services, because I would have thought they were the same thing. So if anybody could explain that to me, I would be appreciative.
This is Rebecca Ross. Again, I'm happy to, Representative Weber. So currently for residential childcare, we have licensed and certified providers. And if a provider is licensed and certified, they can take placements. We do individual contracts that go to governor and council with them. We are moving toward that in order to be able to tailor those. So instead of having minimum certification requirements and anyone and everyone that certifies can provide services, we're looking at really redefining what services they're providing. And we're doing that both in our residential services, but also putting out a number of our community-based services for child protection through contract so that we can better identify what we're purchasing and what will meet the needs of the children and families we're serving. So the vendor providers right now are licensed and certified, but they do not have governor and council approved contracts with us.
Okay, thank you.
I'm getting a text from Christina Dyer regarding the info, and she says the APHSA, A-P-H-S-A, who writes it, is that information is in the guideline that she emailed us to help us walk through the bill. Any other questions? Representative Gay.
Yes, thank you, Mr. Chairman. The last question that was answered, could you clarify more? For one thing, we couldn't understand everything you said because your voice tailed off, but still the difference between a contract and a contracted service and a vendor is not clear to me. Do they address different categories of people? Do they address different lengths of time that you care for these kids? Is it like a residential, you're comparing residential to daycare? Yeah, please explain a little more.
I'd be happy to. No, you can use either model, and throughout the department we have different services that are provided under different models. For example, Medicaid pays in different ways. But historically, for DCYF, our providers have been just essentially enrolled. As long as they're enrolled, they can take clients and we will pay them the rate. And that is for both community and residential services that we pay for children in DCYF care and custody. That's changing to provide a better service array so that we can identify what types of services we want out there and ensure that there's a provider there to do it. Right now, providers are under no obligation to provide a service. They're eligible to take clients, but they don't have any obligation to. By going in a contracted model, we can require that they provide a certain service to a certain number of youth in a certain area to really better purchase what we're looking for instead of only having available what providers are inclined to provide.
Thank you.
We'll see no further hands. I think we have three choices before us with this bill. One is to wait because somebody or some buddies may have an amendment or more coming, so we should wait for those. Or nobody's got an amendment coming, but we might want to sit on it for 2 weeks.
Chief Shigori still is up to testify.
I am sorry. You are so correct. But hold that thought. And I see that, and thank you, Representative Marsh, for pointing out that to me. We have a Mr. Andrew Shigori from Center Tuftonboro who wishes to testify in the hearing. And Mr. Shigori, if you could put your hand up and you'll be recognized to come into the meeting.
Thank you, Mr. Chairman and committee. My concern, first off, I'm Chief of Police in Tuftonboro. I've served in the past on the Therapeutic Cannabis Advisory Council, and I have concerns about sections 12 through 14. I think it's kind of worded poorly. I think the better way is to exempt those products and have a particular what products that they're referring to. Maybe that's the way to look at it, instead of giving a blanket exemption to a whole chapter of laws. More particularly, though, as I came on to talk about the rest of the therapeutic cannabis section here, sections 14 through 32. I guess, like I said, I've been familiar since the start. I was on the Therapeutic Advisory Council. When this program was put in place, we were promised a tightly regulated program that was for the seriously ill people, and it passed under that guise, if you will, under that intent. Then there was a 5-year report issued saying that it should stay along those lines. These changes being proposed, first, when Mike Holt talked about this audit, I looked at the audit. The audit had to do with why licenses weren't being issued within the statutory period of 15 days. It had nothing to do with many of these changes here. I will send a copy of the audit so you can all look at it. What happens if these changes go into effect, sections 14 through 32, we will no longer have a tight program. We will have a very loose program. Give you some ideas. One, patients will no longer be linked to an ATC. They could go anywhere to any of the ATCs and buy it. It'd be impossible to track whether or not they bought more than 2 ounces at any of the ATCs, because right now, if they're tied to one, that one knows if they've come in more than once in 10 days, or how much they bought within that 10-day period. This will exempt them from being able to track that. I know it adds a penalty for doing that, but realistically, it's unenforceable. In other states, you would call this, in Colorado, they called it looping, when people would come back and buy over and over again. And in this case, you have the caregiver could buy along with the patient, and there'd be no way of tracking it. In other words, somebody could go to the Chichester dispensary and buy their 2 ounces, and the caregiver could be going over to the one in Dover buying 2 ounces, and then you don't know how that's going to be tracked. And if they think they're going to track it more, that's going to be tougher to track than anything else. This also will allow the ATCs to grow more marijuana, because right now they're allowed a certain number of plants and then a certain number based upon the number of patients that are tied to their ATC. This says they can grow it for everybody who has a card. Well, recently Mike Holt testified in another hearing, there are 11,000 cards. So instead of having the 2,000 or 3,000 that might be tied to one ATC, they're now going to be able to grow plants for all 11,000 of any cards. I believe it's going to allow out-of-state patients to buy from New Hampshire ATCs. There's no way to verify out-of-state cards. And then also, here's the big loophole that's going to come up. It's caregivers are not going to have a limit on patients. It's presently is 5 patients. They can help 5 patients. With no limit, they can carry almost any amount of marijuana they want with them. There's no way to verify. There's no practical way to verify that in the field. If a police officer contacts somebody and they've got a bunch of marijuana on them, there's no way to verify that in the field. The one time I tried calling there, it was a Friday about 10 in the morning. And instead of being able to verify it, I got a call several hours later. But here's the other problem that happens when you have no limit on patients. Other states have had that, and they've had problems with it. Washington, Colorado, Maine, Michigan. That becomes a loophole that gets exploited. In Maine, they have what are called caregiver storefronts. So caregivers are able to have a storefront where they can give out marijuana, sell marijuana. They can't sell it, but they can exchange it for their cost of expenses, if you will. Maine has them. Look them up. They're called caregiver storefronts, and they're not subject to any regulation or relative to, because they have home grow there too, but there's no subject to regulation as far as, and they're fighting that. The caregiver storefronts are fighting Maine's attempts to add regulation to it. Washington had these pop up. Michigan had a bunch of these caregiver storefronts. By not limiting the patients, you'll see what they call, in some states they call them cooperatives. They'll have delivery services, caregiver storefronts. I think it's it's a lot of unintended consequences here, and it needs a lot more work and discussion before anything like this passes. And none of this, I repeat again, none of this was in that audit. That audit had to do with them not meeting the statutory deadline for issuing cards within 15 days. You should be aware that why I brought it the home grow into this, there is another bill that has gone through. I'm not sure if it went through your committee or not, HB 350, which talked about caregivers having home grow and patients having home grow and be able to collectively home grow. You're gonna have some problems if this passes as written. And the other part of that employees of DHHS program will be exempt from marijuana drug laws if this passes. There's no requirement for them to have any proof that they're involved with a regulatory scheme while they're doing this. This just says if they're involved regulatory, which is an easy thing to, anybody could claim that. Another problem with this bill, it eliminates the address for card holders. Why do we need an address for card holders? Because we do search warrants, and marijuana is still technically illegal unless you meet certain threshold requirements. Like this program, for example, it's an exemption from our marijuana laws. Without an address, somebody could claim any marijuana anywhere is theirs, because I don't expect a patient to carry all their marijuana with them all the time. So if we went to apartment A, 5 Main Street, apartment A, and we found some marijuana in that house in the course of an investigation, any patient could claim it's theirs because there's no name attached to them. As far as I know, there's very limited requirements for any kind of labeling other than what the strain is at the dispensary. They can change the packaging. It's really pretty open as to what they do. And I'm not saying it shouldn't be that way. Don't mistake that. I'm not advocating for a change in that. What I'm saying is without an address for a patient, we can't say that stuff we found at a certain place actually belongs to them. And so if it actually belonged to somebody else, they could get their buddy who has a card to claim it for them and get an exemption, if you will, from the laws. I think there's a lot of loopholes in here. I think it needs a lot of work. And frankly, I didn't see anything that had to do with the audit. If they need more staff, they need more staff. But extending them out 3 years, I don't know how that helps with the audit. Maybe that arguably might have something to do with the audit, making it less that they have to do every year. But it also talked about adding staff and training them. Thank you.
Representative Knirk.
Yes, thank you very much. I had a question, sir. You had commented about kind of a blanket exemption with regard to tobacco in sections 12 and 13. And I have to confess, when I first read it, that's how it impressed me. But I thought we had a fairly clear explanation with the phrase, with respect to the therapeutic use of cannabis. Can you explain why, when it's restricted to with the respect to the therapeutic use of cannabis, that you think it is a blanket loophole that would allow them to buy tobacco at a store?
I wasn't saying that at all. What I was saying was that if there's a certain, what he talked about was some of the things that they do, maybe it's rolling papers he's talking about, because that's covered under that statute. Well, if that's the case, why not just give them exemption to sell rolling papers rather than give them a whole exemption from the whole section of the law? I think that's a better way of doing it. If there's some specific thing they need, some paraphernalia or something like that, I didn't say, I understand what Mike Holt said about that with therapeutic cannabis, and I understand your point, but I think what I was getting at was maybe it needs to be reworded to about those particular programs in the ATCs that, or the products that they're trying to sell that might put them in violation of that section. Name them rather than just give them a blanket exception to the whole law, if you will. Be a little more specific is what I was getting at. I realize it does not allow them to buy under 21 to buy tobacco.
Follow-up, Representative?
Follow-up? Yes, well, but you used the word blanket exemption again, and I think the concern is that we can see that if things change in the tobacco law, then we have to come back with a statute that might be important to be able to exempt that particular thing. Like initially it might be vaping, another time it might be rolling papers, and we have to keep coming back with the therapeutic cannabis program to ask for the exemptions one by one. If we exempt them with regard to the therapeutic cannabis program only, would that not allow them just to simply be able to do what's necessary in their ATC, but would not allow the purchase of tobacco products in a store? Why would that not work?
Well, I said blanket exception to the statute as it relates to their exemption. to therapeutic. It's kind of twisting my words around. Let me give you an example. This bill, as written, as I read it, doesn't just apply to ATCs. They could go into a general store, any store, and buy rolling papers, a patient, because not just the ATC selling, but it also talks about patients with cards giving exemptions, right? I mean, that's how I read it. If it's just the ATCs, that's one thing, but it talks about patients getting exempted too. So they could go to a store, and rolling papers is probably the big thing that comes to my mind because it's specifically stated in the statute. So I think it needs work. I think it needs work to accomplish the goal they said they wanted to accomplish with it. That was my point. I'm not saying it gives them a blanket exception because it does have those few words in there about therapeutic cannabis. But there's another part of that too, and that's grammar. And I'm not an English major by any stretch of the word, but it does say, or alternative treatment centers under RSA 126X7 with respect to the therapeutic use of cannabis. The or is disjunctive, and the New Hampshire Supreme Court has said they're separate. They can live alone. Somebody could argue, I'm not saying that it's true. I know that's not the intent. Somebody could argue that individuals would not be required to follow it under the Therapeutic Cannabis Use of Cannabis Act because that only applies to the ATCs. Like I said, I'm not an English major. I'm not a lawyer, but I'm telling you that sometimes the or is disjunctive and it's not clear that that necessarily applies to both. Somebody could make that argument. I'm not making that argument, but I think it needs clarity. I'm just saying it should be worked on for clarity in that section.
Follow up again?
Follow up again.
Okay. Would not the or mean that the individual purchasing, for example, a rolling paper or a vaping pen would not be subject to prosecution, but nor would the person who is providing it? Isn't that why the word or is there, is to take away the risk for the individual and for the ATC who would be selling the product?
Well, it also applies to individuals with cards, not just ATC. So store clerk with a card is also exempted to some degree too. It's poorly worded. That's my point. As we're arguing back and forth on how it could be interpreted, I think that just shows it. I think that reinforces my point. It needs work. It needs work. I'm not saying it's badly intended. I'm not saying it should to not do it. I'm just saying it needs work on the wording so it's clear that because it says individuals who have an issued registry card, that also includes clerks in stores, right? I mean, they're issued cards. They could have cards working in a store and they could decide to sell to somebody who they think is using it for therapeutic cannabis at a regular store. It's not specific to within the confines of an ATC, or if it's intended, it needs to be reworked. That's my point. The wording is kind of poorly phrased and subject to multiple interpretations as a discussion we're having right now. And it ultimately would have to be clarified by a court if somebody decided to push it that far. I don't know anybody that would, but I'm just saying I think it should be clear the intent and what it's meant to be. I heard what he said, but the writing doesn't necessarily give you that clarity.
Any further questions for the chief? Seeing none, thank you, Chief, for your testimony.
Thank you for your time.
Do we have anyone else who has not testified who wishes to testify?
What was his name? The chief.
I don't have anybody on my list. Those of you who have your computers in front of you.
I don't see any answer.
No? Oh. Okay, now I'll go back to what I was starting to say a minute ago, and thank you again for interrupting me because I had missed the chief. We could do one of three things. So let me ask, is there anyone here who is wanting to work on an amendment? Okay, we have one person who is wanting to work on an amendment, in which case that ends that. We will wait 2 weeks. And with that, I will close the hearing on Senate Bill 162. We had 5 sign up in support, 6 opposed. Now, we've got a little bit of time. So,
Mr. Chair, Representative Shapiro has had his hand up for quite some time, and I think it related to that last bill.
well, I didn't see it and nobody else did and nobody else told me, but that's irrelevant. So Representative Shapiro.
I just wanted to say that I was going to request that we wait before we exec that bill, but I do not necessarily know that I will have an amendment. I just felt like I didn't get a full answer to my question about the work requirement, and I've emailed Mr. Williams to ask him who I can speak to get a fuller answer. So I would request the wait, but I'm not suggesting that I'm necessarily going to have an amendment.
Thank you very much. And our next meeting will be Monday, May 17th, and that gives us 2 weeks to do that. Sometimes we just need to sit and think on something for a while. With that, I would like to go to exec the 2 bills from last time. Amendments have come to us, and I think we've all had a chance to see them. And with that, I open the executive session on Senate Bill 120, and I call on Representative Knurk for an amendment.
Thank you, sir. Yes, I would like to bring forward amendment number 1187, which I mailed to the committee last week, I think on Monday or Tuesday. In any case, so I would move the amendment 1187, and I'd like to speak to it if that's allowed.
Representative Marsh seconds it, and Representative Knurk, excuse me. Speak to your amendment.
Yeah. Okay. It's just simply, I got together with a handful of people, Representative Marsh, Merchant, Weber, and then we got together with also the PAs, particularly the VA person, Richard Laflamme. So that we went back and forth, came up with what we thought was a perfectly fine one, put it out, and Gary Merchant gets the Eagle Eye Award for picking out one more error that was still in that. We processed that again and then came up with this final amendment. If you look at it, it really basically, it just replaces the whole bill, the whole section 1. And the point is that we just tidied up things saying that this didn't have to do with where they were from, but licensed by, this is line 7, 8, 9, licensed by another state or territory, United States or another country, but that has to do with the PA, not the physician or who's the supervising physician. And then going down to lines, we also tidied up the issue that it was offering services, that's line 11, offered through the VA, so that it didn't have to be at the VA because sometimes it was offered elsewhere. Again, on lines 14 through 19, this is about the PAs who are employed by the VA, offering their services and requesting licensure can be supervised by a physician licensed in any state or territory in the United States, providing that that supervising physician has a license in good standing in that state or territory. But we got rid of that word of or other countries because we did not want physicians from other countries supervising. And that was basically it. The listing was, again, just this is lines 22, 3, and 4. The listing is out-of-state licensed physicians who are accepting that responsibility, that information would be given to OPLC. So that was all. They just tidied up those few little problems that we identified. Again, I thank the whole committee for that kind of segue that we did into an ad hoc executive session after the hearing when we kind of wordsmithed at the first bit, but we did go back and make some changes, and this is the final product of it.
Anyone else wish to speak?
Representative Shapiro.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you, Representative Knurk. I might have missed this when we had our original discussion about this, but does the PA in question have to be requesting licensure in New Hampshire, or can they just practice in New Hampshire given that they work for the VA?
My understanding is they can practice since they work for the VA, but if they wanted to get the licensure, we require that they be supervised by a New Hampshire licensed physician. And this was just allowing that it didn't have to default to that because their supervising physician on site may be licensed, for example, in Massachusetts, but not here.
Thank you.
That is my understanding.
Representative Gay.
Thank you. Do we have to, that's a change in wording. If we're talking about on-site, that is really a different situation from what apparently is going on. because man, I mean, I sent y'all all late this last night, my wording, which is almost exactly what you are talking about, but I left out the word on site, which may not be in this either, because that was a real issue of discussion. Do you need a supervisor? If it was a New Hampshire licensed person, PA working in a regular hospital, not in VA, we would require the on-site, I think. But because this is the VA, they run by their own rules. We don't put on-site in there because apparently they're allowing a doctor from Maine to supervise, what was the fraction? 1/4 or 3/4 of all VA PAs are being supervised by somebody in Maine, or at least not with them, not with the PAs, not physically with them. So I thought on-site was a very interesting concept to discuss and to see whether you keep it or not. It doesn't sound like if it's the VA, you use on-site. If it's a New Hampshire PA licensed to work anywhere in New Hampshire, you would use the word on-site.
That I'm confused on what you're trying to say. I'm sorry, but I really couldn't follow what you're saying. I'm sorry.
You just said on-site in your last statement. The supervisory physician, you said something about it being on-site.
I'm sorry if I did. I think I misspoke. What it is, the out-of-state licensed physicians that are going to supervise, they have to have a license in good standing in their respective state or territory. I don't think we have no language in here that says it has to be on-site supervision. What we did talk about was that it was the care offered on-site. That was confusing in the first. What we changed it to was offered to the VA. We had actually wordsmithed that together in the group because of the fact that the care may be given not at the VA, but through the VA to veterans. And we wanted to be sure it was covered for care that was given, let's say, as home care by a PA or in a nursing home or something like that. I think is that what you're saying?
Yes, I just wanted to clarify when you brought the words up on site, I thought you were talking about the supervision. So I wanted.
That had to do with where the services are offered. I'm sorry, not on site at the VA, but through their system. Got it now. I'm sorry.
Anyone else with anything to ask or share? We're in exec session. It does not have to be a question.
Mr. Chairman?
Representative Merchant.
Thank you, Mr. Chairman. To a couple of the docs on our committee, does a PA have to be on site to be supervised by a physician? As in the state of New Hampshire, is it required for the physician to be on site and have direct supervision of a PA?
May I answer that?
Representative Marsh-Beecher to it, and then you may. Go ahead.
Yeah, my answer is because I know of instances where that is not what's happened.
Representative Merck?
Yes, I supervised PAs, and I did meet with them once a week, but I was not at the same practice facility of the PA that I was supervising for 3 or 4 days of the week.
Okay. Anybody else? There's the amendment 1187H to Senate Bill 120 has been moved by Representative Knirk and seconded by Representative Marsh. And with no objection, would the clerk please call the roll on the amendment?
Thank you. Representative Marsh.
Votes yes.
Representative McMahon.
Yes.
Representative Nelson.
Yes.
Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey.
Yes.
Representative King.
Yes.
Representative Kofalt.
Yes.
Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Knirk.
Yes.
Representative Soloway.
Yes.
Representative
Cannon? Yes.
sorry, Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Merchant.
Yes.
Representative Query.
Yes.
And Representative Pearson.
Yes.
And that's 21 in the affirmative.
The chair recognizes Representative Marsh for a motion.
Yes, Mr. Chairman, I move that Senate Bill 120 ought to pass as amended.
Moved by Representative Marsh, seconded by,
I'll second. Salloway.
all right. Well, since the amended bill is now the bill, there should not be any discussion, but I have to allow for it. Seeing none, hearing none. When the clerk is ready, please call the roll on Senate Bill 120 as amended by Amendment 1187H. Moved by Representative Marsh, second by Representative Soloway.
Thank you. Representative Marsh.
Yes.
Representative McMahon.
Yes.
Representative Nelson.
Yes.
Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey.
Yes.
Representative King.
Yes.
Representative Kofalt.
Yes.
Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Knirk.
Yes.
Representative Soloway.
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Woods.
You're muted.
Representative Woods, unmute, please.
Yes.
Thank you. Representative Merchant.
Yes.
Representative Query.
Yes.
Representative Pearson.
Yes.
That's 21.
21-0. Representative Marsh.
Mr. Chairman, I move consent.
Consent calendar, would you please write the blurb? Thank you very much. And that is the exec session on Senate Bill 120. I open the exec session on Senate Bill 45, and we start with an amendment. Representative Marsh.
Mr. Chairman, I move amendment 1253H.
I'll second that.
And that sounded like Merchant, was it?
It did sound like him, yes.
Who was the seconded? Don't be shy.
It was Merchant.
I thought so too, but I asked if you did.
Representative Merchant, did you second that?
Yes, I did.
Thank you.
Thank you.
Yeah, to speak to the motion, the hardest part of this amendment was to put in contingency language so that whether or not House Bill 2 becomes law and whether or not this bill gets passed prior to or after House Bill 2, the appropriate language that we want to put into place will actually get put into place. The second issue that this amendment addresses is the issue of retired practitioners, who we all agree ought not to be able to access the controlled drug prescription, the PDMV, without a reason to be accessing it. And Representative Merchant to help us with a good bit of that language, and therefore his name is on this amendment as well. So those are the two issues that are addressed by this amendment.
Any questions or discussion?
Could somebody just say very briefly what the issue is, so I understand? Could you just, in 25 words or less,
Oh, the
say
issue
the
with
intent
retired-
about the controlled drugs?
All right. Well, The issue that's being changed by the amendment is at present time, certain retired individuals who have no reason to be accessing this database currently still have access to the database, and it makes it so that they would not have access to the database.
And if I may, there's people who retired, but there's also people who are working, clinical people who work in administrative positions that no longer work clinically, but have a clinical license. So therefore, it would apply to them as well. So anyone who doesn't have a reason to be into the program, therefore should not be in the program.
Any further discussion, questions? Representative Woods, is that yellow thing over your right shoulder your hand up, or is it a constellation?
Oh, those are all galaxies.
Galaxy, okay.
Just partly for my own edification, OLS, the office is OPLC, correct?
That is correct. Yes, the definitions are, except for the ones that are changed in the amendment, the definitions remain what they are under current existing law.
And what relationship do they have? Say, if they see something that's a little irregular, are they mandated someplace else to communicate with the Board of Medicine, the nursing board? What is that mandated? If there is something incorrect going on, where does it fall?
That I would have to look into because it's not being changed by this bill as proposed.
Yeah, okay, I wanted to clarify myself.
It's right off the top of my head.
Anyone else? And we have Amendment 1253H to Senate Bill 45, moved by Representative Marsh, seconded by Representative Merchant. When the clerk is ready, please call the roll.
Thank you. Representative Marsh.
Votes yes.
Representative McMahon.
Yes.
Representative Nelson.
Yes.
Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey.
Yes.
Representative King.
Yes.
Representative Kofalt.
Yes.
Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Knirk.
Yes.
Representative Soloway.
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Merchant.
Yes.
Representative Query.
Yes.
And Representative Pearson.
Yes.
And that's 21 in the affirmative.
Representative Marsh is called upon for a motion.
Mr. Chairman, I move that Senate Bill 45 ought to pass as amended.
Second that.
And that was sounded like Representative Merchant?
Yes.
Well, since this is exactly what we just did, I hope there'll be no discussion, but you never know. But I'll give you about 3 seconds. Would the clerk please call, would the clerk please call the roll on Senate Bill 45 as amended by 1253H, moved by Representative Marsh, seconded by Representative Merchant.
Thank you. Representative Marsh.
Votes yes.
Representative McMahon.
Yes.
Representative Nelson.
Yes.
Representative Acton. Representative Acton, we'll come back to you. Representative Gay. Oh, okay, thank you. Representative Gay.
Yes.
Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey.
Yes.
Representative King.
Yes.
Representative Kofalt.
Yes.
Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Knirk.
Yes.
Representative Soloway.
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Merchant,
Yes.
Representative Query,
Yes.
and Representative Peterson.
Yes, and without objection to consent, and would you like the word?
Yes.
Thank you. What we have done today, let's just take a look at that. I know there are at least one amendment coming on 149. The bill we did in the afternoon, we want to think on. So that only leaves the question of Senate Bill 74. What is the committee's pleasure? Is anyone likely to come forth with an amendment on 74, the advanced directives?
I would come up with one, even just an extremely simple one.
Representative Gay would like to come up with an amendment, so we will wait on this 2 weeks as well. Actually, that a minute ago just closed the exec session on Senate Bill 45, thank you. And with no other business before us, we will meet 2 weeks from today at 9 o'clock. So this hearing of the session of the House Human Services and Elderly Affairs Committee is concluded.
Bye, everybody. Good to
Thank
see
you,
you
Mr.
all.
Chairman.
Bye, everyone.
Bye, everyone.
Have a good week.
Bye, everyone.
All too.